Hello. Good morning. Hello. Good morning to all of you. May I request everyone to take seats, please? We are going to start the session. Please request all the delegates who are still outside the hall, they should come and occupy their seats. I welcome you again here on the second day of Big Update CANCON. I hope you all had a good academic discussion yesterday, and all of us have gained something or the other through our sessions, which were live as well as which were delivered in this hall. Some of the sessions were truly remarkable if you have attended them. Today we have planned many panel discussions and some didactic lectures. We will be starting with the most interesting session, I believe, because these are the common situations we face in day-to-day practice. Patient coming with generalized and particularly abdominal lymphadenopathy, and you don't know what is the cause. Then another patient who has come with secondaries in liver, but you do not have a clue where is the primary. And third, a patient who has come with ascites, and you have found malignant cells. Again, you do not know what is the origin. So this session actually will be handled by three stalwarts, and I'm sure you will enjoy this. So again, welcoming all of you to day 2. I have requested all the speakers to limit their talks by 3 to 5 minutes, to reduce their talks by 3 to 5 minutes with the experience we had yesterday, because it's very important to have discussion. I mean, if you speak out a very nice lecture and there are no questions, even the speaker is not happy. We always wish that there is a good interaction with the audience and with the chair. So with that in mind, I have requested all the speakers to reduce their presentation by at least 3 minutes so that we can have that discussion. And without wasting further time, I hand it over to the Master of Ceremony to proceed with today's proceedings. Thank you.
Thank you, sir. Good morning, everyone, and welcome for the second innings of the conference. We start with a symposium on challenges in clinical practice, and I would like the chairpersons to join us on the dais. Dr. Vijan Rai, Head and Department of Gastroenterology, GMC Bhopal. I request you to come on the stage. Dr. Krishnanand, Head and Department of Surgery, Allen Medical College and JK Hospital, Bhopal. And Dr. Manisha Srivastava, ma'am, Consultant Gynecologist at Gastrocare in Bhopal. And I would like my esteemed speaker, Dr. Ajay Jain, sir, to kick off the morning session.
I'll invite Dr. Ajay Jain. He doesn't need any introduction, Head of Choitram Hospitals in Indore. To begin with very interesting topic today, which is the first topic of today's lecture.
Laptop, please. Okay. Good morning, and I bring you greetings from the cleanest hospital of cleanest city to the cleanest capital of country. Once again, thank you so much, Dr. Sanjay and Team Gastrocare, for having me here. So in next 12 minutes, what I will be discussing is how to approach an abdominal lymphadenopathy. Next slide, please. So you all know lymphadenopathy is a benign or a malignant enlargement of lymph nodes situated in the abdomen. And the Other etiologies other than malignancies and infection can be autoimmune disorders, medications, iatrogenic causes. And except abdomen and chest, most of the lymphadenopathy can be diagnosed simply on a history and clinical examination. Next slide, please. So what is so special about abdominal lymphadenopathy? Because these lymph nodes cannot be palpated. They just are incidentally detected on an imaging, and most of the time they can be diagnosed on an ultrasound, but sometimes you require CT, MRI or PET to diagnose them. And they usually indicate some of the chronic problems like infections like tuberculosis, cancers, lymphomas, and some of the autoimmune diseases like Crohn's disease. So how do we approach them? And the first and foremost thing about approaching them is to understand which group of these lymph nodes are. So these are the group of lymph nodes which you can see in the abdomen, starting from retrocrural, retroperitoneal, gastrohepatic, portahepatic, celiac, along superior mesenteric artery, pancreatoduodenal, perisplenic, mesenteric, and lastly pelvic lymph nodes. So these lymph nodes are significant or insignificant is decided by the size and shape. So if it is a retrocrural lymph node, if it is more than 6 millimeter in short axis, it is significant. While if a pelvic node, it is more than 15 millimeter, then it is significant. And again, you have to decide whether it is a generalized or a localized lymphadenopathy. So this is what is a mesenteric. This is most often we see in our day-to-day practice, that we go for any cause, USG abdomen, for a pain in abdomen, for an abdominal discomfort, and sonologists report mesenteric adenitis or lymph node along the mesentery. So most of these lymph nodes are less than 5 millimeter. When they are greater than 5 millimeter in short axis, we call them significant. And being an incidental finding, patients most often become curious about these lymph nodes. So normal sized lymph nodes are routinely, these are routine lymph nodes. If they are less than 5 millimeter, they should be ignored. They are usually seen in children, especially after an episode of fever or an episode of pain in abdomen. A recent study showed that a threshold of more than 5 millimeter with an enlarged mesenteric lymph node are leading to a high positive rate of 54%. And therefore in children they have come out that unless they are more than 8 millimeter, they should not be called a significant mesenteric lymph node. So in children, more than 8 millimeter is significant, while in adult it is more than 5 millimeter, then it is significant. Therefore, sonographic detection of a lymph node should also include this shape, oval, elongated, and if they are more than 8 millimeter, then only they should be cut. And they should be considered a normal finding unless you have other things to diagnose. However, it is not only the size, there are other things. So the number, the distribution, they are also important. And the causes for these important etiologies leading to mesenteric lymph nodes are enumerated here. And most important are hematologic, metastatic, and some of these immunological diseases. Infectious diseases included viral, tuberculosis, parasitic, and some of these lipid storage diseases in children can lead to these mesenteric lymphadenitis. So what are the symptoms of abdominal lymphadenopathy? Most common about are tenderness or pain, most often in the right lower quadrant, fever, a feeling of illness, loss of appetite, fatigue, lack of energy. So all the symptoms of abdominal lymphadenopathy are very vague. So one and the most important thing about any lymph node is whether they are malignant or not. So you have to look at the patient and you have to see whether this patient is in high risk case for a malignant lymph node. And the risk factors for malignant lymph node, if patient is more than 40 years of age, there is a generalized lymphadenopathy. Lymphadenopathy is persisting despite treatment after 6 weeks. Male sex, node not regressing after the treatment for about 8 to 12 weeks. If the node are associated with supraclavicular lymph node, and if patient has significant systemic signs. So conventional and abdominal ultrasound remains the first investigation. CT is the primary modality to confirm these abdominal lymphadenopathy. An optimal technique for CT is a contrast enhanced CT to diagnose and to define these lymph nodes. Some of these malignant, some of these benign lymph nodes can sometimes appear like malignant lymphadenopathy, and knowledge of the various nodal chains is very important to decide whether it is a benign or a malignant or other causes. So these are the features which you can differentiate. So all the imaging technology, if you put together ultrasound, CT, MR, PET, the sensitivity and specificity ranges from 50 to 90% depending on the operator and depending on the technique. But there is no imaging modality which can accurately diagnose just on one basis that this patient has this disease leading to these income. So how to suspect benign versus malignant? These are the features. The best feature is if lymph node has a preserved hilum, unless proved otherwise, it is going to be benign. And if the lymph node hilum is lost, unless proved otherwise, it is malignant. Secondly, the diameter. If the long axis to short axis ratio is more than 2, it is likely to be benign. If the the ratio is less than 2, it is likely to be malignant. Recently, those contrast-enhanced ultrasound has taken over, and they are the technique by which you can evaluate the tissue perfusion of these lymph nodes. And if you have a vascular tumor, vascular lymph node, chances are that this is going to be a malignant. Higher sensitivity in identifying the minor regions of hypovascularity or hypervascularity, and Doppler techniques have led to the characterization of these lymph nodes. Compared with other imaging modalities, grayscale US combined with contrast-enhanced ultrasound is capable of evaluating shape, margins, internal structure, and vascularization of lymph node, which will differentiate between malignant and benign. And it has improved the accuracy of ultrasonography for the diagnosis of lymph nodes as compared to the conventional ultrasound. Another important technique which has been added in ultrasound is elastography, by which you can look at the stiffness of the lymph node. More the stiffer lymph node, chances of it being malignant are more as compared to the softer lymph node, which are less likely to be malignant. The MDCT has a great role in characterization of lymph nodes. They differentiate between normal and pathologic lymph nodes, and the criteria are again morphology, distribution, and enhancement pattern. It is recommended whenever possible, MDCT examination should be performed prior to any nodal biopsy procedure in these patients who have incidentally detected lymph nodes. The workup to confirm the diagnosis is biopsy, and these biopsies can be fine needle aspiration, core needle biopsy, or EUS guided or ultrasound guided biopsies, are then lastly the open excision biopsy. Here comes the role of endoscopic ultrasound. It is the most important tool to evaluate the abdominal lymph node. Principle of the ultrasound is same. Resolution of lymph nodes are better in endoscopic ultrasound as compared to CT. To identify which suspicious lymph node should be accessed for the biopsy is better evaluated on an endoscopic ultrasound, and endoscopic ultrasound guided tissue acquisition has been increasingly used to diagnose these lymphadenopathies, and these characterize the patient's subsequent management. So this is the picture of an endoscopic ultrasound showing a periportal lymph node, and the next video shows that the periportal lymph node biopsy, same time you can do a lymph node aspiration as well as biopsy. Fine needle biopsy has undergone an impressive development with quick and reliable histopathological diagnosis. You have all seen yesterday how an aspiration was done and a diagnosis was made in the next few minutes. Therapies are currently available, so tissue acquisition of malignant lymph node is a mandatory thing to identify the tumor biology, and fine needle aspiration and biopsy needle are able to guarantee accurate results and with perfect specificity and suboptimal sensitivity. Criteria based on B mode evaluation and Doppler features fail to adequately characterize the high specificity of lymph node nature. So nowadays, use of EUS image enhancement technique like Doppler, real-time elastography, and contrast-enhanced elastography has improved the diagnostic value of endoscopic ultrasound in the evaluation of these lymphadenopathies. And these are the criteria to differentiate between benign and malignant. If on a EUS, and if the lymph node is oval, chances are benign, round is malignant, irregular shape is benign, clear-cut asymmetric is malignant, ecostructure is heterogeneous, benign, homogeneous is malignant. So by these features, and obviously by Doppler and subcapsular vessels, whether they are present or absent, you can differentiate between benign and malignant. This is just to reiterate that some of the drugs can also lead to the lymphadenopathy, and we should not unnecessarily investigate these patients if these patients are taking these drugs for a long time. So ladies and gentlemen, I would like to summarize that lymph node characterization represent a crucial point for the diagnosis of patients coming with abdominal lymphadenopathy. With the addition of new technologies like contrast-enhanced ultrasound, elastography, in transabdominal ultrasound is the first investigation to be confirmed further by contrast-enhanced CT. EUS not only helps in the better characterization of lymph nodes, but also helps in tissue acquisition, which is a paramount thing for the proper management. In this era of availability of high-end USG, MDCT, and endoscopic ultrasound, empirical treatment of abdominal lymph nodes with ATT, corticosteroid, or any other drug should not be done. Thank you very much for your patient hearing. I hope, Sanjay, I have finished in time.
Thank you so much, sir. We request you to be on the dais only because we'll be having the discussions after the 3 talks. I request Krishnanand sir to call up the next.
Good morning. Now I call Dr. Yogesh Chawla, sir. He is Chairman Academics and Professor Emeritus, Kalinga Institute of Medical Sciences, Bhubaneswar, for his talk. Welcome, sir.
Thank you very much, Sanjay, and your team for calling me over for this meeting. Coming to MP is always a homecoming for me, since I left this state way back in 1980 to pursue my career from Jabalpur. Anyway, so he's given me a very interesting talk, and that is on liver metastasis with occult primary. So liver is the most common cause for metastasis after the lymph nodes. And various studies have shown that you can identify the primary in about 27% of cases in one series, 73% in another autopsy series, and yet another series about 74%, with colon being the commonest in some, lung, pancreas, breast, etc. So there would still be a group. What I'm going to talk to about is the group in which you have not been able to find out the primary. And this is, in short, known as carcinoma of unknown primary. This is a heterogeneous group of liver metastases where no primary site is identified despite a thorough clinical, radiographic, and endoscopic evaluation. The common origin for this occult primary is usually from the lungs, which remains undetected, kidneys, pancreas, colon, and breast. And the primary in such situations is microscopic in size, and for some reason, either because of the environment or the absence of neogenesis, the size does not increase and it doesn't show a malignant transformation. So isolated liver metastasis is seen in about 38% of cases, but usually in 62% you may find sites which are very small and undetected. What's happened? So these metastases in the liver could be solitary, they could be multiple. Very often they are aggressive, and when you do a histology of them, most of these have adenocarcinoma in about 58 to 79%. Some of them are poorly differentiated or undifferentiated carcinomas. Some turn out to be neuroendocrine tumors and some squamous cell carcinomas in decreasing order. The survival after liver metastasis with primary being unknown is about 3 to 9 months, mainly seen in males, and the age of diagnosis is usually 61 to 65 years. But it's absolutely important to differentiate these cases from primary hepatocellular carcinoma because the prognosis is different and the management is also different. So how do you approach to such a patient with an unknown primary? Patient history is absolutely important, and you have to ask questions specific to the signs and symptoms of different organs of the body. Any prior intervention has been done, past medical or family history, and do a good thorough examination of the thyroid, breast, pelvis, prostate, and PR in both the sexes. Blood samples which would help you would be raised LDH, which usually is seen in malignancies, more often with hematopoietic malignancies, prostate-specific antigen, HCG, and alpha-fetoprotein. We also do CEA and CA125, but they lack specificity. Fecal occult blood needs to be done, urine analysis needs to be done, X-ray chest and CT chest, abdomen and pelvis, mammography, and even MR enteroclysis may have to be done in these patients to come to a conclusion of where the primary has appeared. Endoscopy may help in some cases, but you would necessarily do it. And colonoscopy also is indicated, especially if the metastases are isolated and they are amenable to resection. If there are bone lesions, one would suspect in elderly males, probably coming from the prostate. PSA needs to be done, testicular ultrasound needs to be done, germ cell tumor markers, mammography, apart from the other common usual malignancies that we see. The CT abdomen and pelvis that is done should have thin slices with IV and oral contrast, and these slices should be 4 to 7 millimeters, which usually is done with the multi-detector CT now in usual clinical practice. Some have also advocated whole body MRI because it doesn't give you an exposure to radiation, but it is expensive and it's better in revealing bone metastasis to the spine, pelvis and femur, and you may have to resort to bone scintigraphy. So you see, you have to undergo so many tests to pick up a primary in such situations. Something which has become very popular is the FDG PET, but this has limited value in squamous cell carcinoma. It's important in neuroendocrine tumors when you will have to do a DOTA PET or somatostatin receptor scintigraphy. It has some disadvantages because it can pick up inflammatory lesions also and give you a false positive result. That is why the true positive is about 76%, false positive is 7%, true negative is 6%, and false negative is 9%. So usually the primary tumor sites in this particular study showed from GI and the lungs. But what is most important is doing an FNA of the lesion, either ultrasound guided, CT or EUS guided, and you can do a core biopsy with TrueCut or a FNAC with a needle. Usually you should have a 90% adequate tissue sampling, and this would all depend on the lesion site, depth, location, proximity to the vital structures, etc. And it has been shown, we always felt that fine needle aspiration is less sensitive to biopsy, but this particular study has shown that FNA sample was 2 to 24% more sensitive than the needle core biopsy. So you do a usual H&E staining, do some specific immunohistochemical stains for tumor linkage, and exclude tumors of non-epithelial origin which can be managed separately. And now people are doing gene expression and molecular profiling and gene microarray with target killing. So if you get a squamous cell carcinoma, think on histology, think of pulmonary, esophageal, head and neck, genital, anorectal, and immunohistochemical is of not much use. So do a meticulous examination of head and neck and all these organs which I have just mentioned, which would help you to come to a conclusion for the primary malignancy. If there is a neuroendocrine tumor, you need to do histochemical stains also for synaptophysin and chromogranin. But if adenocarcinomas are detected, which is most common, you should do a CK7 or CK20 immunostaining, because that would tell you whether the lesion is coming from the upper GI or the lower GI tract, cholangiocarcinoma, pancreas, lungs, ovaries and breast, or urothelial carcinoma. And you may have to do additional markers like CK17 for ampullary and pancreatic tumors, TTF1 for non-mucinous pulmonary adenocarcinoma, estrogen receptors, and always differentiate HCC from cholangiocarcinoma with Hep-PAR immunostaining. So, as I said, there's a huge list of investigations that you need to do. It's very time-consuming, expensive, and exhausting if you cannot get a clinical clue. But one has to identify the favorable subgroups. If it is adenocarcinoma and it's a female with peritoneal metastasis, one may have a good response. Women with axillary lymph node metastasis, men with elevated PSA, and metastasis with a single peripheral lymph node. These are the group of patients which have been studied and who are treatable. Squamous cell carcinoma, cervical lymph node if it is there, and inguinal lymph nodes for anorectal and pelvis primaries. And if it is poorly differentiated, young men with mediastinal or retroperitoneal lymph nodes, or NET. Prognosis is usually poor, especially if there is hypoalbuminemia, lymphopenia, if there is increased LDH, which is a measure of tissue damage, comorbidities, adrenal involvement, and poor performance status. And overall, these types of patients have an aggressive approach, except if they have neuroendocrine tumor on histology. So what is the hypothesis? Why is there no primary seen in a significant number of patients? It is, the primary is of small size, it lacks sufficient angiogenesis, and some of the cells migrate to distant organs, and liver could be one of them, which forms a new environment, and the angiogenic support is there. Why these patients are usually have an aggressive disease is possibly due to chromosomal instability. But it's usually important to have a primary site important, because if you can treat the primary site which you identify on histology, you may have a better prognosis. But studies have shown that traditionally, if you're not able to come to a conclusion, when you give targeted, non-targeted cytotoxic chemotherapy based on platinum, which is usually given, the response is very poor. And now you have molecular characterization, which is being now done in some centers in the country. People have used CT-guided interstitial brachytherapy. Some emerging role of immunotherapy has also been studied, and nanoparticle delivery of microRNA for colorectal carcinoma and liver metastasis has been shown. So this is a field which is now becoming more and more interesting for the oncologists, and occasionally the search is futile, expensive and time consuming. Gene sequencing has improved survival. It is important to determine the site of origin, and there is a game-changing concept. So in conclusion, I would say that identifying the primary in about 1/4 of the cases is a major therapeutic challenge. However, because it involves extensive exploration and has an aggressive course, it has a poor response to chemotherapy. You have to undergo a lot of invasive tests to bring about, and it's a burden on the patients. But with the availability of molecular profiling, targeted chemotherapy can improve the prognosis of such patients. Thank you all for your patient hearing.
Thank you, sir, for your informative talk. Now we call upon Dr. C.C. Chaubal, sir. Everybody from Bhopal and all over India are knowing sir very well. Sir is an ex-professor of medicine at PCMS Bhopal and is senior consultant, gastroenterologist and therapeutic endoscopist of Bhopal. So we welcome you, sir, for your talk.
Thank you, Dr. Krishnan, and good morning, everybody. May I have my presentation on this? This is another talk in this particular series. I've been assigned the task to talk about malignant ascites of occult primary, the evaluation and management. So coming to this, malignant ascites, as we all know, is a manifestation of an end-stage events in a variety of cancers and is associated with significant morbidity and early mortality. Its onset and progression is associated with deterioration in the quality of life and a poor prognosis. Traditionally, all these have been regarded as an end-stage disease which was only amenable to palliation till now and systemic chemotherapy. The things are now changing as far as management is concerned. There has been a nihilistic attitude towards this condition. This is probably the second most common cause of death after hepatic metastasis, as Dr. Chawla has just said, that it is prone to frequent hospitalizations because of recurrent obstruction in intra-abdominal infections, and probably it is virtually incurable. The things are now probably changing with some newer modalities of management. Average life expectancy was 6 months after development of malignant ascites. Now with best systemic chemotherapy, the median overall survival has gone up to 20 months and median disease-free survival around 10 months. There has been a poor literature on the effective treatments. This is very important because these patients have often been excluded from clinical trials because they have probably a non-measurable disease. Large number of malignancies have been known to produce malignant ascites, almost all of the malignancies. But if you look at an overall situation, there are certain ones which are very common. The gynecologic malignancies, the GI malignancies, the breast cancer, and these are the three most important ones which produce ascites. And then you have a number of situations where you have malignant ascites developing secondary to cancers or unknown primaries. It is important to know a little about the pathophysiology. It's not that just peritoneal metastasis develops, you have the exudation of fluid in the peritoneal cavity, blockage of lymphatics, giving rise to ascites. There are a number of factors which can play a role in genesis of these ascites. This information is important for us to understand. Is important because there are a number of new targeted therapies which are targeted towards different mechanisms of formation of ascites. I think this is better. I think this is better because I can't see anything here. So that is there. The liver metastasis is another one, the portal vein obstruction, cirrhosis with secondary malignancies. Of course, genesis is different. Number of local and systemic inflammations can result in exudation of fluids. Many patients may develop heart failure, and pancreatitis may also be contributing to this ascites. What's happening here? Now it is important to know that there are certain compounds which have now been found to have, there are certain components like tumours have been found to produce what is known as vascular endothelial growth factor, which results in more angiogenesis, increase in permeability. So you have now targets against this particular mechanism also. You have metallic, so-called MMX of the metalloproteinase, which is produced by many of these tumor cells, which results in breakdown of the matrix and can result in further dissemination of tumor cells. So all these mechanisms are important subsequently to identify various targets of treatment. So if you look at the overall situation, peritoneal carcinomatosis is responsible for 53% of the cases. Massive liver mets producing portal hypertension 13%, hepatocellular carcinoma plus cirrhosis 13%, and there are so many others also. So different mechanisms work in different situations. So in patients with malignant related ascites, almost 2/3 have peritoneal carcinomatosis, while 1/3 of the non-malignant causes are there, so secondary to portal hypertension, or lymphatic obstruction. Like if you have cirrhosis, if you already have a liver with extensive metastasis, the ascites which develops behaves exactly like that of portal hypertension. And lymphatic obstruction can produce what is known as scalous ascites because of obstruction of lymphatics in peritoneal cavity. So how do you evaluate? You have to find out whether the ascites is malignant or non-malignant, and if malignant, what is the primary. If you look at this, starting off with patient with ascites suspected or established malignancy, you have to do certain important things. The diagnostic paracentesis is one of the most important things. Get a serum albumin. Abdominal imaging like CT scan and MRIs, ultrasound examination are all very important. By and large, patients who have carcinomatosis or peritoneal carcinomatosis have an ascites which is a low-grade ascites, less than 1.1. That means serum ascites albumin difference is less than 1.1. In those situations where portal hypertension is contributing to development of the ascites, like liver with extensive metastasis, this gradient is high, behaves just like cirrhotic ascites. It is important to know this situation because the patients who are given diuretics probably in malignant ascites, those who have a low-grade ascites, they respond very poorly to diuretics compared to the others where diuretics may be useful. So looking at this, the overall simple evaluation of the ascitic fluid that we do otherwise, the most important thing to be done is cytology. Overall sensitivity of this cytology is for detection of malignancies around 75%. It is very high in those situations where you have peritoneal carcinomatosis, but in those situations where you have liver mets with ascites formation, usually a cytology is universally negative. It also depends on the amount of fluid that you send for evaluation. Around 50 ml minimum is required for one specimen. And not only that, there is an incremental benefit if you send more and more samples. Like first sample specimen, 83% positive, with three samples, for example, almost 97% will be positive for peritoneal carcinomatosis. Now there are certain very unproven and unhelpful tests. You will remember that in clinical practice, most of the time we see for CA125 or CA, for example, in ascites. Sensitivity and the specificity of CA is very limited, and the precise value for ascitic fluid CA levels in diagnosis and differential diagnosis is very uncertain. Do not measure ascitic fluid CA levels. Similarly, CA125. Virtually all patients, including men with ascites or pleural fluid of any cause, have an elevated level of CA125. Similarly, the assays for ascitic fluid CA125 are not very helpful for differentiating between ascites, which is due to ovarian cancer, and the ascites that is due to tumors or benign causes. So do not test the patient with ascites for CA125 either in the serum or in the ascitic fluid. This is important for all the clinicians because in clinical practice most of the time this test is done. So there have been several humoral tests which are suggested for malignancy like fibronectin, glycosaminoglycan. They have all been proposed to replace the supplement cytology, but none have these tests have stood the test of time and they should not be done. There have been other tests also which can be done to differentiate malignant and non-malignant ascites, like salicylic acid levels, HCG beta levels, gastroenterological growth factor levels, telomerase activity, so on, but they are all experimental and none of them has gone from bench to bedside. Laparoscopy is one of the most important. With biopsy of the peritoneal implant, it has sensitivity of detecting this carcinomatosis in almost 100% of the cases. It is specifically required for the diagnosis of peritoneal mesothelioma, where ascitic fluid cytology many times is misleading. Similarly, a mental biopsy, which can be CT guided or CT or ultrasound guided, can be done to detect malignancies. In spite of all the investigations, almost 20% of patients have so-called tumors of unknown primary origin. They have ascites of unknown origin, with where the primary is not known. Now, advances in imaging and immunocytochemical analysis will continue to influence a decline in the number of cases of malignant ascites associated with carcinoma of unknown primary. That means advanced imaging and immunocytochemistry or immunohistochemical studies are playing a major role. Laparoscopy with a biopsy is a safe and a minimally invasive technique and helps to establish primary tumor diagnosis. It is particularly in the females with the poor performance status who have with a good performance status who have no apparent cause for ascites. I will not go into the details. Initial diagnostic evaluation of patient with CUPS is just like what Dr. Chawla has just mentioned, a complete history and physical examination. Various imaging studies are done in these situations. One should try to obtain a biopsy and a generous biopsy, if possible, when you are doing a laparoscopy, because you need to do not only histology, but various immunohistochemical stains, various molecular studies, etc. are required in these situations. After doing ICs and ICCs, there is something called now molecular cancer classifier assays, which can be done on very small biopsies, experience cytology, etc., and which can certainly give you a very good idea regarding it. So I think now, as far as cancer of unknown primary is concerned, availability of so many molecular assays and so many advanced technologies have resulted in gross reduction in a number of those particular cases. So you can diagnose most of them. If you look at the molecular cancer classifier assays, there are several which are available. I don't know how many are available in India, but at least 3 of them are available in America, where they do certain genetic tests, RT-PCR, and can detect almost 15, 50, or sometimes 49 cancers very easily by doing these particular tests. So especially in those situations where IC or ICC has not been able to achieve that, these molecular genetic classifier assays can be performed. Now, depending on IC patterns, characteristic single cancer tissue, you can identify various kinds of malignancies. I will not go into the details. Like you have different molecular signatures for different types of malignancies. So if they are there, you can direct your evaluation to that particular organ. This is an interesting study which was performed and suggested by some Koreans, I think. It was probably from Korea. This was a diagnostic algorithm detecting primary tumor sites using peritoneal fluid. This was conducted to develop a novel algorithm for determining origin of tumor by combining analysis of cluster patterns with immunocytochemistry. And the cluster patterns means if you do, for example, this is done basically by using what is known as liquid-based cytologies. You do a molecular analysis and you do immunocytohistochemistry in this cytochemistry in these particular situations. What are you going to do then? The morphology of different malignant cells is well written in this particular situation if you do a liquid biopsies. There are no artifacts in that particular situation, no debris seen in that, and this thing. And many of these malignancies, different malignancies, form different kinds of 3-dimensional clusters in the ascitic fluid. Evaluation and assessment of these clusters is very important. You can detect, oh, you can suspect, well, this particular cluster suggests gastric carcinoma, this suggests ovarian carcinoma, like that. You can see here, like stomach and all these things, you have no clusters in gastric carcinomas. Lungs, you have predominantly very small size clusters, pancreas, small size clusters, and so on. Similarly, you have different kinds of other conditions also, like ovary and colon, all these things. And this is how they look like. You can see here the stomach, hardly any clusters are there. A side, B side is the lung, C, you can see here, the pancreatobiliary tract, E is the breast, and F and this thing is colon cancer, and E is ovarian cancer. So these are different kinds of clusters that you see. So for an experienced person doing a cytology like this, he can easily say that probably I feel that it is coming from this particular site. Similarly, you can do certain staining for certain markers, like you have cytokeratin 7 or paired box gene, for example, 8. You have different types of stains for this. They may be positive or negative in different kinds of malignancies. So based on this, they have suggested a kind of an algorithm. This is very interesting. You have atypical still seen on this thing. You do a CK7 staining. If it is negative, look for the 3D cluster. If there is nothing is there, this thing, it is negative malignancy. If it is yes, it may be colon or unusual metastatic tumor. If it's a CK7 is positive, look at the 3D cluster. If there is no 3D cluster, probably it's from stomach. If there is a 3D cluster and PSK, the paired box gene 8 is positive, it may be from ovary. If it is negative, it may be pancreatobiliary, stomach and breast and all these things. So that is the situation. So that is how the things. If battery is running low, I don't know what is this. This is not coming further. Yes, battery is running low. So depending on these markers, etc., you can use different types of modalities for evaluation also. Like previously we used to do blind gastroscopies, colonoscopies, bronchoscopies to detect primaries, but these days it is no longer recommended. You have certain clear-cut molecular signatures there, and you can direct your investigations according to that. So this is how it is. So coming to the prognosis, presence of ascites has strong negative prognostic import. It is different for different malignancies. One retrospective study reviewed experience with the malignant ascites over 10 years. What they have found is the GI malignancies were associated with the poorest prognosis. For gastric carcinoma, 1.5 months, pancreatic 1.4 months, and colonic cancer, it is 3.7 months. The best is probably for a properly treated ovarian cancer. There have been various prognostic factors which are for the non-ovarian cancer groups, which are a poor prognostic factor. The low serum albumin, presence of liver metastasis, and markedly elevated serum bilirubin. Coming to treatment, I will not go into the details. Majority of the treatments that we manage actually of malignant ascites is by repeat paracentesis and diuretics. Diuretics, as I already said, work better in those situations where you have a high gradient ascites, but do not work well in low gradient. So overall efficacy of diuretics is hardly 45% compared to almost 85% of cirrhotic ascites. To obviate the necessity of repeated paracentesis, peritoneal venous shunting has been recommended. It also has several problems. Some people do it, and most of the places it has been given up. Then you have something which has been done by Japanese, the so-called CART, that means cell-free concentrated ascites reinfusion therapy, which is being practiced at several places. What has really made a difference is the presence of intraperitoneal chemotherapy, where a high cytotoxic concentration of active agent is, where it is infused in the peritoneal cavity, it remains in a high concentration in the abdominal cavity with minimal systemic absorption and systemic toxicity. Clinical trials have shown that patients of ovarian cancer have shown intraperitoneal therapy to be superior to the systemic chemotherapy compared looking at the progressions of survival or the median overall survival. The studies have also shown that the combination of a systemic and an intraperitoneal chemotherapy was more effective than the exclusively intravenous treatment. Now, what has really made a difference, I think, is this cytoreductive surgery plus HIPEC or the hyperthermic intraperitoneal chemotherapy. This is a new standard for treating peritoneal surface malignancy. I'll just mention out the principles, that's all. What is done in this is cytoreductive surgery means you have to resect all the visible or the macroscopic disease which is more than 1 millimeter in size. And subsequently, the chemotherapy has an ambition to treat the remaining non-viable or the microscopic disease. That means you do a surgery, followed by that you infuse a particular drug, chemotherapy solution, which is heated between 141 to 43 degrees centigrade. Infusion is done for about 30, 90 or 120 minutes, and it keeps circulating in the peritoneal cavity. The results have been found to be very good. This concept, this therapy was done for pseudomyxoma peritoni way back in 1980 for the first time. Sugar Baker has done a lot of work on this particular thing. What he has mentioned is peritoneal metastasis should not be considered as a generalized disease. Involvement of peritoneal surfaces may occur in the absence of hematogenous metastasis or may represent the dominant clinical picture. This peritoneal metastasis should be considered as a locorenal disease. That is why you have to do a cytoreductive surgery in these situations. Treatment of macro, you do a cytoreductive surgery. Peritonectomy procedures are performed in these situations, and for microscopic disease, you give a heated intraperitoneal chemotherapy. You may treat a system by giving a systemic chemotherapy also in these particular situations. So this is a kind of a roller pump that you use for this thing. There are different methods, the open method, the closed method. You can do it during the surgery, immediately after surgery, or after 3 to 4 days after the surgery. Heat, what is the importance of heat? Heat synergizes the effect of chemotherapy. It helps in the penetration of this drug in the cells. It reaches a high concentration in the peritoneal cavity, it remains there for a long time. Several drugs have been mentioned in this. I will not go into detail, but gemcitabine, carboplatin, mitomycin C, and so many of them in different combinations or alone have been used. Best conditions to be treated are pseudomyxoma peritoni, peritoneal mesothelioma, primarily from the colorectal, small bowel adenocarcinomas, like that. Should not be done for ascites developing pancreatic malignancy, bile duct gallbladder. Can be done for ovarian cancer or gastric cancer. So that is what is mentioned here. I will not go into details here. So in summary, malignant ascites, though represents a small proportion of ascites, have poor prognostic implications. Many options are employed, but no randomized control study to compare the effectiveness. Abdominal centesis and diuretics will remain the mainstay, as happens everywhere. That is what we do. Cytoreductive surgery with HIPEC is a promising treatment for certain cancers. There are several novel approaches that may be considered experimental, like using certain VGF antagonists are there. You do certain immunomodulators that you instill in the peritoneal cavity, and there are so many other drugs also which have been tried, but they are all experimental. Thanks.
Thank you so much, sir. I request Dr. Amit Jain and Dr. Kaushal to please come on the dais. Any questions from the audience?
May I ask a question? Dr. Ajay, this is particularly pertaining to children, where we find lymphadenopathy on ultrasound very often. And mostly clinician is in a fix whether to investigate further. You have mentioned that nowadays consensus is that you investigate any node more than 8 mm. But I feel that more than the size, I think the other details, ecogenicity, the preservation of hilum, and those things are more important. And because in children, whoever comes to an adult gastroenterologist for an opinion, I think more than 60–70% have this problem. So do you really rely on the size or the other details of the lymph node?
No.
And it's secondly, it's very difficult to investigate them further. Either you have to do a FNA, which is not easy in children. And how do you handle this?
So the two most important thing in the children, one is the history. Most of these children, if you take a careful history, they usually come after an episode of fever in last 8 to 10 days or 15 days. So these are the reactive lymphadenitis in these patients. Secondly, the ultrasound feature, not only the size, I said the hilum, the diameter, the short axis and long axis diameter, the other important things. So the ultrasonologist, most of the time, who are very good and they pick up and they always write in their impression. So these are the two things. And the third thing is that
Dr. Ajay Jain sir. So one patient is there, 17-year female. In 2022, she was diagnosed, she presented to a physician with abdominal pain. CT was done and there was multiple mesenteric lymph nodes and one peripheral node was there. And the FNAC revealed tuberculosis. She was given 6 months ATT. There was a partial resolution on CT scan of the lymph nodes. But sir, because there was partial resolution, the physician increased the dose for next 3 months also. After that, the patient was symptomatically fine, sir. Now in 2024, again she presented with abdominal pain. Again the CT scan revealed lymph nodes, multiple lymph nodes in mesenteric. Again seen by physician, again started ATT. There was no follow-up scan after 9 months of that thing, ATT. Now again she took ATT for 3 months. After that the CT was done, sir. Now CT reveals there is a calcification, most of the lymph nodes, but size has not decreased. Patient still has abdominal pain and inability to gain weight. So how to proceed in this patient?
first of all, because this patient has a calcification in the lymph node following a anti-tubercular treatment. So I'll believe that this patient has been adequately treated, and the lymph node, in these lymph node, the tuberculosis is not the cause of pain in this particular patient. Now you have to further investigate it for other causes of pain in abdomen. Because what happens is that whenever we get an investigation which gives some positive finding, we tend to go to that side that probably this is the cause of the pain. So an adequate treatment with anti-tubercular treatment, good response, calcification, I think we have to look for the other cause of pain in abdomen. Secondly, when these mesenteric lymph nodes are enlarged, some of this pain may be because of the stretching on the mesentery, and intermittent pain, especially after the meals, could be because of mesenteric adenitis. Panniculitis is another important cause in these patients, which one has to look after in these patients other than tuberculosis for the cause of pain. Obviously, you have to investigate this patient other than tuberculosis for cause of for pain in abdomen.
So pain is very mild. The only concern is size is still not reduced, sir, and it has not reduced yet. So what should we do for that? Because even 2 years back, the problem was same.
I think size alone should not be the guiding principle in this particular patient. If you are very concerned, then probably an excision biopsy should be able to tell you. But my gut feeling is that you ignore the size at this point of time because calcification has happened, and look for the other cause of the pain in abdomen in this patient.
One comment I would like to make, in children we should also see for fecal loaded colon, because that is one of the causes of pain in abdomen, and we keep on treating this lymph node as a cause of pain. So it is important that we keep this in mind. And I find many patients now coming with acute abdomen and being treated, investigated, and the CT only reveals presence of fecal loaded colon, which is because of the lifestyle, whatever children are following. What do you say?
One has to have a very low threshold for getting a CT in children for a pain in abdomen.
Children, but one of the causes, if you have been investigated, then fecal loaded colon should always be kept.
Yes.
Secondly, sir, I'd like to ask Dr. Chawla, rather than going up for so many investigations, why not just going for PET CT as the first line of investigation?
Yes, as I said, firstly, PET would give you a positivity in about 75% from this study. And it is always good to follow a protocol. Have a CT scan, we would be more comfortable with that. And then go in for a PET scan. That should be the ultimate.
Because many lymphoreticular malignancies, lymphomas, etc. can be pointed
They
out.
can be picked up, I agree with you, but then it is not 100% sensitive. So doing a CT or an ultrasound in a proper way, or even an MRI, you would be able to do an FNAC of the lesion, if you find.
So all three lectures were very well, very good. Put your hand on your heart, sir, and for an individual patient, how much workup do you do? All three of you. You said about, A to Z.
So I'll start. If my patient is a child, he has come for the first time with pain in abdomen. These are mesenteric lymph node, and my sonologist says subcentimetric lymph node. I will not do anything. I'll just treat symptomatically, keep under observation, and patient is fine. I'll forget it. Huh? Secondly, if the patient is an elderly patient, there is a single lymph node, size is more than 1 centimeter, homogeneous, hilum is lost, probably I'll investigate further this patient. And first investigation will be a CT scan. Once the CT also suggests, then probably a tissue acquisition, FNAC or FNAB, and a histopathological diagnosis. So the things changes with the size, shape, structure, and symptoms, and obviously age also. A significant thing is weight loss. If there is a weight loss and the lymph node, I will definitely investigate further.
I think SP, in our situation, of course, the blood investigations are important. They do help you. A CT scan of the chest, abdomen, and pelvis would be helpful in such cases. And lastly, PET scan. But everybody agrees that it is an expensive proposition and it's a big burden to the patient. So if you can come to a conclusion before going to no, it's not necessary. If it turns out to be a neuroendocrine tumor or a slow-growing tumor, you're getting a lot of neuroendocrine tumors now. So every SOL in the liver is not always HCC or a metastasis. Think of neuroendocrine tumor also.
Even multiple metastasis in a liver metastasis in a patient is not a battle lost. You have neuroendocrines as well as CA colons, where there is 5-year survival.
Absolutely, I agree with you.
Yeah.
And people have tried even a liver transplantation for multiple metastases.
And liver resection is also done in CA.
Resection is also done.
Dr. Chaubal sir's comment.
See, 80% of the times, I think you are able to achieve a diagnosis because imaging, etc., will tell you the source of primary. You may already be treating a patient with that particular disease developing this. And your simple examination, cytology, and everything can be. It's only 20% of the cases where it really matters. But if you have done a laparoscopy and all these things, immunohistochemistry is now available in our city also. IHC, Stenting, etc., and cancer hospital, etc. is done. You can certainly get those markers studied if you require. Of course, liquid biopsy cytology is not done anywhere in Bhopal. I don't, because it's a bit difficult also, and immunocytochemistry requires more experience. This was just a small study which I quoted from, came from Korea. It interested me because it was done on a aspiration cytology done on an ascitic fluid. I mean, so most of the time they were taking tissues or this thing and doing an IC and all these markers on that. But here they have done it on the cells itself, or identifying the different types of clusters you see. So that was something unique for this thing. So 20% times it is there, and as far as management is concerned, I don't think in Bhopal surgeons are here. I think Krishnan is there, whether they are doing cytoreductive surgeries. Nobody is doing hyperthermic intraperitoneal chemotherapy so far in Bhopal. I have not heard about this. But this is certainly very useful. I think Dr. Manisha Shawaz is also there, I think, regarding ovarian malignancies and so many other things. It has almost doubled the survival. That is what Sugar Baker studies have shown, actually. So that is important.
Just few points to make. One, regarding the FNAC. As a oncologist, we prefer the core-needle biopsy because we can do ISC. So FNAC is something we are only doing when the biopsy is not possible or feasible. So that is one point to make. So
this is recommended now. As far as possible, try to take at least a core biopsy or this thing. That is important.
And second thing regarding sir, HIPEC is for therapeutic and CA ovary, even with ascites, it can be stage 1. So CA ovary stage 1 patient can have ascites. So that is treated totally differently. And number 2, you have mentioned the HIPEC. HIPEC is a therapeutic intervention, not for palliation. And it's not increasing the survival in all the cases. And like in ovary, the median survival gain is 5 months. And so for the intractable ascites, more useful is PIPEC, where they pressurize intraperitoneal chemotherapy with the same, almost the same way like the HIPEC with the catheter. So that is one thing is available in India itself for the intractable ascites.
So I've already mentioned that there are certain subsets of malignancies. Pseudomyxoperitoneum is one, appendiceal carcinoma another, where it works very well. Colorectal metastasis also they have done because it has been done in one of my colleagues who passed away recently in America. Colorectal secondary developed. He underwent cytoreductive surgery and this thing, but he could not survive. There are complications and of course.
For the FNACs, even the cytology, you can put that material into formalin, make a good cell block, and then you can do all IHCs and other things. So even that can help you in making a good diagnosis.
Thank you, sir, for this discussion.
Sir, this was all about clear ascites. How do we approach a patient of malignant ascites, negative for tuberculosis workup and autoimmune workup, but it is recurrent hemorrhagic ascites with features of weight loss, suspected malignancy, nothing found? Though very rare, but we see these patients commonly in gynec practice, refer practice. Recurrent malignant hemorrhagic ascites.
Pancreatic ascites, of course, and tuberculosis and malignancy, of course, these are some of 3 very important ones which give rise to this particular. You are talking about recurrent hemorrhagic ascites, this is something very extremely unusual and rare. I don't have any I have no idea regarding any studies which are conducted in this particular
young
subset.
patient, how do we approach?
That he has already mentioned, nothing was found.
That we've already done, we've taken biopsy.
She is
it's
herself a
negative
laparoscopic
for tuberculosis. Nothing, but it is recurrent hemorrhagic ascites. Recurrent hemorrhagic ascites, negative for autoimmune workup, I said that. Very rare.
Okay, thank you, sir. As we are short on time, we will have to move forward now. I request everybody to please limit the number of questions to 3 per session because we are at a tight schedule. Please, esteemed faculties, please come to the center of the stage for the photo. Meanwhile, for the next session, it is a panel discussion on CA colon. I'd like to invite the chairpersons for this session, Dr. S.K. Nigam, Senior Surgeon from Bhopal, and Dr. Ajay K. Nanwer, Associate Professor of Gastroenterology from GMC Bhopal. The panelists for this session are Dr. S.P. Mishra from Prayagraj, Dr. Sunil Kumar from Bhopal, Dr. Pavan K. Atala from Hyderabad, Dr. Kamlesh Talesra from Bhopal, and Dr. Atul Samaya from Bhopal. The moderator of this session will be Dr. Sanjay Kumar.
So, without further delay, our panelist is already on the dais. I request Dr. Sanjay Kumar to please start the panel discussion on the carcinoma colon. Please, sir.
Thank you, chairpersons. I have a very elite panel to discuss about carcinoma colon, which is perhaps the biggest problem, and if not, it is going to be one of the biggest problem as far as GI cancer is concerned. We have Dr. S.P. Mishra from Prayagraj, a senior gastroenterologist, Dr. Pavan Adala, who is a GI onco and liver transplant surgeon from Yashoda Hospital, Hyderabad. We have Dr. Sunil Kumar, our own medical oncologist from Bhopal, Dr. Atul Samaya, oncosurgeon from Bhopal, and Dr. Kamlesh Talesra, a senior radiologist from Bhopal. So I'll just briefly introduce the topic. I'll start with history of a couple of cases. This was an 80-year-old male who was diagnosed as cirrhosis in 2019 and was admitted to us with hepatic encephalopathy and dyselectrolytemia. So he was being managed as cirrhosis. In 2020, he had bleeding per rectum. And when we did a sigmoidoscopy, we found that he had CS sigmoid, biopsy-revealed adenocarcinoma. No treatment was undertaken after discussing with the patient because they felt that patient already had a morbid disease and they didn't want to pursue any treatment for cancer. In 2022, he did fairly well for next 2 years. And in 2022, he came with colonic obstruction and we placed a colonic stent for relieving the obstruction, and he again did fairly well. 2024, he has come again with some bowel symptoms, no real obstruction, and we have done a sigmoidoscopy. I'll show you that. He still maintains a good appetite. He has lost 2-3 kg weight in last 1 year. This is the sigmoidoscopy which we have done now. You can see the stent. So here is a patient who is a known patient of child C cirrhosis in 2019 and had developed CS sigmoid in 2020, and this is 4 years after the diagnosis of CS sigmoid. He is with us and merely lost 2-3 kg weight, has not been given any treatment, only a stent to relieve his obstruction. This is the picture. There is partial ingrowth in the stent, but we could still cross it and we reached the upper part of the sigmoid. You can appreciate. Case number 2, 62-year-old male, came with abdominal pain, colonic stricture at hepatic flexure. Biopsy was inflammatory. On colonoscopy, somebody put him on AKT, but he landed with obstruction to us 10 days later. We did a laparotomy straight away, and unfortunately there was a cecal growth. So this was probably a misdiagnosis, and surgeon performed a right hemicolectomy. Biopsy revealed adenocarcinoma. Went to Mumbai, started on chemo. This was a mucin secreting adenocarcinoma. Unfortunately, he had some complication after chemo and died 3 months later. This is the third case, 60-year-old male, very interesting. 2019, he came just for non-specific symptoms. We did a pan-colonoscopy, found a solitary rectal polyp. Polypectomy was done, showed adenomatous polyp. 2019, 4 months later only, he asked for a repeat sigmoidoscopy. We did it, it was normal. In 19, we had already planned for a repeat colonoscopy after 1 year, but he got it early. In only 10 months' time, he wanted us to do. And unfortunately, we found a polypoidal growth in cecum. So mind you, he had a normal pan-colonoscopy 1 year before, but still there was a polypoidal growth now. This was again a mucin secreting adenocarcinoma. So there were no polyps left, still he developed a carcinoma. In 2000, again after 1 month later, he underwent a right hemicolectomy. Biopsy report was T3N1A, KRAS was wild, and MSI was positive. We will discuss this later. And chemo was done. And 2023, we did a colonoscopy, it was normal. And today morning I spoke to him, he's perfectly fine. He's coming for a yearly colonoscopy shortly. So these are the 3 cases we'll base our discussion on. So let's now get on to our panel. What do the experts say about various aspects of CA colon? So I'll start with Dr. Sunil Kumar. What is the prevalence of carcinoma colon in world? Its rank amongst the all cancer, which is a commonly asked question. And is it low in India as compared to West? And why? And if at all it is rising in India, why?
Well, every year almost 1.9 million cases of colorectal cancer are diagnosed world over, and that forms around 10% of all cancer cases taken together. The 5-year prevalence of colorectal cancer in the world is 5.25 million cases. Second question. It is the third most common cancer and second leading cause of cancer related deaths. When we talk about males, it is third common cancer and third leading cause of cancer related deaths. And in females also, it is the third commonest cancer and third leading cause of cancer related deaths.
So it's fairly common. Incidence is low in India as compared to West.
Low in India because when we talk about age standardized rates, it is 7 per 1 lakh population for males in India and 5 per 1 lakh population for females in India. And in comparison to Western or countries high on human developmental index, there its incidence is around 40 to 50 per 1 lakh population.
Yeah.
And the possible reasons are that the consumption of processed food and meat is quite low as compared to Western or those countries where its prevalence is high.
But we are moving in that direction. Even processed food is increasing.
That is the reason for increasing in the incidence of these cancers in India.
Perfect.
Besides that,
so that's what Dr. Sunil has told. This is the third most common cause of cancer in men and second most common in female after breast. We'll move forward to Dr. Atul Samaiya. What are the clinical presentations? How does the patient present? What percentage are diagnosed after symptoms and what percentage are asymptomatic when they are diagnosed? You can keep on the slides, please, sir.
Yeah, basically the symptoms depend on the site of disease, whether it's a right-sided colon cancer, left-sided or rectal cancer. Generally, the left-sided colon cancer present with the early symptoms compared to right side. For the right side, we see classically 3A, anemia, asthenia and anorexia. So, and for the left side colon, generally the features of obstruction, pain, increased frequency of motion, tenesmus for the rectal cancer, mucoid stool, bleeding per rectum, melena. These are the common symptoms when they present to OPD. However, if you see the true incidence of asymptomatic cancer is exactly not known, because if you are doing a screening test, it is different. If you see the data, the skin detected cancer accounts for around 10% of the overall colorectal cancers. But if you see the true incidence of asymptomatic patients coming and detecting cancer on colonoscopy done for some other cause, like in the other case, that comes around to 1%.
So in West, where they have an active screening program, they do diagnose 10 to 15% cases on screening only. So don't ignore your symptoms like change in bowel habit, bleeding from anus, blood in stool, abdominal pain, loss of appetite, persistent lethargy, pallor, or unexplained weight loss, which applies to actually most of the cancers. These are the very important symptoms. So I'll just skip this. Dr. Atul has already said it. So again, Atul, what are the risk factors and what is the diet which predisposes to cancer?
If you see, the risk factor applies more or less common for all the cancers and the similar for the colorectal cancer. Around 10 to 20% are hereditary. If you see, take a detailed history, only 10 to, in Indian context, maybe little less. Then the processed meat, as mentioned by Sunil, processed meat, chronic constipation, then inflammatory diseases like ulcerative colitis and the Crohn's disease, almost 10% patient in more than 10 years time they develop the cancers. Then alcohol, smoking, which applies to almost all cancer. If somebody is drinking more than 3 packs per day, he has a high risk for colon cancer. Type 2 diabetes has been associated with the cancer, but exact is not known. Similarly, smoking, the person who is quit smoking again still have a high risk for the cancer. And
so low fiber diet, addictions,
low fiber, yes,
perhaps diabetes,
and obesity, and lack of physical activity, which is common to almost all cancers.
So as he said, there are certain non-modifiable factors like age, family history of colonic cancer, polyp, history of other cancer, genetic conditions, IBD. These you cannot modify. But what you can modify is a diet, cooked meat, unprocessed food, diet low in fruit and vegetables, heavy alcohol, smoking, sedentary lifestyle, obesity. Even obesity is a risk factor for most of the cancers. So proceeding further, Dr. Pavan, what percentage of cancers develop from a polyp? And if not, how do other cancers develop? And what are the various polyposis syndromes?
Percentage of cancers from a polyp depends upon the type of the polyp that we see. If we look at adenomas as a whole, 10 to 15% of them will develop into a malignancy. And if we look at advanced adenomas like high-grade dysplasia, more than 10 mm in size, proximally located and all. So these kind of polyps, they have a higher tendency of developing malignancy, to probably around 45 to 55%. Whereas when it comes to serrated polyps, high-risk serrated polyps particularly, they have around 35% of getting a cancer out of them. Cancers can develop without polyps also. That is because of the rapid hypermutation that happens and hypermethylation that happens at the genetic level, which will cause cancer to directly develop without
so certain
following
genetic
this adenoma
mutations which can lead to cancers.
Yes. So it's particularly based on the mutations. Without polyposis, they can directly jump because from tumor, from the start of the tumor to the growth, it happens very rapidly.
As happened in our third case, who did not have a polyp in previous colonoscopy, but developed a cancer almost 10 months later, a big growth.
So that's definitely possible without a polyp. And yeah, we have different types of polyposis syndromes based upon the kind of polyp on histopathology. We have adenomatous polyposis syndromes. Typically, it is either HNPCC syndrome or a FAP. Then we have solitary serratus polyposis syndrome. Then we have hamartomatous polyps.
Yeah, we'll come to that
everything.
again. Yeah.
All those things.
Yeah, thanks. So about 75% of colorectal cancer start from polyps, rest occur de novo. About 80% of all colonic polyps are adenomas. About 5% of adenomas are actually malignant when they are diagnosed. So I think we can have an audience question at this time. So any PG can answer this. What are the various types of polyps? Anybody? Anybody who's awake and listening? And which of these are pre-malignant? Any PG would like to take it over?
Sir, in the same context, I just want to Dr. Atul Samaya that villous polyposis is supposed to be a precancerous condition, and there are two types of treatment advice for that. One is the sleeve resection per rectally, and another is the resection of the particular segment of the colon. Which I want to ask, what is the size of the villous polyposis which should be removed by sleeve resection and which should be by the resection of the colon?
Sir, we have some questions related to resection. We'll come to that. So basically polyps can be adenomatous, hamartomatous, inflammatory, etc. But mainly adenomatous polyps carry malignant risk. So coming to Dr. S.P. Mishra, what is the role of screening for diagnosis? Who needs screening? Is it relevant in India?
Well, again, there's a carcinoma sequence that, like you said, that adenomas develop into carcinoma and the polyposis syndrome. So screening is very important for diagnosis of early cancers and prevention of cancers and deaths. In the West and in the most developed countries, and even in China and Japan, I was there in Japan for this training. You know, they have, this is way back in 2005. They have a team of 15 people who just do colonoscopy screening, not therapy, only screening. That number probably will get in the near future because more people are coming out. There's a deficient of number, but screening does help. And the screening program is anybody above 50 gets a colonoscopy done. The Cancer Society of American Society of Gastroenterology advises at 40, 45. And if somebody has a first degree relative who develops a cancer before 60 years of age, or two relatives at any age, then you do it at the youngest person developed 10 years before that. 10 years before that. Yeah. And then follow them up every 3 to 5 years. Remove all the polyps seen, and if they are adenomatous, decrease the screening period. And fecal occult blood can also be done. That's very good. And Japan mostly uses the fecal occult blood. Yeah. Who needs screening? I told you, people with familial polyposis, those who have history of family. But in the West, everybody is getting a colonoscopy done. And probably with, like you said, changes in the lifestyle and the diet, the reporting is more, probably we'll need screening. I talked to the ICMR people in 2005. They rejected the proposal because they said it's not possible.
It's going to be relevant in our country too. And
it's going to be relevant. I think it is relevant. And whenever I do a colonoscopy, I try to look for polyps. And if the polyps are there, I remove them on the same go.
So at the moment, we are doing screening in select groups, like if there is a family history, if there is a polyposis syndrome, then we are doing. But for a common man, we are not yet doing. Perhaps it will come. Dr. Chaubal has a point here.
I just wanted to know, panels, thousands of colonoscopies we have done, all of us. In India, how often have you seen asynchronous or a metachronous polyps develop in these patients? Synchronous or metachronous? The reason is very clear. I think it's my experience. You have a malignancy there, but you do not have so many polyps. So I think in our country, this so-called adenoma carcinoma, there's something else working other than adenoma carcinoma sequence in this.
Yeah, perfect.
We don't have to have so many of polyps. Had it been there, I think definitely screening program would have been there in India.
Yeah, sir.
But in this situation, it's different. early onset of malignancy is also in the absence of any family history. That is also quite common in our particular situation.
So
What do you think, sir?
That's precisely the reason that we have not been able to generate a proper screening program, because we do not know our population, how does it behave.
Sir, what you say is right, and that's what we were discussing. I know of 3 senior gastroenterologists who were diagnosed with adenomas, one with CA in C2, and they're doing very well because they underwent colonoscopy spontaneously because they thought that they should go under screening.
It will have a relevance, but I
Definitely.
think we have to generate some data. So we'll proceed forward. So what do you do for screening? You can do a colonoscopy, which is the best test. But of course, to reach to a colonoscopy, the fecal test is very important. Nowadays, we have simple fecal occult blood testing or fecal immunochemical testing. This is the data from West. So this is how colonic polyposis, adenomatous polyposis looks like. So Pawan, what is the protocol for screening family members of the CA colon patient in family clustering, in polyposis, in HNPCC, etc.?
The first most important factor is the clinical history.
What is the screening protocol? I mean, see, like sir said, in West it is 50 years for everyone. Now it has been lowered to 45 years.
If family clustering is there, then we have to start at least 10 years earlier.
10 years before you had a patient of polyp or cancer. I think that is what should be the message.
Yeah.
The second thing I would say is that in increased risk population as polyposis, etc. In FAP, like they say that you start screening at 10 to 12 years of age.
Whereas HNPCC we start around 20, and then SSPs we start around 30, 35.
So very important message that if you have a family member who has got a polyp, or adenomatous polyp, or a cancer, then you start at 10 years before index patient. So if somebody had developed colonic polyp, adenomatous, or malignancy at 40 years of age, his family member should start screening at 30 years of age. So this is a very important message which I wanted to convey. Yes, Dr. Sahu.
Just a minute. I don't think colon screening is the need of the hour. And
in India?
Yeah, in India. In India. I'm talking Indian context.
That is what Dr. Chaval has also said already.
Okay, so we move on.
I think so. That's what that has been conveyed well.
But Sanjay, we can have fecal occult blood done. We can have fecal occult blood, and those who are positive can.
I think it will need some discussion. We can have it at the end.
Opportunistic screening can be done, which you have mentioned. Mass screening definitely is not the need of hour for India.
I mean, that's a topic for the entire day, that whether we should have a screening program in India or not. So let's go forward. So this was very simple. Again, I think audience is not connecting. I thought, what would you do in a patient with a report of FOBT positive, fecal occult blood test positive? Whether do you do a colonoscopy, an upper GI, or both upper GI and colon, or you repeat? And some people even give just anti-amoebics. So anybody from the back? So I think the message here is that there was a beautiful study in the British Journal of Surgery long back, and they actually concluded that most patients finally would have to undergo, if you repeated the fecal occult blood testing, then finally they would have to undergo both upper and lower studies. Anyway, so how do you do an early diagnosis, Dr. Mishra? And I'll need a comment from Kamlesh also as a radiologist.
Well, you want the role of magnification endoscopy?
How do you do early diagnosis?
Early diagnosis, basically, what you said, sir. Fecal occult blood can be done in most of us, and it's not expensive and easily
does magnification endoscopy help in that?
Okay, definitely. It does help. And NBI and endoscopy also help, because it helps in basically not making early diagnosis. Your eyes have to be trained to pick up the. Now we have something known as AI is coming in, which is going to help you in detection of early polyps.
Yesterday we had 2 beautiful lectures on the same topic, one by Dr. Mohan and one by Dr. Prakash from Kochi, and they both emphasize that the quality of our endoscopy and colonoscopy has to go up.
Yes.
And we have to devote sufficient time to each patient.
Sanjay, that can only be achieved if we have more gastroenterologists. We are so pressed for time, doing so much procedures.
More gastroenterologists would like to do more endoscopy, still they will give less time.
Because of the population.
I don't know whether the mental attitude has to change. Kamlesh, any role of radiology in picking up early cancers?
In early diagnostic workup, where we can make you free and imaging can help, is CT colonoscopy. So CT colonoscopy is easier procedure to perform. Just need bowel preparation followed by bowel distension. And the newer equipments coming are integrated with AI. So AI, continuous deep learning, and which is giving, now the images of CT colonoscopy are getting much better. So not just polypoidal lesions. Now these colonoscopies will be able to perform ulcerations as well. And AI will help in localizing the lesions as well as to an extent characterizing the lesions, which can definitely be counter-checked by the radiologist. So like sir said, the workflow, so yeah, definitely. So CT colonoscopy can help you take out the burden of doing colonoscopies to an extent.
But you are
Till now it is option for the patients where colonoscopy is not possible or patient is not willing for that. So till now that is the option, but over the time we can say the role may grow.
So we'll proceed further. So if there is a polypoidal growth on colonoscopy, colonoscopist obviously knows that this is a malignant growth and he will take a biopsy. But what are the features in a polyp which suggest malignancy, Mishra sir? And do you take a biopsy or do a polypectomy in all patients where you find a polyp?
So the last question first, any polyp I see, I just remove it out.
So polypectomy should be done rather than biopsy. Yes.
Simple answer.
Any features in
Features
the polyp?
for large polyps, irregular polyps, bleeding polyps, friable polyps, and discolored polyps. Polyps that are blackish in nature, they suggest malignancy. And then you can see they are tethered to the colon also.
Correct. So adherent polyp with ulceration, firm consistency, friability. So those are the features that we endoscopists should look for and should be aggressively pursuing it further. Dr. Kamlesh, this is a very common sonographic finding, and this has actually given all endoscopists so many colonoscopies. So there is a reported thickened sigmoid or ileocecal region on ultrasound. So what do you suggest? Do you do a second imaging or shall we go for a colonoscopy?
So I may be biased for imaging possibly, so I will ask for Dr. Atul's opinion as well. Means I will consider everything in this, just thickening. So thickening may be a variety of causes, right from the neoplastic to inflammatory. So I may go for a comprehensive CT to look for exactly what is the picture. Many part of the bowel which we are not able to see on ultrasound. So many part of the stomach, abdomen, especially in the bowel, we are not able to see on ultrasound. So getting a comprehensive picture on CT and possibly then doing any invasive procedure might be more fruitful.
Yeah, because often it is because of this unprepared colon. The stool is giving that appearance, and often that's the finding we have found. I'll proceed further. So Atul, what are the various stages of CA colon? Just in brief.
So
1 to 3.
Like for all malignancy, it is stage 1 to 4. Generally, it is on the based on TNM. T for the tumor size. So here is the depth. It's not the size. It is the depth. Tumor confined to mucosa, submucosa is T1. Going to muscularis propria is T2. And if it is crossing the muscularis propria up to serosal surface, it becomes T3. If it is invading or adherent to the adjacent structure, crossing the peritoneal basal surface of peritoneum, it becomes a T4. For nodes, any node positivity is N1. If more than 4 nodes are positive, it is N2. So this is basically based on that, it is stage 1 and 2. T1, T2 is stage 1. T3 is stage 2. Then the all node positive are stage 3 and metastatic disease are stage 4.
So is it easy to classify before surgery these patients into TNM classification based on imaging only?
In few cases, if the nodes are definitely positive, it is adherent to adjacent organ, we can classify them T4 lesion and the node positive.
So one
even
should
in
try
many
to
cases, nodes are negative on the final histopathology. So the final histopathology is the final staging in these cases.
So the colectomy specimen gives you the final staging, but on imaging also you are reasonably sure. Kamlesh, what is the best imaging modality for CA colon and rectum?
Yeah, it's very important to discuss because everybody come across this with the question. So yeah, I will rather start from the below, the difference between rectal CA and proximal CA. So yeah, so there we decide rectal CA because we all know MRI has got excellent soft tissue differentiation when we talk. So it is the positive of MR. What is negative is a time taking and relatively the mobile part of the bowel is difficult to image. So when we come to rectum, so rectum is excellent imaging with the MR, so MR definitely is the gold standard. So when rectal malignancy we are talking about MRI. When we come up the proximal bowel, so proximal bowel we can have both the options. Even theoretically MRI is good, but practically CT gives us equally good information doing the CT abdomen, and now I understand in CA colon when we are working up, so CT chest is also required.
So why not do MRI in all? Why do CT at all?
For what, sir?
For CA colon, for rectum MRI is best. For colon also you said MRI is reasonably good, comparable. So why not do
Yes.
MRI only? Why do CT at all?
So when we are working up chest, abdomen, pelvis, so it becomes practically it becomes reasonable. Means many a times it is less time taking, and MR time is the one thing. Availability of the equipment and comfort of the surgeons, number 2.
And movement
number 3 is, yes, patient. So patient cooperation, if not good, then in MR not we are getting consistent quality as good as CT. In CT almost consistently we will get good quality. So if it is non-rectal malignancy, we can opt for directly CT chest, abdomen and pelvis. But for
In
the rectal
rectal
malignancy,
MRI?
definitely abdomen, MRI abdomen and combined with CT chest.
So he's very clear. For rectal, do MRI. For rest of the colon, do CT, chest, abdomen, pelvis.
There I will just differ. Based on the institute, you can decide on that. Again, their theoretical advantage of MRI. So if you are good at MRI and you have good protocols for MRI, you can go ahead with MRI with combination of CT chest. Both the options are open as per your institutional practice.
So
even for rectum, I would like to have a CT chest and abdomen along with the MRI pelvis for the rectum. So I will not go for the MRI abdomen until there is liver lesion to quantify whether they are multiple, single. So my choice will be as a surgeon, because I can read the CT scan properly, but I need MRI, I need Kamlesh for MRI.
That's also an issue, that we can read CT better than MRI ourselves.
But
so Pawan
okay,
and Sunil,
but here definitely the take-home message should not be this, because this is not what is suggested, which is advised. Because see, when we are dealing with CA rectum, so definitely liver lesions we are looking for. So, and doing the one study, when we are doing pelvis, we are giving MRI contrast. So it's always better to complete the abdomen in that same sitting. So that's fine. If you feel like MRI, you are not happy with the MR upper abdomen part, then later on you go for CT is different thing. But in the same sitting you can come.
I would like to ask one thing. In NCCN, for chest uniformly they have always mentioned CT chest. For chest, MRI is not mentioned anywhere, and I have heard from radiologists also that for chest part, HRCT or CCT.
No, I can answer that also, because in chest the MRI performance is not that good because of the motion artifacts.
Sir,
I think
that's why
they always prefer CT.
Possibly. So when we are going for CT chest, it is by simple logistically, it's easier to get a CT chest and abdomen in the same setting.
I think we can close it here. We are short of time. The message is there.
So yeah, CT chest, yes.
We proceed further to Pawan and Dr. Sunil. Sorry, this was the role of PET. Do you recommend a PET scan, and when do you recommend, both of you?
No, I don't do it routinely, sir. I do it in very special instances where I want to start a neoadjuvant for suspected spread of the.
So for neoadjuvant, if you are considering, you would like to give.
In an operable metastatic disease,
well,
yes, we do.
There is just one indication, and that is if a patient has potentially resectable liver-limited disease, and in these patients, PET CT should be done. Otherwise,
so if you are
CT scan
considering
is
a hepatic resection along with the colonic resection, you do a PET CT first,
Operable
because there may be
metastatic
a metastasis elsewhere. That's a good point.
And when there is a reaction to contrast, we can opt for PET scan
Without contrast. So, Dr. S.P. Mishra sir, any other testing on the tissue for you and for Dr. Sunil? Apart from
by and large,
histopathology,
if you get histopathology, that's good enough, but sometimes you need IHC and all those tests that has been shown by Dr. Chawla and others. Yeah. So those tests can be done, but only rarely do you need those tests.
Sunil?
Well, the test that should be done on every patient is for MSI or MMR.
Our third patient had MSI
instability by IHC or mismatch repair by PCR, because that helps in identifying patients who are carrying hereditary disease, because that has implication for the patient as well as for his or her relatives.
So I think this knowledge should be common to all now.
No, yes, but we only do in younger people if they have more MSI.
Certain guidelines are there. Yes, sorry, I interrupted you.
And in patients who are having metastatic disease, mutation testings for KRAS, NRAS, BRAF and HER2/neu should be done, because there are targeted therapies for these mutations, and if patients they do not harbor any of these mutations, then we can go for next generation sequencing to identify rare but potentially targetable gene mutations.
Yeah, we'll come to that also. That has come, this is a new knowledge, and I think we'll be discussing. Role of MSI testing, sir has already mentioned that in younger patients and patients with synchronous, metachronous colorectal malignancy, HNPCC, etc., it should be done.
Sanjay.
So, yes, sir.
Same question, how far has research on E-nose progressed as far as detection of these malignancies is concerned?
E-nose, any comments? This, sir, you can tell about it.
This is a particular thing which I think they have done for, in experiments they have seen that certain melanomas, etc., can be picked up by dogs by just smelling, because certain volatile acids are elaborated, eliminated in the breath, which can be caught in these things.
I have a slide pertaining to that in the end. I'll show you. Yeah.
So they started with the experiments on the dogs, that they detected that this patient has melanoma because of that particular smell. So same thing probably is applied.
A dog smelling the breath is okay, but smelling the posterior...
No, they are elaborated in your breath. Those volatile acids are elaborated in your breath, which are detected.
It is by breath.
So, I can elaborate on that. There's we have a triple IT, and some people are doing over there about breath and the flatus. They are working on it, but nothing very concrete.
Yeah. So coming to next, can I have the slide? So any role of EUS? We have discussed about MRI and CT. So is there a role of EUS particularly in rectal malignancy, Dr. Mishra and Dr. Kamlesh?
Yeah, you can see the depth of the tumor and whether you can resect it or not by endoscopic methods is okay. And by and large, you can see the involvement of the muscles also.
So you can do a T staging perhaps better on EUS. That's what some people feel. But Kamlesh?
Okay. So sir, from means EUS, because of very high frequency, excellent differentiation of muscle layers, this there. And now possibly with the EUS there is possible to have even elastography, possibly over the time it is possible to have USG contrast, and we will be able to do perfusion as well. But still the limitation is that field of view. So just even we are not, even at the early stage T2, T3 we may get some nodes. So those nodes are not picked up well on EUS, that has missed. So MR, now coming to MR, so MR is now over the time it is taking up the role of EUS also. So if we do proper T2, high resolution T2 imaging, cross-sectional imaging, perpendicular to the lesion, so we are able to make out the layers of the muscles. So MRI will be comprehensive study for that.
I agree. Even if you do EUS, you cannot bypass cross-sectional imaging.
EUS, if you do, you need EUS plus MRI, but over the time possibly MRI will do the purpose of both.
So not many centers are doing EUS for staging of rectal cancers now. So coming to management quickly, I have reduced the time by 10 minutes. I am trying to finish. So what is the management as per disease? Dr. Atul has already said 1, 2, 3, 4. What is the management?
Stage 1, it is surgery itself is curative. There is no role of chemotherapy. For stage 2, it is surgery followed by chemotherapy. If it is microsatellite stable disease, in MSI high, again surgery itself is curative. In rectal cancers, we need to add radiation also. In stage 3, again we divide whether it is upfront resectable or unresectable upfront. Upfront resectable, we go for surgery followed by chemotherapy, and in rectal cancers, it is radiation also. In upfront unresectable disease, we go for neoadjuvant chemo and radiation followed by surgery. There is coming role of neoadjuvant immunotherapy also in MSI high patients. Stage 4, chemo, immunotherapy and targeted therapies.
I think the guidelines are fairly clear about this. So that's what he said. So any role of endoscopic resection in stage 1, Dr. Mishra?
Yes.
In very early disease, I'm not saying stage 1.
So you want yes or no? It's yes. Basically, you can remove mucosal cancers, less invasive, the colon is preserved, the patient goes back, but not all cases should be taken up for endoscopic ESG or ER.
So you have to have a good T staging before you can do this. If it is T1, which is only up to submucosa, you can do ESD. But if it is T2, which you cannot identify very clearly in all patients, even after MRI and EUS, you cannot do it. So I think endoscopic resection only for disease up to submucosa.
And whenever there is doubt, call your surgeons.
Yeah, they will operate anyway. What are the various surgeries as per stage? Atul, very briefly.
Basically, for stage 1, 2, 3, if they are operable, surgery is the main front for the colon cancer. For rectal cancer, yes, stage 2B onwards, we generally prefer the neoadjuvant chemoradiation followed by surgery. And for upper rectal cancer, they are treated like the colon cancer. They are not treated like rectal cancer. Right. So the surgery preferably by the minimal invasive approach, laparoscopically. If not, then the open surgery, there is no difference in the outcome. But yes, morbidity and the overall patient benefit is there with laparoscopic surgery.
Clear. Yes, please give 2-3 minutes. 2-3 minutes. So any role of neoadjuvant, I think he has already said. Pawan, you want to add something?
Yes, sir. So neoadjuvant therapy main role is in rectal carcinomas particularly, where we have to give both chemoradiation. So T1, T2 node negative disease, as Dr. Atul has said, we don't have to go for neoadjuvant chemotherapy. Straight away we can go for surgery, even in the lower rectum. But when it comes to T3 or any node positivity, we have to go for a neoadjuvant chemoradiation therapy. And our protocol is to give for larger tumors, and when we want to do a sphincter saving surgeries, very close to like intersphincteric surgeries and all, we prefer giving a total neoadjuvant chemotherapy, where we give entire dose of chemotherapy and radiation before surgery, and then we take up for surgery 8 weeks after the surgery. If the tumor is small and we have operable liver metastasis and all, we give a short course radiotherapy with 6 cycles of chemotherapy, and then we go for simultaneous resection. Simultaneous resection is what I choose every time.
Simultaneous resection is preferred.
Whenever it's possible, simultaneous resection.
So this he has already covered. I think 5-year survival as per stage, just figures.
5-year survivals are around 65% when all stages are taken together. For stage
65% for all stages together. So it's a very good 5-year survival.
90% or more in stage 1, 85% for stage 2, and it is 65% in stage 3, 13% for stage 4, but potentially resectable liver limited disease that has 5-year survival of around 40%.
So 40% 5-year survival even in stage 4. This is a very important information, and even with liver metastasis, patients can do well after resection. So this Pawan has already said. So I think early or comorbid condition, do you resort to palliative stenting, or there's 2 roles of stenting. Either you do in an inoperable patient, or you do stenting in operable patients to avoid 2-stage surgeries. I just want to comment on this. What is your experience? Have you done, Dr. Mishra, surgery in a patient who is operable? You have put a stent and later on surgeon has operated.
No, I have not put a stent in operable patients. Surgeons, but when there's obstruction,
an obstructed patient, and they will do a 2-stage surgery.
We have used stents, and like a patient you did, I would have been very wary of putting in a stent there, because they tend to bleed, the cirrhotics.
So we have several patients where we have done a pre-operative stenting just to prepare the patient well, and about 10-15 days later surgeon can operate. What is your experience?
I have done 5 cases, pre-operative stenting for left-sided colon. Right side colon I don't need.
Of course, left side.
Left-sided colon, so I have done 5 cases.
So we also have good experience.
And we have avoided colostomy in all 5.
And data also supports. We can have a comment from Dr. Manu and Dr. Rajesh also. What is your policy at AIG? I mean, you do patients who come in obstruction.
So you rightly said where the patient has acute obstruction and the bleeding is there, and then to relieve, and the patient is potentially operable, we offer.
And I tell you, all our patients have done well. Do a pre-operative stenting, they are prepared well, abdomen is soft, then surgeon can plan out surgery. Salim, you have a comment? No? Okay. We'll come to that.
So one comment, sir. I think there is one study which has shown 19% of micrometastasis following a stenting procedure, so they don't routinely recommend.
So they say that the micrometastasis increase after stenting?
Yes.
There is one meta-analysis which has shown there is no difference in the outcome of the patient. So this is published somewhere in 2016 or 18.
But then you are avoiding one surgery.
You are avoiding 1-stage surgery, avoiding 2nd surgery, and second thing, micrometastasis. This is some paper published recently which has shown some increase in micrometastasis, but still it is a debatable issue.
No, but barring obstruction, most surgeons will do a 1-stage surgery.
Yes, I agree. I am talking only about obstruction, left-sided. Hari
Sir,
has a comment.
This is regarding stenting in left-sided colon. It's indicated when there is an elderly patient having acute obstruction of couple of days duration, or sometimes the patient comes with an obstruction of 4-5 days duration, and the patient is not immediately fit for surgery and the single-stage surgery during the resection also.
I think that point is well taken.
You buy some time, you prepare the patient well, and you avoid the infectious complication, you avoid the stoma formation also. Of course, there's no difference in the survival, but stoma rate is definitely low. And
agreed, you avoid one surgery.
Yes.
Instead of 2, you will do 1, and elderly patient, it gives you time. So I think I can skip few questions. Coming straight away to molecular targeted based therapies, Dr. Sunil, sorry.
Well, there is definite role of targeted therapies in colorectal cancer. Various trials have shown that they not only improve response rates but also progression free and overall survival. And the better thing is that they are well tolerated, can be used for prolonged period of time, that is till progression of disease or unacceptable side effects in metastatic setting, as compared to chemotherapy, where side effects are quite common and we hardly use them for 6 months or so.
So they're fairly safe.
Cost is still a problem because most of the patients are still not affordable for these therapies. Immunotherapy nowadays costs 10 to 12 lakhs per year. When we come to this anti-EGFR therapy, cetuximab or panitumumab, that costs around 2.5 to 3 lakhs per month. Bevacizumab is the cheapest and can be used without any mutational status, or that costs around 50,000 per cycle.
So there are options, though they are costly, and they are well in vogue now. So last 2 slides, 2 interesting new concepts. One was circulating cell-free DNA in colorectal cancer. This can be used for early detection as well as for detecting the primary or secondary resistance. Secondly, as Dr. Chaubal said, the rotten egg smell is from colon cancer. You may train your dogs in future. And they have actually identified increased production of hydrogen sulfide in intestine is associated with colorectal cancer. And this particular study has suggested that it can pick up colon cancer much before they become clinically apparent or even colonoscopically apparent. So this is just an interesting fact. And if there are any more questions from the audience, we will take up. So briefly, colorectal cancer is a very common disease. In India, still not so common. The incidence is 4 to 5 per 2 to 5 per lakh population. Prevention and early detection is possible. Polyposis versus non-polyposis is well studied, but less in India. But there is a huge role of screening in West yet to come up in India. There are tremendous advancements in imaging, genetics, histology, and treatment. Surgery is the best treatment, either endoscopically or operatively, if feasible. Chemo, especially targeted therapy, has emerged strongly. Dr. Sahu is going to talk about that in later part today. And there is a 5-year survival even in 4th stage. This is the most important fact. And there is a lot to come in diagnosis and treatment. Thank you so much. So we can have 1 or 2 questions from the audience. Salim, you have a point.
Sir, I have a strong objection to the comment that was made that screening for colorectal cancer by colonoscopy should not be done in India. It should not come from an academic forum. Say this statement to a person who comes to you asking for a colon scan, and you send him back telling him that it's not required because you're from India, and he presents to you after 10 years with liver metastasis, with lung metastasis.
I fully agree with you, Salim.
Will you have medical evidence to support you? You will not have.
It is like telling all hepatitis B positive patients that you don't need treatment, you're having a silent disease.
There are only,
it should not be done, but of course this is a very going to be a very violent discussion. I don't want to indulge in that, but no, I take your point.
Sanjay, I have a problem. I am a proponent of that, but there's a problem to it. Screening such a huge population is not feasible. So feasibility is something, if it becomes a government policy, they have to provide it. So I had a long chat with the ICMRP when I came back from Japan. They said the same thing, and I agree with
feasibility
that.
Is a different, it's altogether.
For individuals, it's okay.
The feasibility is altogether a different thing.
So let me just close this by showing a raise of hands. Dr. Sahu, after your comment.
After my comment.
After his comment, we'll have a show of hands who wants screening in India to be, thought of, or who doesn't.
Everyone wants screening for every disease. That's a fact. But the thing is it doable? Screening is a different word altogether. So even we are not able to do the cervical cancer screening, which is a much more bigger load than this. So doing a colonoscopy and doing that one-off case is not what screening is all about.
So screening is not just colonoscopy.
You have to reach to
can
masses.
Do other measures.
You want to reach to masses to make a screening effective. And colon cancer, the incidence is still not high enough for the government to invest in a population screening program.
It is
You
45 per lakh in Hungary and 2 to 4 per lakh in India.
You can do a high-risk population screening, that is okay. But you cannot advocate in academic.
So that's your point of view. So shall we have a show of hands based on whatever we have discussed? Who wants screening to be implemented in India?
You have colonoscopists over here, so they'll all agree.
No, I don't see many hands. Please be free to raise your hands if you want screening to be done. I am a proponent. Not because we do colonoscopy, it can be done by other methods also.
Just point to it, cervical cancer screening, pap smear is in the National Cancer Control Program, but that is even not done, which is the most common cancer for females. It is not done properly in India. So for the lower incidence, opportunistic screening is yes. Otherwise, for mass screening, we don't have resources for the mass screening for colorectal cancer.
Okay, fine. So we'll end with a final comment from the chairperson.
So, point is well taken. As Dr. Samir says, that it should not be said on a academic forum that it should not be done. It should be done. In England, Kate Perry was colonoscoped, and that her colonoscopy was telecast on a national television, just to increase the awareness of the screen for colorectal cancer.
But I have a different opinion.
We can't say it should be ruled out.
But then I have a different opinion. Same thing will go process. See, screening and surveillance, it is basically government responsibility.
Yes.
Remember this. There's a patient, payer will be the government. It's not a person himself. If you introduce this as a part of this, like pap smear and all these things, they are also covered under government. There are insurances which cover this particular thing. And so it has been accepted by Medicare in America. It's because the incidence is so high over there. But same thing cannot be. In this particular academic forum, of course, academic forums can be different for different countries. It's not that.
Let us close this with a thing that, with a notion that perhaps it is the job of ICMR to decide, not ours. Thank you very much.
Thank you, esteemed faculty, for this very engaging discussion. I would request you to please come to the center of the stage for the photograph. Moving on to the next session for today. It is a panel discussion on neuroendocrine tumors. I'd like to invite the chairpersons for this session to stage. Dr. Anand Singhai, surgical endoscopist, Sagar. Dr. Shekhar Srivastav, surgical gastroenterologist, Shekhar Hospital, Bhopal. Dr. Mahim Kosharia, professor of surgery, Gandhi Medical College, Bhopal. The panelists for this session would be Dr. Rajesh Gupta from Hyderabad, Dr. TP Sahu from Bhopal, Dr. Salim Naik from Delhi, Dr. Anuradha Shekharan from Hyderabad, and Dr. A.H. Kapadia from Bhopal. This session will be moderated by Dr. Manu Tandon from Hyderabad.
Hi, good morning everyone. I welcome all the panelists here for discussing a very important topic, neuroendocrine tumors. Dr. Rajesh Gupta from Hyderabad, Dr. TP Sahu from Bhopal, Dr. Salim Naik from Delhi, Dr. Anuradha Shekharan from Hyderabad, and Dr. A.H. Kapadia. Welcome Dr. Manu Tandon to moderate this session.
Thank you. Thank you very much. Good afternoon, all of you. We have had a wonderful panel discussion preceding this. The only thing is we'll probably cut down a little of the slides we've been asked to reduce the time a little. And I'd like to thank Sanjay for the privilege of giving me the opportunity here. Now I'm going to talk to these specialists on neuroendocrine tumors. When I was a student, I think the people at the back are the students. There was no word as neuroendocrine. Yogesh is there. We used to have a carcinoid syndrome once in a way, or a carcinoid tumor once in a way, mostly detected incidentally. There was no word like NET then. Today, this is evolving science still. We are coming to know more and more, and I am sure with this expert panel here, we'll be wiser at the end of the discussion. So we'll begin This is our panel, and Sanjay has done a wonderful job. He's included everyone. We have got Dr. Rajesh, who's a gastroenterologist, Dr. Salim, who we just heard, a surgeon, Anuradha is a pathologist, Dr. Kapadia belongs to the Department of Nuclear Medicine, but I'm going to ask him regular imaging also, and finally Dr. Sahu, who is the medical oncologist. I'd request all of you panelists that we limit ourselves for the sake of the time that we have been given. I told you 2 minutes in my communication to you. Probably we'll have to hurry up. We'll begin with a brief introduction, and this is meant for the students. NETs arise from neuroendocrine cells, and why are they so called? Because they have features of both nerve and endocrine cells. They have no axons, but they are features of nerve. Sometime later we'll go into that in detail. The GIT is the commonest site. The chest is the next commonest site, but you can get the tumors anywhere in the body. There are certain risk factors associated with these. They are, you can see the risk factors, carcinoid in siblings, more in women and diabetics. Some of the pancreatic neuroendocrine tumors are associated with these syndromes. One, VHL syndrome, all of us know about it. Neurofibromatosis type 1 also. And what you should know is a majority of the NETs in the GI tract are non-functional, whereas the pancreatic NETs, 40% of them are functional. That is a very crucial difference. Functional and non-functional, we are going to take the differences very shortly. So the new term that WHO has given for all gastrointestinal and pancreatic NETs, and we're going to discuss both of them, is gastroenteropancreatic or GEP NETs. They form only 2% of all malignancies. Incidence has been rising over the last 40 years, and this is due to multiple factors, mainly awareness, detection, better imaging to find out. And you see the incidence in the last two lines of this slide. In 73 it was 1 per 1 lakh population, and now it is 7 per 1 lakh population. Now this is mostly, probably we'll ask the panelists, awareness and detection. So we'll begin with the physician, gastroenterologist Rajesh. You come across NETs in your practice, and if you confirm on it on biopsy, what is the first investigation that you ask for? I've also added a second question. This is to shorten the time. How many of you, what you see are functional and how many are non-functional?
So as you rightly said, sir, majority of the NETs what we encounter, they are non-functional. So the second thing is about the commonest organ, because we do GI endoscopies, upper GI endoscopy, which are within the range of endoscopies. So gastroduodenal we pick up more commonly, though as per the literature, the small bowel is the most common site of NETs, but because we do endoscopy, we pick up these lesions more, so we'll say this is commonest. But as for the literature, it is GI, the small bowel is the most common site, then the stomach is not so common, then comes the rectal, and then appendix, and then colon, and then stomach. But we do more of the upper GI endoscopy, we end up getting more. And there's a majority are non-functional.
Okay, you diagnose, you send it to the pathologist,
Yeah.
he said, and what would be the first investigation that
So
you would ask?
obviously we take biopsy, because these are based on biopsy diagnosis.
Yeah.
If they say it's a biopsy is positive for NET, then I do cross-sectional imaging. Sir.
Which is a CT or what?
CT, sir.
CT.
Obviously the.
Okay, different studies shows the difference. Rajesh has said that it's what are picking up rate. Now I've just showed 2 studies which show differences in the origin, but by and large this is from large studies, so you can take these as taken as probably standard figures. 20% are functional in the GIT I mentioned, and 40% in the pancreas, and I told you they are associated with either MEN1 or neurofibromatosis. I'm coming to the Indian data, and here is where I'm going to ask Salim for his opinion. Now, we had 2 Indian studies. One was from a group of surgeons, Jagannath, all of us know. It had Sadik Sikora, it had Dr. Shastri, and all surgeons who screened in a registry 407 patients, and most of them were pancreatic. Histology, you see, out of the 230 patients, majority of them were grade 1, but the most common site there was pancreas. So was the other study from Ahmedabad. They had only 100 patients, but again pancreatic NETs were the most common. So my question is, Salim, you are a surgeon. Is this the commonest NET that you see as a surgeon, not as an endoscopist?
No, sir. Even nowadays, the most common NETs which we are seeing are upper GI NETs. Majority of the NETs would see would be luminal NETs, stomach or duodenal, most of the time. But we also, with the advent of WhatsApp, we get a lot of texts from our fellow colleague general surgeons who operate upon appendicitis, which turn out to be NETs later on. If you say which are the most common NETs we operate upon,
yes.
So yes, they would be pancreatic NETs, but we get a lot of patients who come to us for opinion, who are usually upper GI NETs, who usually just require observation most of the times.
Yeah. So I think the Indian data is very important for us, but I think to be taken with a little pinch of salt, because both those studies, 400 and 100, showed pancreatic NETs to be the most common. Anuradha, moving on to the pathologist, you got a tissue from Rajesh. He's done an endoscopy. Is IHC a must to diagnose? We are not staging it yet. And the second part is, I want to especially tell, is there any special precautions you would like, or the standard, put it in formalin, send it within 2 hours, enough, or do you want to tell the students anything, how best to get a good result?
So first, about the precautions of taking biopsy, we don't have any special precautions, sir. So all you have to take it and put it in the regular 10% formalin. But that is to be dropped immediately.
Time you want it to reach, or does nothing like that?
No, the only thing is we want you to drop it in the formalin container immediately.
Okay.
Because this is not only for NETs but for anything else, because it affects the IHCs.
Yeah, so the beginners please follow.
Second, we do need immunohistochemistry to diagnose NETs, particularly when we have poorly differentiated neuroendocrine carcinomas.
NECs you have?
Yeah, that is because there the differential diagnosis of poorly differentiated adenocarcinomas and the high-grade lymphoproliferative lesions come into play. So based only on the morphology, we will not be able to tell that it is of neuroendocrine differentiation. And also in the regular NETs, usually they are well differentiated. We do not need, but it is always better that we confirm with neuroendocrine markers, that is chromogranin synaptophysin. So this is the first role to diagnose. But we also need NETs not only to grade, but also to prognosticate. And the prognostic markers, in addition to Ki67, are the CKIT and the CK19. So one study says if both are negative, it is low grade. Both are positive, it is high grade. One of them is present, it is intermediate. Third, we also need IHC sometimes to identify the subtype. If you're thinking of any functional neuroendocrine tumors, we can do additional markers like insulin, glucagon, somatostatin. Fourth, we also need IHC when you have a patient with liver mets and you want to identify the primary. So you can do panel-based markers. Fifth, you also need IHC to use for scintigraphy treatment, that is the SSTR2 receptors.
Okay, I have then one question to ask you, again a message for the postgraduates. Suppose Rajesh suspects NET on an endoscopy. Directly should we write off IHC, or you need routine histopath and IHC?
So you should directly write IHC, because the current thing is you have to grade it.
So if your suspicion on an endoscopy is high, the pathologists feel that you can directly ask for IHC. You need not wait for the preliminary report. Thank you. We move on. Well, WHO as usual has classified these, and the classification is very simple, grade 1, 2 and 3. It's based on 2 factors, the Ki index, we'll be coming to that, and the mitotic index, the number of mitotic figures. The numbers are written there, they are very familiar, 3 to 20 and more than 20. And Anuradha has just pointed out that for NEC, neuroendocrine carcinomas, especially you have both the types, you need to do IHC. There is a new term in classification now, we call mixed neuroendocrine neoplasm, MINEN. People write NEN or NET. That is when an NET or an NEN is mixed with any of these, an adeno, a squamous, or an acinar carcinoma. At least 30% of this element should be there. So this is the new terminology that the WHO classification has now included. And staging, which will come shortly, stage 1, 2, 3 and 4 depends on the size and the depth of penetration. Stage 1 limited to the submucosa, stage 2 beyond the submucosa, stage 3 involving the serosa and the lymph nodes, stage 4 anything with distant metastasis. But see the last line. Tumors behave differently in different situations. For example, in the duodenum, you can have metastasis in a functional tumor in more than 50%, whereas in the stomach, the same size tumor, your metastasis is less than half or 1/3 of what you see in the duodenum. So the same NET at different location, that I'll be asking subsequently to our other panelists also, how do they behave. Dr. Kapadia, you are going to tell us about imaging also. Now I ask for a CECT, tell me what do I look for when I ask characteristic features, what you want. Rajesh just said you want a cross-sectional imaging. And how would you differentiate it from other SOL?
So CECT is the first and initial evaluation for the radiological evaluation. We need a contrast enhanced scan, both arterial and portal venous facial. Most of the time the lesions are very small in size and variable locations. So it is difficult to locate also.
But what do you, classical findings on an NET?
They are hypervascular, mostly they are hypervascular, and as per the location, sir, the size can vary, sir. Their margins can vary. They can be ulcerated margins, they can be infiltrated. Circumscribed lesions are there mostly in pancreatic NET. And we have to look about the lymphadenopathy, peritoneal seedings, mesenteric fat stranding, any metastasis, distant metastasis are there or not. We have to look on the
how would you differentiate from other hypervascular? Let's say I say an AVM is also there, or some other hypervascular areas. Is there any way where NET you can make out just on CECT?
Sir, it is difficult to measure only on CECT. Here comes the role of the gallium DOTA scan, which are SSTR.
We'll come to that subsequently. So CECT students, please look out for increased vascularity in the arterial phase. We move on. Dr. Sahu, you see, you are an oncologist, you see metastatic NETs. Tell me, is there a rise, genuine rise in the last 2 years, and which is the commonest organ with metastasis that comes to you?
See, the incidence will be varying as per your practice. If you are in like let's say Gastro Institute attached, so you will have more NETs presenting to you what we are discussing.
What about Bhopal?
In Bhopal, what we look at is we get more of the pancreatic NETs and the small intestine. As a person who is practicing mainly on the stage 4 patients. So these are two varieties. The most common metastasis which we observe is liver and the local lymph nodes are the two things that I see more. In the probability of metastasis, there could be other sites of metastasis, but liver is the most common site of metastasis for a neuroendocrine tumor.
And primary, you said pancreas or small bowel?
Pancreas or small bowel is my major practice, what I see here.
That's good enough. You are an experienced oncologist, so the message is the commonest secondaries that are seen, the incidence is of course on the rise, and I listed out the various reasons for it, is that small bowel, I think that's because we detect them late, and pancreas, and we're going to come to pancreas very shortly.
Last thing which I wanted, because of the two papers we showed from India, if you look at it, the authors are predominantly from cancer institutes.
Yes, and surgeons.
Yeah, and major cancer institutes, most of us are advanced stage and most of them are pancreatic.
Correct.
That's why you're getting that.
Yeah, biased, skewed data, even I agree on that. Both of them were surgical dominated from Cancer Institute. Rajesh, would you like to tell us, since you are an endoscopist who also does regularly endosono, for the teaching is for the last benches. What do you expect? Any specific features you want to tell on endo and endosono? Endosono for pancreas,
Yeah.
endo for the rest.
Generally, because these are subepithelial tumors, sir. So if they are tiny, there will be small lump, bumps kind of things, small, shiny, because the overlying mucosa will be smooth and shiny. So these are tiny lesions. If they are tiny in the stomach and duodenum, because that we can pick up. But small bowel, generally we don't do endoscopy, so we can't. That's the referral bias is there in the data also, what you showed. So second important thing, endoscopically, if we find any suspicious lesion, subepithelial lesion with overlying shining mucosa and yellowish in appearance, I'll suspect it could be a duodenal or gastric.
Umbilication?
So umbilication is if that's little bigger, then they start showing. So we take biopsies obviously, and if I suspect any lesion, I'll biopsy that and then get the report. As far as the role of endosono is concerned, because as I said, it is subepithelial. The depth is very, very important, because we cannot assess the size simply on endoscopy. We can underestimate the size. That's the reason whenever we suspect any subepithelial lesion to be neuroendocrine, and we are planning management, because that helps in planning further management beyond CT and cross-sectionally. If we want to send this patient for ESDs and 1 to 2 centimeter in size, I want to be precise in measurement of the lesion, because before I send it for ESD or anything.
Yeah, Mohan, I think, has got a talk on resection, so that will come in the afternoon session. So again, for the students, please, high index of suspicion. If you have a suspicion that it is a neuroendocrine tumor, better to get an endosono is what is the message given. This will help you plan the treatment better. I will now very briefly list out the various areas where you get endosono and what we see. Gastric NETs, they arise from the enterochromatin cells of the gastric mucosa and are divided into 4 types. The incidence I have been telling you increased tremendously, 0.3 per lakh earlier, 40 years mein, and now it's close to 5 per lakh. The incidence is almost 20 times. 4 different types. Again, pay attention. Cell of origin is almost similar except the rare type. The first 2 types, 1 and 2, have got increased gastrin levels. The 3 and 4 have normal or maybe even lower gastrin levels. 1 is having an atrophic mucosa, 2 is a hypertrophic mucosa, and that is the one which is associated with Zollinger-Ellison syndrome. And see the size. Size gradually increases from 1 to 4. The percentage at which they occur has been given as a chart. So a single slide describes all the types of gastric mucosa. Coming to the duodenal NETs, they are mostly male predominant, generally in a higher age group, but I don't agree with the Western data. We see them in the younger age group also, and many of them have METs by the time they are detected. 5 different types of functioning tumors have been detected in the duodenum, and their location, they are listed out here. Gastrinoma, somatostatinoma, ganglionic, paraganglionoma, non-functioning also, and duodenal NECs, and you see their location either in the D1 or they are periampullary. So location may help you guide to the type of duodenal lesions. Rajesh has already told you that we don't pick up these because we don't reach them routinely with routine endoscopy, but by the time you pick them up, and Dr. Saab has also told us, Dr. Kapadia, that, and Dr. Sau, that intestinal ones are the ones with maximum metastatic because they are picked up very late. You see here the regional lymph nodes are involved in 70 and liver in 40% by the time they are picked up. Appendix, Dr. Salim Nayak told us that it's very common, incidental post-appendectomy, colonic and rectal I have mentioned. Most of them are large size. Rectal are again picked up because we are doing frequently, we had that discussion, screening, colonoscopy. That's how we pick up many of them. Pancreatic NETs has got a series of syndromes that come, and students must know that all these are the functioning tumors that you get in the pancreas. insulinoma, glucagonoma, somatostatinoma, Zollinger-Ellison, VIPomas with diarrhea. Sometimes you have ACTH ectopic and sometimes you have a parathyroid hormone like peptide and stimulates parathyroid hormone affecting bones and forming stones. So these are the various NETs spread all over the GIT. We are talking of GI, both. Dr. Salim, your question. You've seen the list that I have just listed out everything. Which as a surgeon you say don't make an attempt for anything, directly send it to the surgeon. Your opinion, we'll ask our panelists also, what do they feel, and then at the end of the talk, we still have some time, we'll ask them.
Sir, I think the question should be reframed. As a surgeon, I would like to be a part of any NETs that are picked up, but I would also want them, all the NETs I operate, to be discussed in a multidisciplinary tumor board before we select which are the ones which would benefit from surgery and which are the ones which would benefit, which would go to Dr. Sahu or to other modalities or to a gastroenterologist or someone else. And the treatment should be more patient specific. If you feel about what are the tumors that would be benefited by surgery as such. So all resectable NETs, the first modality should be surgery, unless they are picked up in stomach which are multifocal or picked up in the stomach or G1s in high risk patients. These are the ones I would not want to operate upon, or which are metastatic and a surgical cure cannot be attained. So I think it's more important that all these tumors, when they are found, along with imaging, the board that is sitting here, all the specialists, a pathologist, a nuclear medicine person, a radiologist, medical oncologist, a gastroenterologist, and a surgeon should sit together and discuss out what should be the best strategy for this particular tumor.
Just a rider. Suppose I have a periampullary NET confirmed. You think Rajesh should come into the picture, or it's ideally send it to you? No metastasis, no nothing. One periampullary or an ampullary NET.
If it's a periampullary or ampullary NET, I would want to operate this patient, provided that this patient is not a high-risk patient and it is not a G1 tumor. It's not a G1 tumor in a high-risk patient. Okay. So a G1 tumor in a high-risk patient might well do with a localized resection or with no treatment at all as well.
Okay. We'll move to the next one. Sorry, I think Anuradha, we talk a lot about Ki-67 index and mitotic index. Can you give a brief teaching exercise for the students?
Yeah.
For some of us also.
Sure. So the minute we get a biopsy and morphologically we think we are dealing with a neuroendocrine tumor, the first thing is we have to look at 3 points. That is the mitosis per 10 hyperfields. So 10 hyperfields sometimes we do not get in cell blocks.
Okay.
And mitotic figures based on mitosis, necrosis and Ki-67, as you have shown, the WHO grading is in grade 1, grade 2, grade 3. So the grade 1 mitotic figures are less than 2. In grade 2 it's 2 to 20 and grade 3 it's more. But it is a lot of inter and intra-observer variation even in counting mitotic figures, because counting the apoptotic cells or cells hidden between the lymphocytes, it's not easy because it depends on the visual evaluation. So Ki-67 on IHC is said to be little better over mitosis. The only difference in Ki is the first one is between 0 to 2 and the second is 3 to 20. And the other one is greater than 20. So what may be 2 for one pathologist can be 3 for another, but that changes the grade. So there is a lot of inter-observer variation. Second, Ki-67 is also dependent on the tissue that we receive. And different clones of Ki-67 are there, crush artifacts are there. So it impedes the counting. And also by definition, now the WHO latest 2019 has divided neuroendocrine well-differentiated tumors into 3 grades. It is grade 1, 2 and grade 3 well-differentiated NET versus neuroendocrine carcinomas, which by definition are grade 3.
Yeah.
So the difference is mitotic figures in well-differentiated neuroendocrine tumors are around 20. Ki will be between 20 to 30%, but the NECs will always be more than 50%. So that is one more major thing.
Let's go back to the slides. So I told you these are cells which have got both. Anuradha has also mentioned chromogranin and synaptophysin are the commonest seen. You can have, do we do neuron-specific enolase?
Chromo and synapto more sensitive, but sometimes when they come negative, we have to do other neuroendocrine markers like CD56 and INS1.
Okay. Now Ki67 is a protein, and this you see as this index as how many of these are tumor positive cells are available. Field, of course, she is rightly said there is an inter-observer variation, and you should be careful
and
there.
Also one thing, sir, we have to count 500 cells to evaluate Ki67.
And you do count that every time.
So we at least have to do an average of 300 cells, so practically we don't count 500. That is why, since it's an eyeballed estimate, now we are getting AI-based algorithms to improve our efficiency.
Dr. Kapadia, imaging is back to you. Which are the ones which dotate scan picks up ideally? And I don't know dotate, talk. Is there a difference or it is just all uniform?
Sir,
you know, sometimes it is written talk, sometimes dotate, sometimes. So
Sir,
I want a clarification on that for myself and again for the PGs behind.
Sir, DOTA-TAT is a composite molecule. It contains three things. DOTA is a chelating agent, just like EDTA or DTPA. On one side, it links with a heavy metal. In this case, it's gallium. It can link with lutetium also. It can with any other heavy metal also. And on the other side, there is a linker molecule, which is, in this case, is a synthetic analog of somatostatin. It could be octreotide or octreotide. So DOTA is just one thing which link both link both.
So you can write anything.
No, there is difference in terms of the affinity to the receptor. There are 5 receptors, somatostatin receptors in the body, SSTR 1 to 5. The first DOTA which was get FDA approval is DOTA-TAT, sir, in 2016, and it has a very high affinity for SSTR2, and it is the most abundant receptor in the body. So then later on it comes DOTA-TOC in 2016, 18, and then DOTA-NOC. Now DOTA-NOC is having affinity for SSTR2, 3 and 5 as well. But the thing is that DOTA-TAT has highest affinity for receptor 2, which is nearly 9 times higher than other agents. Many other agents are also still coming which can link with even F18 cyclotron produce agent. Gallium is, we have got this handicap that we need a generator, and it is a costly affair, and it has to be maintained. F18 can be logistically easier, it can be purchased from somewhere outside agencies. Now the DOTA-TAT scan, ideally NET which are generally grade 1 or grade 2 should be subjected to DOTA-TAT scan. Grade 3 which are more less differentiated, they should be taken for FDG scan, which are more aggressive, and then FDG is the better modality for lesser differentiated tumors. But for grade 1 and grade 2, DOTA-TAT has to be utilized.
Okay. So after the pathologist sees and tells the grading, we send where we want. No.
Exactly, sir.
Okay.
Exactly.
He is not agreeing. So how will clarify that?
No, there are two things. First thing, to add on to what you have spoken, the gallium, the problem is it has a half-life 1 hour only. So you need a generator on site.
Yeah.
That's why there is now a copper-based tagging which is done. That has a half-life of 8 to 12 hours. So that could make a change. Like in Bhopal, I can get, as you do the PET scan, we can get the radionuclide material from outside. For till now, it's mainly India is more gallium. So that's why we need it on site, because it's only 1 hour. So you cannot do it other cities. So number 2, which I spoke, the point is what do you want to treat is going to dictate your investigations. How do you want to treat? Do you want to do a DOTA-based therapy on the upfront? Then I would like to do a DOTA scan at that point. And number 3, which I want to make the house very clear, is PET scan has a very nice indication. If something picks up on a PET scan, and my pathologists are given even a grade 1, I will believe that it is not going to respond to dotate therapy, because PET scan will not be hot on a patient who has a somatostatin receptor uptake. So that is how I take it now.
Very
Okay.
briefly now, we are running
Yeah,
out
sure.
of time.
For me, it's quite easy. For me, it is like the grade what the pathologist told helps me. I'll come to grade 3 first, and in that, beyond 55% of Ki67 and less than 55, it makes a difference in that chemotherapy. If it is more than 50 to 55 Ki67 advanced disease, we go for proper chemotherapy, that is as platinum and etoposide based. We treat it more like a small cell carcinoma. If it is less than, let's say grade 2 or a grade 3, which is below 50, although the data is not level 1, we go for oral capecitabine and temozolomide. The responses are very good and people do very nice. But for the grade 1s and those who are functioning or non-functioning, we go for octreotide based treatment, plus minus dotate based on what you want to practice. Yeah.
So, functioning and non-functioning, you say?
For functioning, there are only 3 drugs that are approved. Octreotide, lanetride. Lanetride is not available. Go for octreotide. The dose should be 20 to 30 milligrams depending upon what you do. The other symptom-based, there is one more drug which we don't have it. I am not sure. It starts with the telorestrat or something. Okay. So that is used when it's highly symptomatic. So that's a drug that's not available to my knowledge. So these are the way how we practice the functioning. For non-functioning, chemotherapy as per the grade, or you have sunitinib, which is also there, which you can always give in upfront.
Okay. Rajesh, we have the last set of questions and we will be brief. Various endoscopic techniques starting from banding, EMR, ESD, and for pancreatic entities, where do you use ablation?
So the role of endoscopic treatment is only G1, G2 lesion. 3 generally there is a surgical domain clearly. In 1 and 2, if they are accessible to endoscope, we do band ligation for the smaller G1 lesions. But if they are G1 to G2 lesions, we do ESD and EMR, the role is there. So as far as this is what the standard practice is, so all we are practicing and we assess these lesions properly. To that I said US is a must along with the cross-sectional imaging when we are planning endotherapy in these patients. As far as the role of US in pancreatic NET, so generally primarily it is in the domain of surgeons. But when the patient is surgically unfit or if this is not accessible, we had started doing radiofrequency ablation in these patients, US guided.
Both functioning and non-functioning.
Non-functioning, because these are the patients should be treated duodenal and pancreatic NET irrespective of functionality.
Yeah, because of the high incidence of. Dr. Salim, we have a metastatic lesion. We have a big primary, let's say in the pancreas, which is spread a little slow. What about debulking? We have heard a lot in NETs especially. Does it improve survival?
Sir, if it's a good if it's a good risk patient with a G1, G2 disease, we should think of debulking.
You should think.
We should think of debulking. If it's a G3 disease, it should be treated like an adenocarcinoma. It will not have much benefit, sir.
Yeah. So please, a message: debulking will improve survival.
Will improve survival in G1 and G2 disease.
Okay, Dr. Saw. Who is but we'll come to you, Dr. Sahu. Yeah, sure. Comment after that. Well, this is what I had written out based on this thing. Localized disease, small. When it is large, you have both options. Small means limited also. Regional spread, surgery probably is the best. Metastatic, I have written debulking. You are going to give me a different opinion. We come to PRRT and chemo a little shortly. Anuradha, on biopsy, can you very briefly tell me functioning, non-functioning, what are the markers you use?
So basically on morphology, we try to see whether it is well differentiated versus poorly differentiated. But you have to evaluate for insulinoma. You can do an IHC with insulin marker and evaluate serum markers. Second is the ampullary and the duodenal somatostatinomas. They also on biopsy show characteristic pseudomatous calcifications because there's a lot of calcium deposits. So once I see pseudomatous calcified bodies, it's a trigger that probably it's a secretory somatostatinoma tumor.
So you can make out.
So we can make out in these two particular conditions where there are additional features.
Thank you. Okay, Dr. Kapadia, many of us just know PRRT, peptide receptor, but very briefly what I have written, when indicated, what is the cost, how many sessions you need, what is the gap between the two sessions?
Sir.
Please listen to this. PRRT is advised for metastatic disease. When, how much, and the difference he is going to tell us.
PRRT stands for peptide receptor radionuclide therapy. Now this is a highly targeted therapy and very effective therapy for which is targeted towards somatostatin receptor, which are found abundantly in neuroendocrine tumors, cells of the neuroendocrine tumors. We need multiple sessions in 4 to 6 cycles of therapy. Each therapy is for 1 day, and it is an infusion of lutetium DOTA. Lutetium DOTA. Lutetium is an agent which is a beta emitter, and it is used for therapy. Gallium is an agent which emits, which is a PET agent, and it is used for imaging. So there is a difference between gallium DOTA and lutetium DOTA. The lutetium DOTA is specifically for therapy purpose. Other agent is yttrium-90 also, which can be used, which was used earlier also, and we are using now also. But the mainly we are using now is lutetium 177 DOTA.
How costly is it, Dr. Kapadia?
Sir, it has to be somewhere between 80,000 to 1 lakh rupees per session, sir.
So you need 6 sessions, so roughly 6 lakhs.
At least 4 to 6 sessions.
And
4 sessions, so at least mandatory.
And you give a gap of how much?
There should be a gap of around 2 months between the 2 sessions.
So please listen, 2 months gap, roughly 1 lakh of rupees. There are 2 different types. You heard it from the expert himself.
And then we need a radiological department ward.
Do you have it in Bhopal?
We have got a radiation ward in Bhopal, and we have had RSO also, which is mandatory requirement for this this kind of therapy. And it is an infusion which needs many other things other than this thing, sir.
You wanted to clarify something else, Dr. Sahu.
The first thing is for the dotate, I'll come down to that one. If it's most of patients are on octreotides, so they have to stop it at least 4 to 6 weeks before.
So
that's important. Yeah, long. All of them are long acting. So if it is short acting, 8 to 12 hours. The second point, you can start and restart the octreotide within 4 to 6 hours. That is the difference. I think people should know that you stop it once 4 to 6 weeks before, start 4 to 8 hours after the dotate therapy. For the metastatic part, I'll come to the questions first and then probably go for it. Which tumors respond best? I think as per the data set, the grade 3, especially more than 55%, they respond best to chemotherapy, because that is how the aggressiveness is, the KS is high. But even the more than 10 or 20, the temozolomide, capecitabine data is very good. And what is the 5-year survival?
Yeah, we have been taught it's a slow-growing tumor.
Yeah,
both.
so that's a grade 1.
Yeah.
That's why in grade 1, as Dr. Salim told, sometimes he doesn't operate. He gives a close observation as an option also if the patient is asymptomatic. So that's also a valid treatment. So we also do not want to give any adjuvant treatment for patients who are completely dissected. There's no data set. Last part. For the debulking, there is no bigger data set to tell you there is an overall survival advantage. It should be done on a case-to-case basis. Patient is symptomatic, you want to relieve the symptoms.
Individualized.
That is how the debulking should be advised, not for a survival benefit. That's the only last point.
So just one point, when a patient has a primary and a metastatic lesion, pathologist should always grade on the metastatic lesion because the grade is higher there and not on the primary.
My panelists have answered. Chairpersons, any comments from you? We are coming to the end of our time. We cut it down by 5 minutes, but any participation from the audience?
Hello, I'm audible.
Yes, please, any question to them? Or you feel
Yes, it's very well discussed. I have one just an I would like to add on for the postgraduates and for newcomers, like it has got the various names which you have told about the neuroendocrine tumors, neuroendocrine carcinoma, carcinoids. The term carcinoids is nowadays no longer recommended because it fails to convey the malignant potential which neuroendocrine tumors does have. So nowadays it is the grade 1 and 2 which are known as neuroendocrine tumors, and grade 3 which is poorly differentiated are known as neuroendocrine carcinomas.
Any?
Yes, sir.
Yes, SP.
Dr. Kapadia, to you. Since Dotanak has affinity to type 2 receptors, can we combine the different modalities to have a better diagnosis?
A cocktail, sir. Dotanok and Dotatate. Sir, we have got a cocktail of two radionuclides, yttrium and lutetium, because their penetrating powers are different. But as of now, both of them are not, NOC and Tate are not combined, sir. So we can mix the radionuclide parts, yttrium 90 and lutetium 177, sir.
But that's not going to help you. For the diagnosis, if you have more of receptor 3 or receptor 1, then you need a cocktail of the DOTA.
I think that we'll discuss later.
Later on, sir.
Pramod, anything from you? Anything for the postgraduates are supposed to ask this. This is meant as a teaching. In fact, Sanjay was very clear that the postgraduate should be taught. So anything, otherwise we will close the session. I'd like to thank all of you for the wonderful discussion. And can I have my last slide, please? Because I want to welcome you for the Endocon also. I think my slide. Well, we have an Endocon coming in September, and I'd like to invite all of you to Hyderabad. Please block the dates. If my slides are there, you will see the dates.
19 to 21st, no?
19 to 21st September. That was the last. Thank you, slide. Thank you very much. Thank you very much, sir. Thank you, and thank you for your participation.
Thank you, esteemed faculties, for this discussion. Please come to the center of the stage for the group photograph. Now, for the next session, the topic of discussion is approach to incidental SOL in pancreas. May I please invite upon stage the chairpersons for this session, Dr. Sunil Jain, Senior Gastroenterologist and Interventional Endoscopist from Indore, Dr. Ravindra Kale, Senior Gastroenterologist from Indore, and Dr. Saurabh Dubey, Consultant Gastrointestinal Surgeon from Bhopal.
Good morning. Our next talk is on incidental pancreatic SOL, what to do, and it is it will be delivered by Professor Pramod Garg. He is in AIMS, Executive Director, Associate Dean, and everyone of the audience knows him.
Good afternoon. At the outset, I'd like to thank Dr. Sanjay Kumar, the organizing chairman, for this kind invitation. I'm going to talk about an approach to an incidental space-occupying lesion in the pancreas, also known as incidentaloma of the pancreas. Now, by definition, a lesion like this should be picked up on imaging, which is done either as a routine investigations, which is kind of fashionable nowadays, or the investigation has been done for some other indication and the patient is asymptomatic, at least as far as that lesion is concerned. And we have to also differentiate space occupying from diffusely enlarged pancreas. For example, you see here, it's a diffusely enlarged pancreas, and here you see there is a space occupying lesion. So that's the difference. Now, in general, if you have a space occupying lesion anywhere in the body, particularly in the pancreas, we should take it as neoplastic unless proved otherwise. And the reason for that is that if you miss a neoplastic lesion, you will have more severe consequences if you don't consider it as neoplastic. It is either malignant or benign. If you have a benign lesion, it could be benign neoplastic, but sometimes you do see infectious lesions, but they are very, very uncommon. Another important thing we have to find out when you have a space occupying lesion, whether the lesion is solid or cystic, and this has major implications for the diagnosis, treatment, and prognosis. And third, sometimes you have a solid lesion with cystic degeneration. When we have to approach these patients in whom you have found a space occupying lesion, the important factors to consider to make the diagnosis and also treatment are age of the patient, sex of the patient, comorbid conditions, for example, underlying diabetes, and whether the lesion has been picked up de novo or there is an underlying disease, for example, chronic pancreatitis, or patients has had, say, for example, acute pancreatitis in the past. That has a major bearing on the final diagnosis. And then you characterize the lesion on imaging, which I'll come to subsequently. So there are three common types of lesion. One is pancreatic ductal adenocarcinoma, second is cystic neoplasm, and third is neuroendocrine tumor, about which you had a very nice panel discussion just now. And the other we often see is autoimmune pancreatitis and sometimes infections, but my focus would be on pancreatic ductal adenocarcinoma and cystic neoplasm because neuroendocrine tumor has been recently discussed. And there are some other rare tumors I'm not going to discuss at all, nor will I ask you to read this. These are primarily histological curiosities which are found on surgically resected specimens. You can't really make a diagnosis on clinical or imaging criteria. Coming to the incidental pancreatic ductal adenocarcinoma, it is rarely incidental because nowhere in the world there is a screening protocol. So it is very difficult to pick up small incidental pancreatic ductal adenocarcinoma. By the time they are picked up, most are symptomatic. Their characteristics are that patient is usually elderly, beyond the age of 60 years, and maybe diabetic. The lesion is solid, and the characteristic finding here is that the duct upstream is dilated. So wherever is the lesion, if you find the duct is dilated, be very, very careful. This patient needs your attention right away. And this is a classic example. If you see here, very subtle dilatation of the distal, in the tail of the pancreas, duct is dilated, and there is a very subtle small lesion here. Take it as ductal adenocarcinoma unless proved otherwise. You can do further test, for example, PET-CT or EUS to confirm it, but generally speaking, FNA is not going to help you because of one reason, that if you do FNA, the sensitivity of FNA is at best 90%. You are going to miss 10% of those patients. And even if it turns out to be benign on surgery, it is okay. You have done a reasonably good surgical procedure. You don't have to worry whether it is benign ultimately. In fact, the patient and the surgeon will be happy that the lesion has turned out to be benign rather than malignant. Overall, if you look at solid pancreatic SOLs diagnosed incidentally, it's about 0.6% according to one series in healthy kidney donors. In a series of about 3,000 patients, people who had undergone PET-CT for unrelated causes, about 0.5% had a pancreatic SOL. And this is a very large series, about 40,000 PET-CT done for cancer screening in Japan. The incidence of pancreatic ductal adenocarcinoma was only 0.001%, which is somewhat similar to the incidence of pancreatic ductal carcinoma. So it's not very common to have solid lesions on incidental imaging. If you look at the series of resected lesions, that those lesions which have been resected by surgeons, you find that solid lesions are 31 to 65%. So majority of solid lesions are actually resected, and of these, you have about 1/3 ductal adenocarcinoma, and about 1/4 to 1/3 will be neuroendocrine tumor, and then you have other rare causes. And sometimes focal chronic pancreatitis is also found to have on surgery, which is a mass-forming inflammatory lesion. Now, what is the impact of outcome if you find a lesion on imaging and patient undergoes treatment? So overall tumor resectability is better if you find an incidental lesion versus those who have symptomatic, which is kind of logical. Median survival somewhat better, but you see here in this series, it was only 16 months. The reason for that is a pancreatic ductal adenocarcinoma is a very, very aggressive tumor. And the lymph node involvement was also similar, which is rather surprising. And same for another series of about 1,800 Whipples, they found stage 1, which were kind of picked up incidentally. 34% patients had stage 1 tumor, and the overall 5-year survival was about 50% better than those who had symptomatic disease. This is just an example of a patient came to us, 75-year-old male, incidentally picked up a small lesion in the neck of pancreas. PET CT was done, which confirmed a positive lesion about 1.4 centimeter. We advised surgery. He didn't agree for that, and 2 years later developed unresectable tumor. The reason I'm showing you this particular example is that whenever you have lesion, please discuss with your patient very carefully and say that why it is so important for these patients to undergo surgery, because then you can have kind of a curative resection. The other issue is when you have a underlying chronic pancreatitis, patient comes to you either with symptom or without symptoms, and you do investigations, you find a space occupying lesion there. It is likely to be malignant if there are two things. One, it is idiopathic chronic pancreatitis, and you have a mass lesion, it is likely to be malignant. And second, if there is a new onset of pain for a few months, consider malignancy very strongly, okay? Now, it is likely to be inflammatory if you have a patient with alcoholic CP who comes in with history of 1 or 2 years of pain. There is diffuse enlargement of the head of pancreas rather than a discrete mass, or you find that the pancreatic duct is coursing through the lesion. So these are the two characteristics on imaging: diffusely enlarged head of pancreas or a duct coursing through the head. It is likely to be inflammatory, and the etiology of CP is alcoholic. This is what has come out from our studies. And this is an example of a patient who had chronic pancreatitis, came with new onset of pain, and was found to have a suspicious lesion in the head of pancreas. You can see here, there are calcification and there is a soft tissue mass there. Sometimes difficult to identify what it is. So often in these patients, you should do FNA to confirm. But if you are sure about the mass lesion, you don't have to do FNA. You can directly send the patient for surgery. In this particular patient, FNA was done, and also a contrast-enhanced EUS was done. This is a video given by my colleague, Dr. Soma Jagannath. He does a lot of these interventional and diagnostic EUS. I'm going to skip PNET because we have discussed this. Now coming to the second variety, that is cystic tumors. So that means the lesion is cystic on appearance on imaging. The incidence actually seems to, prevalence seems to be actually fairly high. It varies from 1 to 24%. Now that depends on the kind of imaging that has been done. That also depends on the age of the population where this has been done. So, but it's fairly common to have on CT or MR a cystic lesion. There are three main types: serous cystadenoma, mucinous cystic neoplasm, and intraductal papillary mucinous tumor. And these are other things which can confuse you with cystic neoplasm. This is a kind of standard patient, middle-aged lady comes to you with non-specific abdominal pain, no other problem, no antecedent pancreatitis. That's very important. And you find a lesion on the in the tail of the pancreas or distal body, and the diagnosis here is either a cystic neoplasm or pseudocyst. If you have this kind of lesion, only about 2 centimeter lesion, there is nothing inside, it is likely to be a benign mucinous cystic neoplasm. Often the issue is whether it is a pseudocyst following acute pancreatitis or is a cystic neoplasm. The best test to tell you that is the first imaging when the patient had any symptom. If at the time of first imaging, whether you have an ultrasound or a CT or MR, it shows a cystic lesion, it is likely to be a cystic neoplasm. If the first imaging didn't show it and subsequently you find it, it is likely to be a pseudocyst. Very simple, okay? And then, of course, there are many other features which can be found on CT and MR between pseudocyst and cystic neoplasm. Cyst fluid analysis, I'll come to that, generally not very helpful, but if you do it, you find in cystic neoplasm, primarily you are looking at mucin. If mucin is present, it is either MCN or IPMN and not a pseudocyst. So just a brief description of these three types. Serous cyst adenoma seen in elderly females, 6 and 7 decades of life. More than 50% are asymptomatic. Symptoms include abdominal pain, mass lesion, or sometimes even jaundice. The characteristic imaging findings are it is microcystic, there is no communication with pancreatic duct, and a stellate scar may be seen, which may be calcified also, a classical example of serous cyst adenoma on a CT, and on EUS you find microcystic appearance. Fortunately, these are very slow growing tumor, and the potential of malignancy is very low, and they usually do not require surgical resection. You can just follow them up over a period of time. Mucinous cystic neoplasm are seen in middle-aged ladies. Location is generally in the body and tail of pancreas. They may present with pain or diabetes or antecedent or presentation with pancreatitis, but incidentally they are detected in about a quarter of patients. The characteristic features here are macrocystic appearance, no communication with PD. This is very, very important. And on histology, you find ovarian stroma, and the risk of malignancy is about 17% according to one series, but it varies on the type and the size of the lesion. CT and MR are good modalities to differentiate and diagnose mucinous versus non-mucinous, but the overall diagnostic accuracy is around 80% between mucinous and non-mucinous tumors. And therein comes the role of EUS, because most patients with cystic neoplasm will require a diagnostic endoscopic ultrasound, and there you may, I will come to that, you may do a fluid analysis to find if there is a mucin, if there is mucin present, string test is positive, amylase is normal, CA may be high, and this test has come up recently that the glucose content is low, it is likely to be a mucinous tumor with a very high sensitivity. But overall fluid diagnostic accuracy varies from 40 to 60%. So the imaging characteristics are more important. So you have a lady like this, she has a 2 centimeter lesion in the distal body of the pancreas, there is nothing inside. It's a benign MCN, 2 centimeter, asymptomatic, do nothing, just follow up, okay? On the other hand, you may have a patient like this, where the lesion again is not very large, it's about 2 centimeter, not seen very well, but you can see here that there is a intramural nodule here, there are septae here, which are enhancing on CT, and this is a MCN with high risk features, and these patients would require surgery. This is another video given by Soumya, done recently, of a patient with mucinous cystic neoplasm. You note here multiple thick septae here, and there is a solid looking lesion here, and he did a contrast enhanced EUS. You find this is the lesion, and the lesion lights up, the solid part lights up on contrast. That means we are dealing with a very high risk MCN here, and these patients would require surgical resection. Generally, they are benign, may progress to malignancy, and surveillance is justified in these patients, but less than 3 centimeters benign, you should observe. Coming to the third type, that is IPMN, they arise from the duct filled with mucin. They communicate with PD. That's again important differentiating feature, and about 30% may have asymptomatic. Main duct lesions are seen 47 to 75%. They are usually symptomatic. Side branch IPMN are generally asymptomatic, seen about 25 to 39%. The duct is dilated in main duct IPMN, and that is what differentiates between the two tumors. So this is branch duct, this is main duct, and this is a mixed type. Location is usually in the head of pancreas. MRI and EUS again very useful. Sometimes you may see in a main duct IPMN fish mouth papilla from which you can see mucin coming out. This is a classical example of a branch duct IPMN, about 3 centimeters in size. This is classical example of a main duct IPMN with solid mass inside. And this is what the classical fish mouth appearance is. I have only seen it once, and that's a video I keep showing all the time, and that you have a fish mouth appearance of a papilla, and you can see this mucin coming out. Then it is diagnostic of IPMN. A malignant potential in both MCN and IPN increases with the size of the lesion, and there are many guidelines available. This is the Fukuoka guidelines commonly followed, that you may have worrisome features and you have high-risk features, depending on which you can consider surgery. Generally in IPMN, if it is branched at less than 3 centimeter, no surgery is required. May induct, malignancy risk is high, and you should advise surgery in these patients. Prognosis generally is good. One word about FNA. Generally, people tend to do FNA, but there are pros and cons of it. Fluid analysis has 60% diagnostic accuracy. You can do molecular markers, but there's a risk of infection and also pancreatitis. And it should be done only when you are not sure if there is a solid lesion within this cyst, and there's a clinical doubt of, strong doubt of pseudocyst. So these are the 3 main types in summary. So the approach to incidental SOL in the pancreas on imaging, that is CT generally is the first test. You may have either solid lesion or a cystic lesion. If it is a solid lesion, do an EUS, sometimes FNA, not always. If there's a suspicion of NET, you can do FNA, otherwise generally no. You may or may not do MRI, but solid lesion, generally there is a need for surgery. If it's a cystic lesion, you do MRI for sure, and also you do EUS in almost all cases. And if it's less than 3 centimeters, no worrisome features, benign, follow up. But if you have high risk features, then consider surgery. If you have worrisome features, you may do EUS and FNA. And if it's a more than 3 centimeter lesion with either worrisome or high risk features, these patients require surgery. So I'd like to summarize, ladies and gentlemen, by saying that there is increasing awareness of SOLs in the pancreas because of widely available and routinely practiced CT and MRI in these patients. Solid lesions are uncommon, but more likely to be malignant and requires more often surgical resection. Cystic lesions, either serous adenoma or MCN or IPMN, they are usually benign. EUS is helpful in the diagnosis. Less than 3 centimeters, we follow up and do nothing. More than 3 centimeter, large or symptomatic lesions require surgery. Thank you for kind attention. Happy to take questions.
Pramod, I wanted to ask, see, if you look at all the guidelines, like Fukuoka is there, you have AGA guidelines, and of course, Indian Pancreatic Association, there is one area where they all differ, and that is regarding the surveillance intervals. So what policy you follow if you want to follow these particular patients, or how long will you continue with surveillance in this?
I think we can't really have a definite guideline. It has to depend on multiple factors. One is, how is the patient? What's the age? Are there comorbid conditions? For example, a patient 75-year-old come, and on incidental finding, you have a 2 centimeter lesion in the pancreas. What are the comorbid conditions? So I'll do the first imaging. I'll see whether it is benign looking, and I can ask the patient to come back 3 years later for another surveillance. On the other hand, you have a 45 or a 50-year-old lady, has a 3 centimeter lesion, otherwise well, I would say she would probably require surgery in some period of time. There, your frequency of surveillance may be earlier. So first imaging you do today, everything is okay, call after 3 years, everything is fine, you find how the size of the lesion is increasing. If it is very slow or not increasing, 5 years later. So I think it has to be individualized. You can have 1 year, 3 years, 5 years, but can't be having definite guidelines.
Sir, my question is regarding US, and you mentioned plus minus FNA, but quite often the observation is that there is a solid lesion which is imminently resectable, maybe more than 3 centimeter. US has been done, and then an FNA has also been done, and then the relative would invariably say, sir, wo report to biopsy report to negative.
I wouldn't do FNA. I would go for surgery. If the patient is operable, lesion resectable, take it out. Physicians have to think like surgeons.
Sir, I will like to add, actually it was very vast topic you were given. It was not easy to cover all the different kinds of lesions, and there are different guidelines, completely different for different kind of lesions, solid, cystic as well. So I will just like to make few points here. In the cystic, regarding the cystic neoplasm, you have generalized most on the basis of the size of the lesion. I will strongly differ there from the surgeon point of view and based on the current recommendations. Mucinous neoplasm, you mentioned less than 3 centimeter, wait and watch. I will strongly differ. Current guidelines say mucinous neoplasms have significant neoplastic potential. So in all cases, whenever the patient is fit for surgery and mucinous neoplasm we are suspecting, we will go for surgery. The type of surgery and the extent of surgery will differ, and the location of the tumor. If there is a young patient and mucinous neoplasm even less than 3 centimeter in the tail of pancreas, I will go for a simple resection. I may not remove the spleen and the lymph nodes along with that. Same patient, 4 centimeter tumor, I will do pancreaticosplenectomy, distal pancreaticosplenectomy. Wait and watch approach no longer stays correct for mucinous neoplasms. That is only for serous neoplasm nowadays. And there too, we have to watch the increase in the size. More than 5 mm per year is indication for surgery. And one more point I will like to make, initially in the slides you mentioned PET scan. So I will differ there again. In pancreatic SOLs, PET CT is no longer recommended first line of imaging. It is the kind of last resort. Always we have to start with triple phase CT scan for any pancreatic lesion, and that triple phase is different from what triple phase we do for liver. Pancreatic protocol triple phase is entirely different, and that is the most commonly missed thing which we see in the clinical practice. Many patients come from CT done outside, they say it is a triple phase scan, we don't see any tumor, we wait and watch, later they come with recurrence. The problem there is the routine triple phase scan is taken in arterial, venous and delayed venous phase, but for pancreatic tumors we need delayed arterial phase, which is pancreas protocol. So any pancreatic SOL, which were incidental tumor which we are talking about, incidental tumors are those tumors which are missed in routine CTs, but if that patient has undergone a specific pancreas protocol CT, that tumor would not have been missed. So that will come under the ideal incidental pancreatic tumor. So that I will like to add.
So this time will not be counted in my time. So I don't differ with him, I'll send my patients to him.
It's a great talk, sir. I have a small question. So if patients are symptomatic and have main duct IPMN, they are symptomatic with pain or recurrent acute pancreatitis, and you find these lesions, and they fit into 2.5-3 centimeter cyst with 8 mm MPD in the head, but the distal MPD is not dilated, and there is no evidence of chronic pancreatitis. So would you just go for a surveillance, or would you just say go ahead and get this?
So if I understand correctly, you're saying there is a lesion in the head, the duct is dilated, not distally.
Not distally.
So it's kind of a mixed time, or I would say that patient is operable. My preference would be surgery.
Surgery.
Yeah.
Thank you, sir.
Rajesh.
Last question. So cystic lesion, we always correct in absence of, because we commonly see cystic lesion in US. If there is a cystic lesion in absence of history of pancreatitis or previous imaging generally is not available, would you recommend aspiration in those patients, because that a characteristic of the fluid determines whether there is mucinous or non-mucinous cyst?
If my decision is not to operate, I probably wouldn't put in a needle. I would follow up. If for some reason I think this patient should undergo surgery, then I will put in a needle.
Younger patients?
No, that's what I'm saying. So overall patient's condition is such that I want to operate, right? I'll put a needle if I'm not sure. Otherwise, I will wait. I'll just follow up.
Thank you, sir, for such an interactive talk on pancreatic SOL. For further queries, you can obviously meet sir during the lunch period. I will request the sir and chairpersons to join at the center of the stage for the photograph. And now we move on to our next topic, which is clinical vignettes in GI and liver cancer, a case-based panel discussion. I would like to invite the moderator, Dr. Manu Wadhwa, on the stage. The panelists for the session are Dr. Simi Dubey from Bhopal, Dr. H.P. Yadav sir from Indore, Dr. Shefali Bansal from Bhopal, and Dr. Mohammad Tala Noor from Indore.
Good afternoon. So let me welcome my eminent and very learned panel.
Manav, can I just take a minute? All the PGs who have presented posters, the judges have gone there. They can go to the poster area. Thank you.
All right. So, I've been asked to talk about liver abnormalities and GI cancers as in clinical cases. I have a very learned panel with me. So my job is very simple. I'm going to put up some clinical cases and let the panel do all the discussion. I would welcome the audience to ask questions in between if they have any queries rather than waiting till the end. So before I go to the cases, just a brief background. When we look at liver function tests, we are not looking at bilirubins, ASTs, ALT. We are looking at classifying the nature of injury which the liver has undergone. So we can broadly categorize liver function tests into 4 categories. So I would consider tests which assess liver cell injury, which is primarily bilirubin, AST, ALT, test for detecting cholestasis, where gamma GT and alkaline phosphatase come into picture. You have synthetic function tests, which primarily are albumin and bilirubin, but here I would like to mention that platelet count becomes a very important liver function test. Now it's not exactly a synthetic liver function test, but it tells you about portal hypertension. So in your clinical practice, the moment you see a low platelet count, your mind as a gastroenterologist should think that does the patient have a liver disease or a portal hypertension or not. So, and finally, albumin and prothrombin time, which actually indicate the liver synthetic functions. Liver morphology tests also are a part of liver function tests. So your cross-sectional imaging like CT, MR, fibroscan, ultrasounds are also a part of liver function testing. So with that background, let's straight away move to the cases. So we come to case number 1. 40-year-old gentleman, anorexia, nausea, vomiting and jaundice for 10 to 15 days. No past history of jaundice, no blood transfusions, no surgery. Now this guy has been taking regular alcohol for last 15 years. Almost 3 drinks a day. There is no other history of any other drug intake, allopathic, Ayurvedic, Unani, or any complementary alternative medications. On examination, he has icterus. He has a 3 centimeter soft hepatomegaly, no spleen, no free fluid. This is a liver profile. Bilirubin of 7.8, SGOT or AST of 564, ALT of 808. Gamma GT is mildly raised, albumin is 3.6, platelet count is normal. So let's start with Dr. Shefali. Dr. Shefali, I've just listed out the diagnosis. What would you consider as the first diagnosis, sir, and why?
Sir, I would like to dissect out all the options that you have given. Considering the history of alcohol hepatitis just does come to the mind. But when we look at the ratio between AST and ALT, then there has to be a ratio of 2:1 in patients of alcoholic hepatitis, which is not there in this case. The second thing is, when there is alcoholic hepatitis, usually the enzyme levels do not exceed 500. Here they are gone up. So, though alcohol is there in one of the options, I would still keep it much lower down. My first option would be acute viral hepatitis in this patient, considering the prodromal phase of symptoms that he has had, followed by icterus, followed by tender hepatomegaly, where there is a rise in the liver enzymes, where the SGPT is much more than the SGOT. So my consideration would be viral hepatitis. As for the drugs, you have clearly mentioned that there is no history of any drug intake. So again, that goes down.
So let's be, I'm reiterating what Dr. Shefali has told us. AST-ALT ratio is probably the most important factor which speaks against alcoholic hepatitis here. Your AST is usually more than 1.5 times the ALT. Here is the other way around. So AST-ALT ratio defines alcoholic hepatitis and cirrhosis. So even with this kind of liver enzyme picture, it is unlikely to be cirrhosis. And this patient anyway had a soft hepatomegaly, so cirrhosis is very less likely. So this is something which I thought I must highlight. The moment you see a level of AST, ALT more than 10 to 20 times upper limit normal, there are only few differentials. You literally rule out almost all causes except these 3-4. So acute viral hepatitis is 1, drug-induced liver injury is 2nd, and 3rd is acute ischemic hepatitis, which you often see in post-operative patients. Somebody has hypotension, you get a referral from a cardiology unit for deranged liver functions. You see enzymes in the range of thousands. So that's a setting. This patient does not have that setting, but acute viral hepatitis is what this patient had. So the first take-home message is, Not all patients with chronic alcohol intake and jaundice have alcoholic liver disease. So kindly remember that just because the patient is taking 3 drinks a day does not mean that he has alcoholic hepatitis. You need to see other factors. Alcoholics are actually as prone or maybe more prone to have other liver diseases than a usual patient who has a normal liver, and drug history should be taken in all patients. Second case, this is a longer one, and this has a lot of messages. I'll just describe the case and then we move on to the panel. So 43-year-old obese diabetic, this is a guy you will see every day in your OPD. Absolutely asymptomatic. On executive health check, you see a raised AST/ALT, and he comes to you for follow-up. Otherwise, he doesn't have any symptoms. There is no significant past history. There is no alcohol intake. And that's the profile. Bilirubin of 1, AST 128, ALT 90, gamma GT 2 times raised, albumin slightly low, and platelet count 90,000. We do an ultrasound which shows grade 2 fatty liver, portal vein of 10 millimeter, there is no spleen. Dr. Yadav, what would you think about and how would you proceed in this case?
Here we have an obese diabetic patient, mildly raised SGOT, SGPT, and no other significant history. So here there are few differential diagnoses. Obviously the patient is obese diabetic. We should consider fatty liver disease, NAS. And before labeling any patient with NAS, we should consider other causes also, like chronic viral hepatitis, hepatitis B, hep C. They can also cause similar mildly raised asymptomatic enzymes. And other things are drugs. And when we talk about the drugs, the patient is diabetic, may be taking some drugs. And other than this, it's important today's practices. The patient might be taking some healthy juices and some multivitamin containing other than some Ayurvedic preparations also. So we should ask about all those things, because this type of can be seen in many conditions. So important are drugs, NAS, chronic viral hepatitis. These are the important causes. Other than that, some less common causes, like the patient is younger one, then can have Wilson's disease, female, then obviously autoimmune is less likely because usually they are symptomatic.
So Dr. Yadav is trying to tell you that just a fatty liver on ultrasound does not preclude other investigation for the cause of liver disease. You still need to rule out hepatitis B and C. Of course, you've already asked about alcohol. You still need to do autoimmune markers. This is a guy who has significant liver disease, right? So your workup has to be complete in the evaluation of this patient as an etiology. And once you rule out others, then you rule in a diagnosis of what we call MESLD or NASH these days. So the viral markers in this guy were negative, hepatitis B and C. He had a dyslipidemia. So another very important thing, investigating a fatty liver, you have to look at the metabolic profile. You have to look at dyslipidemias, you have to look at fasting blood sugar and HbA1c. So you actually may find a normal sugar but HbA1c of 6.5. That also is an indication that this guy probably has a metabolic syndrome predisposing to the liver disease. So non-alcoholic fatty liver disease. Dr. Simi, would you stop here or would you do anything else? You have a diagnosis, you have ruled out all other etiologies. This guy has fatty liver disease. Would you start treatment for the metabolic syndrome or would you like to do something else for this patient?
No, definitely. We are not going to stop here, and we have to find out at what stage is this non-alcoholic fatty liver disease is. And for that, we have to go with certain other tests also. It includes invasive or non-invasive tests. And now recently we are OPD test which is available non-invasive, that is the FibroScan, and we definitely go for it. And this procedure actually takes very little time and give us an idea what is the stage of non-alcoholic fatty liver disease and what is the stage of fibrosis in this patient, at what stage it is, so that we can further plan the management of these patients.
So any patient who has significant liver disease, FibroScan has actually become stethoscope of gastroenterologists. So we would do FibroScan for every single patient with a suspected chronic liver disease. I'm not talking about acute viral hepatitis here because there it will be fallaciously high. But wherever you suspect a chronic liver disease, cirrhosis or no cirrhosis, you want to do a FibroScan to assess the degree of fibrosis in this patient. Previously we used to do liver biopsy, but that's actually defunct these days. We nowadays don't do a liver biopsy for assessment of extent of disease.
Mano, any level of bilirubin where you feel that FibroScan may be faulty?
So anything above 2.5, probably FibroScan is going to give you a very high value. Similarly, AST, ALT value above 150 or 200, fibroscan is going to be fallaciously high. So you should limit your fibroscans in a patient who does not have jaundice and ASTs are below 150, 200. So we did a fibroscan. The fibroscan came as 36 kilopascals. Remember, this guy has a AST of 120 and bilirubin of 1. So this is likely to be a true value, not a falsely high value. We did do a liver biopsy. In this case, this is an older case which I am discussing. Nowadays, we have stopped doing biopsies with the more and more experience in, more and more confidence in assessment of fibrosis by fibroscan. The biopsy confirmed the presence of cirrhosis. So this is a NASH-related cirrhosis which is compensated. Dr. Noor, what do we do now? Any more investigations, or we tell the patient start treatment and go home?
So at this stage, once we have confirmed the presence of cirrhosis, then we need to screen for varices, because many of these patients can have significant large varices. They can be, so if they have large varices, then portal hypertension reducing agents can be added, beta blockers. And at the same time, it is very important to rule out SCC in this patient, because some of these patients can harbor, so we have to do alpha-fetoprotein levels, and if they are raised, then doing a triple phase CT scan at the time of diagnosis is also important to rule out SCC.
So two very important points Dr. Noor has raised. Please remember, if it is not cirrhosis, your evaluation stops here. You don't need an endoscopy, you don't need any further imaging, you already have ultrasound with you. But if you diagnose cirrhosis, it is mandatory to screen for varices because your treatment changes. Lower risk varices, you add a beta blocker. Higher risk varices, you do a banding and a beta blocker. So your management now depends on whether the patient has portal hypertension or not. Secondly, cirrhotics have a high risk of HCC, so you also screen for hepatocellular carcinoma. Now I want to initiate the audience to this new concept of an abbreviated MRI. Nowadays, we understand that ultrasound is not a good investigation to screen for HCC. We also understand that contrast CTs and contrast MRs are expensive and you need to give contrast, which itself can cause problems. Now, there is more and more literature and more people are doing abbreviated MRI. Now, this is a very limited number of sequences you do. You don't give contrast. You only ask for 3 imaging, T1 weighted, T2 weighted, and diffusion weighted. And based on that, it gives you a much better sensitivity of HCC as compared to an ultrasound. If your abbreviated MRI is normal, that means no suspicion of a nodule, you don't need to do a contrast imaging. The cost would be 1/4 or 1/5 of the regular MRI because the total time it takes is 10 minutes. You're not giving contrast, you're not taking extra time on the MRI console. So please ask your radiologist, if it is not done at your place, kindly start doing it. It is slightly more expensive than an ultrasound, but much better information is provided by abbreviated MRI.
One clarification, we'll be doing CT or abbreviated MRI in all patients who have cirrhosis, irrespective of alpha-fetoprotein, I think.
Yes, sir. So I'm not talking about CT here. CT without contrast will not give you information, and you don't want to give radiation also to this patient. There was a debate whether you actually want to do a cross-sectional imaging with contrast or not in a patient where you have a low index of suspicion. With the abbreviated MRI, the things are changing. It is still not in protocol, but that's what most of us are doing now. Abbreviated MR, no radiation, no contrast, 10 minutes job, twice as expensive as the ultrasound. So your ultrasound would cost you 500, 700 rupees. This will cost you 1,000, 1,500 if you're doing enough volumes.
Sorry. But AFP doesn't come in algorithm. That is what I am highlighting.
No, AFP is always done.
No, it is done, but irrespective of whether it is normal or raised, you will do imaging.
Absolutely. Why? Because alpha-fetoprotein is positive in only 25 to 40% of small tumors. 3/4 of the small tumors will have a normal alpha-fetoprotein.
The sensitivity of abbreviated MR is equivalent to triple phase CT.
Sensitivity and specificity are two different things. So sensitivity is as much as a cross-sectional imaging. The specificity is not. So it will even pick up regenerative nodules and tell you this is suspicion. You still need to confirm with a triple phase CT, but in 90% of cases, you will save a cross-sectional imaging in these patients. You understand what I'm trying to say? Yeah. So a lesion, if there is no lesion, no suspicious lesion, you don't need a cross-sectional imaging. And that will be true for 90. So what ultrasound does for you, abbreviated MR does better.
So there was a,
Can I come in?
Yeah, Ashish.
As per his question about sensitivity and specificity, there was a large study done at PGI Chandigarh where they showed that sensitivity is more than 98%.
Yeah, 98%.
And specificity was 100%. So very good modality.
Yeah.
But only thing that most of the radiologists are not tuned to it. They need to know how it is done.
So, I would urge all of you to go back to your radiologist and ask them to read about abbreviated MRI. That is the new concept of screening for HCC without increasing much cost here. So we did screen this guy for HCC, and as luck would have it, he had a 2 centimeter lesion in the right lobe of liver.
Mano, I have 3 issues.
Sir.
One thing, we have already incorporated fibroscan because it is done left and right in India. But
Right,
what
sir.
about some non-invasive markers like FIB4, which have been included in the algorithm a step ahead of LSM? It is much cheaper to do also, but people are not doing it. Second is utilizing Bovino 7 criteria for using LSM to decide when to start beta blockers. There was a time when for pre-primary prophylaxis, that means where patients do not have varices, we never give beta blockers. But now in this situation, those patients who do not have varices may still have that particular LSM criteria which says that, well, it is high. So should we start beta blockers at that point of time?
So next time you have to give me 1 hour for this presentation, then I'll discuss all these issues, sir. The point you are raising is absolutely fine,
And
sir.
third is 20% of the patients who have NFLD develop HCC without developing cirrhosis. Do we
Exactly,
have
sir.
any surveillance guidelines for those situations?
So very important questions. As I told you, I need more time for this. I'll only answer the third question here, sir. It is very well known that today the commonest cause of HCC in a non-cirrhotic patient is NAFLD, not hepatitis B, because hepatitis B is already under control, reasonably under control. We cannot have surveillance guidelines because we don't have enough data to say when to do it. And if you include or NAFLD patients, then you will be screening 50% of your population. In urban cities, 50% of population has NAFLD. So it's not feasible, and we don't have literature to support, as of now, the screening. Let's move on. So this patient, asymptomatic, comes to your OPD and turns out to have a HCC. Can you predict this based on the investigations, the first investigation you saw? So this guy, let me take you back to the LFT which we saw. I will draw your attention to 3 facts here. Look at the ratio of AST-ALT. So Dr. Shefali in the last case told us that AST-ALT ratio is a predictor of alcoholic liver disease. I told you it also predicts cirrhosis. Here the AST is more than ALT. The ratio is almost 1.5, 1.4. Secondly, albumin is on the lower side. Thirdly, platelet count is low. So this LFT and platelet count actually gave you an idea that you may be dealing with a cirrhosis with portal hypertension. So if you carefully look at the liver function test, more often than not, on the first visit, you will be able to counsel the patient, boss, ye investigation mein karne wala hu aapki, provided that these things come out positive. So that's one important thing to remember. So from case 2, the take-home message is NAFLD and NASH may not be as innocuous as it initially might seem to appear. You can have cirrhosis in significant number of patients, and many of these guys actually have HCC. If you have any doubt about presence of advanced liver disease, even in an asymptomatic individual, please get a fibroscan. Biopsy, I would not advise to do now, but fibroscan is mandatory for evaluation of any patient who has suspected chronic liver disease. Secondly, thirdly, endoscopy and HCC if you diagnose cirrhosis. If the patient only has advanced fibrosis, no cirrhosis, you do not do endoscopy or a abbreviated MRI. Let's move on to case number 3. We have 11 more minutes. I think we should be able to cover all our cases. So this is an internal medicine case, ma'am. 61-year-old male presented with pain abdomen for 2 months, gave a history of shortness of breath on exertion, no alcohol, no history of jaundice, no nausea, no hematuria, no melena. And this is an investigation profile. Hemoglobin comes as 5.8. That explains the shortness of breath. TLC is normal, platelets are normal, LFTs are almost normal except slightly raised gamma GT, and albumin is 3.4. What do you want to do next, ma'am? Anemia with pain abdomen.
We have to evaluate anemia in an elderly male, 60 plus. 60 plus presenting with anemia for the first time, the first thing which comes to my mind is to rule out a GI malignancy. I would advise a upper GI and a lower GI scopy. in addition to the routine investigations which you have said before the invasive procedure?
So this is a patient who gives no history of melena.
And sir, even you have said, yes, so there's no history of melena, no history suggestive of a GI bleed. I would like to go for the routine investigations before.
Exactly. So,
and type the anemia.
Type the anemia. So
Type
most
the
important thing here would be to type the anemia first. Look at the peripheral smear. So single most important investigation which we forget to do as a specialist is a peripheral smear. We see a CBC, we don't look at the MCVs, we don't see a peripheral smear. Please remember to look at peripheral smear. The information which you get from a liver function test in a liver disease patient, similar information you get in anemia in a patient who has from a peripheral smear. So it's a very important investigation. So we did a peripheral smear, we did a retic count, we did a B12 level, we did serum iron levels. We also checked for stool occult blood and a ultrasound. And this is what we find. Dimorphic anemia with hypochromasia.
Anemia with a deficiency of both B12 as well as iron, and the stool occult blood is negative. But sir, a single report of stool occult blood negative does not rule out a GI malignancy and does not stop me from doing investigations for a GI cause. At least 3 serial stool samples to be done, and we do treat B12 levels. We will try to correct the iron profile and try to see if the anemia improves. But if there is a lesion underlying, you have to keep a strong focus to rule out that investigation, to do a upper GI followed by a lower GI after correcting B12 and iron would be my
Dr. Simi, your comments, please.
Yeah, that's very true. So actually B12 iron, we later on, first we simply go with the peripheral smear and reticulocyte count, because we have to see, is bone marrow functioning normal or not? Is it suppressed despite of anemia? So definitely reticulocyte count is 3%. Peripheral smear gave us a dimorphic anemia picture. Then we go for all these levels, whether B12, folic acid and iron, plus stool for occult blood, yeah, definitely we will go to assess the loss. Then here we have to pay attention at the USG abdomen, which is giving us few lymph nodes. So this alarms us that what is going on? What is the cause of deficiency of B12 and iron actually? Are we going with some small bowel disease? Something is going on which is hampering the absorption of both B12 as well as iron. Or it is a simply stomach disease also. So absorption is hampered. That is the cause of deficiency. So here further investigation is needed.
So I'm so glad that I don't have to answer anything. My panelists are so learned that they're telling you everything you require.
And one more small thing, Dr. Manav.
Sir.
And in India, we should not forget the ward infestation. Obviously, it's a conference of cancer. We all are thinking for cancer. But ward infestation is very common. And many times we get the patients related to
so every panelist agrees that we are looking at a small bowel pathology here. So let me give you a fact. Vitamin B12 levels would be deficient in 80 to 90% of urban population. Nowadays, this was not there 20 years back. Dr. Asmit will remember when we were doing our MD, we were told that nobody has vitamin B12 deficiency in India. Nowadays, 80% urban population has B12 deficiency because of the RO water which you are using. It takes away every vitamin and mineral from the water which you are using. So unless the patient is taking vitamin B12, B12 will be deficient in almost all the patients. Dimorphic anemia still shows a low serum iron level. You still have to suspect a GI bleed here. Patient may be losing because of worms or a malignancy or anything or absorption defect. So you label it as nutritional anemia, maybe fallacious, maybe going overboard. You have to investigate further. So Dr. Noor, what would you do?
So in this patient, as we would like to do further imaging to rule out GI malignancy, for which routine.
So my question to you is, would you do imaging first or upper GI colon first? The other panels seem to believe that upper GI colon should be done before the cross-sectional imaging, which actually what we did.
If we have to do both, then proceeding from non-invasive to invasive would be an ideal approach.
I completely agree with you. So you can actually debate either way, whether CT first or upper GI colon first. We actually believed the ultrasonologist and we went with the upper GI colon first. We thought that the ultrasonologist has been able to screen the abdomen in a good way. We did upper GI, which was normal. We went with a colonoscopy expecting to take a biopsy from the ileum to look at what is going on, and this is what we found. Ulcerated lesion in the right colon. deep ulcer, punched out ulcer. If you look at this picture, the rest of the colon is almost normal. It's not a concentric lesion. It is not something which is causing thickening there. It's only in the involved area where you see the ulcerated lesion. Then we went ahead and did a cross-sectional imaging. So as I said, we can debate either way. We can do a cross-sectional imaging first or a upper GI colon first. This is how we went. And because we were suspecting malignancy here now, we straight away went with a PET CT whole body with CECT abdomen. So there has been a lot of debate about whether to do a triple phase CT first or a PET CT first. We combine it nowadays. You do it in the same setting. If you think there's a suspicion of malignancy, you do a PET CT and you do a triple phase CT along with that. What is the debate in that? So I thought I'll just clarify that in the presentation. This is what we found. Right colon, significant thickening. You can appreciate the lymph nodes around the right colon, and you can appreciate periportal lymph nodes. So this guy actually had multiple abdominal lymph nodes. He had eccentric thickening of right colon. We took biopsies. And we found out a high-grade T-cell non-Hodgkin lymphoma. Can you believe it? Somebody comes with an iron deficiency anemia, and he turns out to have a T-cell non-Hodgkin lymphoma without involving bone marrow, without any blood involvement. So TLC was normal, platelets were normal, and the hemoglobin deficiency was because of bleed from the ulcerated lesion. So that's one case I thought we should share. This is a guy we recently saw around 2 months back. So the take-home messages from this case: all iron deficiency anemias should be investigated with upper GI colon, every single. So even if you have a dimorphic anemia, but you see a low iron and you see microcytes, please investigate for GI blood loss. Stool occult blood, even 3 samples are not good enough to pick up bleeding because the bleeding is intermittent. It may not happen for 7 days, it may happen continuously for a few days. And we also remember that 60 ml of blood loss is required to cause a melanic stool. So absence of melena does not help you. Stool occult, vitamin B12 deficiency is more common than what we think. And finally, on an ultrasound, the bowel evaluation may be inadequate. It depends on the observant radiologist will pick up more bowel lesions, but it is often very easy to miss a bowel lesion on an ultrasound. The sensitivity is not as much as you have a solid organ lesion. We have 2 more minutes. It's a very small case. I just wanted to make one clinical point here. That's the reason I took this case. So I will invite opinion of both the gastroenterologists here on this case. So 59-year-old male patient, doctor, referred from Aligarh for jaundice and pruritus with an ultrasound saying that there is a CBD stone stuck at the lower end of CBD. On closer examination, the patient did not report any history of fever or of pain. Bilirubin was 12, gamma GT was 658. So, Dr. Yadav, would you straight away take up this patient for a ERCP? You already have an ultrasound report. CBD stone stuck at the lower end, but patient does not give any history of pain abdomen, patient does not give any history of fever. Would you straight away take up for ERCP, or would you like any further investigation before you go?
Stone disease, there are few things which are odd in this patient. One is usually there has to be some pain, stone is stuck up, and there may or may not be cholangitis, but stone, there has to be some pain. And that's the one thing in history. So ERCP is therapeutic procedure and should not be taken as diagnostic. So we should do further imaging in this patient.
Absolutely. So your clinical sense dictates what you do next. It will be very easy to just go in, do a ERCP, put a stent, and say that the CBD was cleared and patient will be fine. And 6 months down the line, he'll come back to you with a metastasis, and you'll be cursing yourself that this guy did not to start with give me a history of pain. It is very unusual for CBD stone to cause cholangitis without any history of pain. So this is what we found. You can appreciate an enhancing lesion at the lower end of CBD on cross-sectional imaging. We did a side wing endoscopy, and this is what we found. The mucosa over the papilla was absolutely normal. But you can see a bulky, bulging papilla. All we did was took a lot of deep biopsies in this patient, and the biopsies turned out to be negative. What would you do next? Dr. Noor, you would repeat a side wing with deeper biopsies? Would you do a ERCP with brush cytology? Would you do a EUS or an FNA?
So several options are there. Obviously, if the overlying mucosa is looking normal, then repeating biopsy will not be very
may not be as effective as, because we have already taken deep biopsies.
Another thing can be pre-cutting and then taking deeper biopsies. And then obviously breast cytology and the EUS with FNB or FNA can be an option.
So generally in such a scenario, you would prefer a EUS FNAB over a ERCP for a simple reason that you don't want to do an extra therapeutic procedure. You don't want to cut the papilla and then take biopsies and cause bleeding from the suspected tumor. So this is what we did with the EUS, and you can appreciate this 2 centimeter lesion seen right below the papilla. We took biopsies, FNAB confirmed adenocarcinoma. And as luck would have it, on the day we did the FNAC, same day evening he developed cholangitis. High grade fever, bilirubin shot up from 12 to 18. And we had to go and do a ERCP. Now last question, before we go ahead, anybody can take up. Would you do a SEMS or would you do a plastic stent in this case? What would be your choice?
Here, the idea is to treat the cholangitis. This is a periumpillary or lower CBD tumor. Even if you put a small stent, 6 centimeter, that is not going to interfere with your with the surgery and doing the anastomosis at higher level. So small stent can be placed, but most of the time in such cases, lower CBD obstruction, practically and clinically, there is plastic stent also work well, particularly for lower end obstruction. Obviously, we can use metallic stents also.
So, what do we need to remember is that in a tumor, when you're
be below the hilum.
So you basically want to relieve cholangitis as soon as possible and not interfere with the surgery. Now this guy is anyway going to undergo a Whipple. So even placing a metal stent does not make a difference. And metal stents are bigger, they cause better resolution of cholangitis, so we decided to place a metal stent here. And the patient was operated after 5 days. We found out a T2 lesion without any lymph nodes, and he's good at 1 year of follow-up. I would stop here, and any questions from the audience, we are happy to answer. The panel here is happy to answer. Thank you.
So, one small question. This patient of iron deficiency anemia, sometimes we see the patients with iron deficiency anemia, upper GI lower normal, lower GI normal. So what is your protocol for further evaluating? Would you still immediately go for evaluation of small bowel by doing capsule?
So we would do a cross-sectional imaging. If the cross-sectional imaging, a CT scan is a normal or a MR is normal, we probably don't do a capsule here. Unless we are sure that he's bleeding. Then we would ascribe the anemia to probably a iron defect, iron absorption defect. B12 was also low, irons are also low. On the other hand, if you find, as a routine, we'll also take biopsies from the terminal ileum. Very often than not, more often than not, you'll find terminal ileitis. You treat that, you give iron. Question of doing a capsule, I would say it is optional. Some people would do it. We generally reserve it in case we suspect a lesion.
So, one clarification, sir. Here.
Yes.
Sir, it's a dictum that never leave a obstructed biliary system undrained. So the moment we were doing USFNA, I would have actually done ERCP simultaneously and prevented this cholangitis first. And second, it would have exposed the lower CBD, and I have taken, even my FNAC would have been inconclusive. My biopsies would have been given a positive diagnosis. So you agree that you got FNAC positive?
No, FNAC. So, see, there are different ways of approaching. There's nothing wrong in what you are describing. It can be done that way. The patient, we planned that we have rows. We actually diagnose malignancy on table. We do FNAC, the pathologist is there, he tells us adequate tissue is there, we can see malignant cells. And we planned for a surgery within next 48 hours. I don't want to make a papillotomy there, make the tumor bleed, make it more complicated. What you're saying is right. This is one way of approaching things. Our way is different. And FNAB with a bigger needle is as good as a biopsy. And more often than not, you're able to reach a diagnosis. The US experts here would vouch for that.
22G or 25G in duodenum when you are in a short?
No, we use 22G.
22GB.
Yeah.
I think we can cut it off here.
So we can discuss this over lunch. Any more questions?
Thank you so much,
thank you.
Manav.
Thank
That
you.
was an excellent clinical learning. I think he needs a big applause. Thank you all the panelists also.
Now the next session will be video digest. So may I please invite upon stage our esteemed judges for this session. They need no introduction. Dr. Vinay Dheer from Mumbai, Dr. Mohan Ramchandani from Hyderabad, and Dr. Prakash Zacharias from Kochi. The first presenter in this session will be Dr. Gaurav Patil, interventional endoscopist, HN Reliance Hospital, Mumbai.
We have 5 presentations in 35 minutes. So 6 minutes each. So I think we should stick to the time. So the rules are the video presentation will be for 6 minutes plus 2-minute discussion. And there will be 2 prizes. What are the prizes? I think Sanjay will tell us later. I would cash prize, okay. So I will ask other presenters to kindly upload their video presentation on the computer already, so that we can save time. Gaurav, please go ahead.
Yeah. So good afternoon, my dear friends and my colleagues and our respected judges. Thanks, Dr. Sanjay, for this opportunity. So today I'll be discussing a case of a very little unusual case of resection of adenocarcinoma, which was present at the G junction. Not an easy routine dissection that we come across in a practice of ESD. So this is a case of a 69-year-old male who's a smoker. He's hypertensive, he is diabetic, he has early CKD, he's not on dialysis, just medical management. He has a history of a surgical fundoplication 20 years back, and on routine evaluation for dyspepsia, he has been diagnosed of adenocarcinoma at the G junction with a lip of Barrett's esophagus. This was a report that was given to us, and he was referred to the surgical department at HN Hospital. So the surgeon performed a PET scan, a routine evaluation, worked him up for a surgery, and he was told that he will have to undo the fundoplication and undergo the surgery. So before he went for the surgery, an endoscopy was asked just to stage or search to locate and size the tumor. So the initial endoscopy, and this is the video of the first endoscopy, and here this is without the distal attachment, and the reason why I'm showing it is to understand how a distal attachment can change your management. So you can see you can see a lip of Barrett's esophagus on the 4 o'clock aspect, and this is a non-neoplastic Barrett's, which is having a regular arrangement of your ridge and circular mucosal pattern and regular vessels. And as we move down, we can see some nodule formation at around we can see some nodule formation which is around 1 or 2 o'clock over here, and this is something you're suspicious about. You start to worry that this is the possible area of the tumor, and you want to make sure that you are giving the surgeon a good information as what has to be resected, what has to be left. So this is the area which we are seeing, and a good fundoplication. There is good grip of the scope, and again as we withdraw the scope, some bit of superficial ulceration, maybe the biopsy side, and there's a nodule formation which is seen around 11, 12 o'clock. And on retroflexion, we try to see the tumor, if the tumor is actually at the G junction going into the stomach, into the cardia, but we are unable to see the tumor even on withdrawing the scope, even pulling back the scope. So what we do is we attach routinely a distal attachment, and this helps to evaluate the tumor, gets the tumor in phase. And after we get the tumor in phase, there are two important things that we start seeing. One, you can see a irregular area of mucosa where you can see some ridge and tubular pattern which is slightly irregular, and the vessels are focally distributed in an irregular pattern. There is some squamous epithelium in between, and you can see some vessels are irregularly distributed. So at this stage, we don't know whether this is just inflammation or this is dysplastic tissue, and is this an area of concern. So this is somewhere around 6 o'clock. And you can see some deep submucosal vessels, and this is under magnification and with using water. Now we evaluate the nodule, and this is a worrying nodule which is seeing, and very clearly you can see the vessels are now becoming focally distributed, which are irregular, branching in a abnormal hazy pattern, and the mucosal pattern is abnormal. So this is just below the Z line. This is towards the cardia, and which makes us wonder, is this a tumor which is actually from the cardia and then coming up, or is this a true Barrett's? And then we withdraw the scope and we try to see, and then after using the distal attachment, it helps you to separate the tumor from the mucosa, and then you can see a clear demarcation line. You can see an area formation, a demarcation line, and here you can now appreciate with the help of a distal cap, yes, there is a tumor. This is a malignancy which has been biopsied before, and this is quite, looks like a superficial one with no deep dark vessels, superficial eroded tumor which has somewhere around G junction just towards the cardia. So based on these findings, we then explained the patient, we need a EUS, we just want to see the nodal stage. The PET did not pick up any nodes, but we did a linear radial EUS, and to the good fortune of patient, there were no regional enlarged lymph nodes, and we got a reasonably good T staging also in this. Ideally, EUS is not meant for the best for T staging, but we could see that the submucosa was not really infiltrated by the tumor. Maybe this was a very early cancer that has been picked up. We had MDT meeting with the surgeons, oncologist, and the patient himself, and we said, okay, we can maybe just get away with the EST of the entire Barrett's along with this thing. Other plan was to do just a cap EMR of the nodule, which probably wouldn't pick up, wouldn't be able to get the flat lesion, which was at around 6 o'clock. We would only get the nodule. And the third option was invasive surgery. So keeping all these aspects in mind, his comorbidities and his choice, we said, yes, I think endoscopic resection should be the first go-to. So we began a dissection, and normally in such cases, we routinely want to start dissecting after marking in from the retroflexion area. The reason for this is two things. One, you want to first create a retroflex submucosal cushion, submucosal tunneling from the retroflexed area, and this is how we perform it. We are dissecting along the retroflexed part of the cardia, part of the tumor, and we know this is a very vascular area. There's a lot of bleeding, and as you are dissecting, you want to make sure you're maintaining the planes of the submucosa. Not an easy area to dissect, and once you start dissecting inside, you can start entering the distal end of the esophagus from this tunnel that you're creating. So we went ahead and started dissecting, and you can see some bleeding that is happening, and once you start dissecting from the retroflex, you can see these palisade vessels and the spindle vessels which are seen on the muscle aspect, the spindle vessel and the muscle aspect of the G junction, and you start dissecting. Another important sign is once we are dissecting, we start seeing even the penetrating vessels which are commonly seen in when you're performing POEM, that you see these vessels which are the guarding vessels when you enter the stomach. So we are now entering the esophagus from the distal aspect, and as we are dissecting, we come back and we start creating a tunnel along the same side, that is the posterior wall, from the proximal aspect of the tumor.
Gaurav, can you speed up, please?
Yeah. So as we are dissecting, we create a tunnel and we join these two tunnels. This is the proximal tunnel and the distal tunnel. Once these two tunnels are joined, we know that we've created a sufficient long tunnel ESD, and we continue to dissect this tunnel along the anterior aspect. We dissect the tumor from the anterior aspect, and then slowly we start, the same principle of ESD. We go out on the posterior aspect, left laterals, that is around 9 o'clock, and we dissect the entire tumor in toto. So this is a basically end block resection of a circumferential tumor, which is at the G junction in a patient who has undergone a fundoplication. Little challenging and not the routine ESDs that we perform. More over that, because this patient was early chronic kidney disease, we decided to use hemospray in this patient just to prevent delayed bleeding, and that's something we have started to use routinely in patients who are high risk for bleeding after an ESD. And this is something, this is the resected raw area that of the esophagus, and this is spraying the hemospray, that is a collagen spray from Cook Medical, to prevent bleeding in these patients. So when the biopsy comes back, this is a moderately differentiated adenocarcinoma. The tumor is invaded deep muscularis mucosae. There is no submucosal invasion, and this patient then follows up for after 3 weeks exactly.
Gaurav, I think we have to stop because we are very short of time, because the strict rules are to be followed in a competitive video session.
So this patient underwent dilatation. He has intact fundoplication. And he is on a routine follow-up. I think after 3 months he'll come for his next dilatation, which our aim is to go up to 15 millimeter. And so the take-home message that if you need to have a thorough evaluation of these tumors, you need to have an idea of the location, the size, and signs of deep invasion. You can protect or save a major surgery in these patients. Hemospray works well to prevent rebleeding. Elective dilatation prevents symptomatic stricture, and it's a video of the same tumor. Thank you.
I think we have crossed time, so we'll go to the next presentation by Dr. Sunil Kasturi from Bangalore. Sunil?
I may remind all the presenters that if you stick to time, then only you get marks. If you overshoot, your marks will be deducted. This is a competition.
Try to finish video in 3 minutes.
Hello everyone. Today I will just briefly tell you about the combined method for tracheoesophageal fistula closure. We did it for the first time. 47-year-old lady, she presented with papillary CA thyroid. She underwent surgery in 2021. She had a local recurrence which was very advanced and bad tumor. For in view of airway obstruction, tracheostomy was done in April 2022. For feeding purpose, thereafter PEG placement was done, 24 French, for nutrition. Later on, after 6 weeks of PEG placement, she developed cough and regurgitation of food contents through tracheostomy tube. First we went ahead with CT thorax, which showed a tracheoesophageal fistula around 4 to 5 mm size at D3 level. Then an upper GI endoscopy was done to see the fistula site. Endoscopy, there was a slight narrowing in the cricoid region. The scope was negotiable with mild resistance. We went ahead with around 10 to 12 mm CRE balloon dilatation, and we tried to close the fistula with dummy cap, just to whether any clip we can place. We just thought like that. Since it was a thick mucosa and unable to grasp, it was unsuccessful. Hence we planned for fistula closure with VST device. This is the post-cricoid stricture. There was mild difficulty, mild to moderate difficulty in negotiating. Could negotiate slowly. Then the fistula site was appearing around 18 to, around 20 centimeter. This was around small fistula, around 4 to, it's in the 5 o'clock position, around 4 to 5 mm fistula. Then we did a bronchoscopy and wire through the tracheostomy site. We did a bronchoscopy and wire was placed across the fistula. Wire was seen in the stomach. Then we introduced a 8 French sheath for AST device under gastroscopic guidance. This is the AST device we used. And deploying AST device, firstly we opened it distal most near to the stomach, then we proximally moved it. It was a good opposition on the esophageal side. slowly withdrawing the device up to the site of the fistula. Once the perfect position and good wall opposition is confirmed, then we simultaneously did the bronchoscopy and just check the site of the way to release the proximal release through the tracheal site. It was fitting opposing correctly. Then while deploying through the tracheal side, because of the traction pull, there was slightly desaturation and lot of little bit aspiration was there. So we immediately suctioned it and we thought we would release. Once we released, the size of the proximal release of the this tracheal release stent was little bit more. It was slightly causing compression and stridorous breathing. So we went ahead once again the assembly, we have reassembled it once again. And because of pull, the device was more towards the tracheal side. It was less in the esophageal side. So we just proximally we released in the under gastroscopic guidance, just not as the initially distal most part, little bit proximally we released. And since the device was migrated, we just released it proximally under endoscopic guidance. Then we went ahead with trachea along with the push-pull technique. We just released the device. This is the esophageal release. We didn't release completely. There was a just proximal distal most part. We just released it. Using the traction, push-pull, then we deployed the tracheal side. We confirmed the position and patient was doing good. And we check fluoro was done. It was showing good position. The next day, check fluoro was done. It was showing tracheostomy in tubu and the ASD device in situ. The device is in situ, ASD. So, post procedure, she tolerated well, and there was required frequent suctioning for 2 or 3 days. Then there with supportive antibiotics, she was doing good. We followed up the patient for up to 3 months. She was doing good. So briefly summarizing, cardiac septal occluders, either AST or VST device closures, are thought to promote fistula closure by occluding the fistula tract, and they stimulate the tissue ingrowth. Recent meta-analysis suggests it is an 100% technical success rate and around 77% clinical success rate and around 22% adverse rate. Whenever the other methods fail, I think then good option in managing GI fistulas or you can use cardiac septal occluders. Thank you.
That was a fantastic presentation. Only one thing is never send mobile pictures, mobile. It was very, it's not a good way of presentation.
Fine.
Apart from that, the video was good. How do you, I saw the date was in 2000. It was done in year 2000. And now, what is the long term? We have done almost 7-8 cases, and none of them stay for long, like 6 months. Then they either vomit out that stent or they get aspirated. So, what was your opinion about that? What happened?
First thing, sorry, date was like old system. It was not entered properly. For 3 months, we followed the patient since she's a metastatic and bad recurrence and all. She was doing good up to 3 months. It requires frequent suctioning. Apart from that, she developed then some fracture and finally she expired due to other reasons. But for 3 months, this device was in situ and she did well, sir. No.
Yeah, so the message is when there is a metastatic CA and never do it for benign disease.
Yes, only.
So it's only for metastatic CA when the life expectancy is less, you can opt for this option because other options are also not there.
Not feasible.
Thank you very much. Any questions?
Thank you, sir. The next presenter is Dr. Pankaj Gupta, consultant gastroenterologist from Max Super Specialty Hospital, Saket, New Delhi.
Good afternoon, everyone. The topic of my today's presentation is troubleshooting of migrated SEMS during hepaticogastrostomy procedure. We had a 69-year-old lady who presented with metastatic pancreatic carcinoma with gastric outlet obstruction. She was planned for palliative chemotherapy and biliary drainage. However, both ERCP and choledochoduodenostomy were not feasible because of duodenal bulb infiltration. Therefore, she was planned for antegrade stenting or hepaticogastrostomy. This is the video of the whole procedure. On endoscopic ultrasound, we identified multiple dilated intrahepatic ducts. A dilated segment 3 hepatic duct was identified, and a puncture was made using a 19-gauge needle. A guide wire was placed into the dilated segment 3 hepatic duct. The position was confirmed on fluoroscopy with an contrast injection. Once the position of guide wire was confirmed, dilatation of the fistulous tract was done using a 6 French cystotome. Further dilatation of the tract was done using a 4 mm hurricane balloon. After the adequate dilatation of the tract, a 10 centimeter partially covered metal stent was deployed with distal end in the segment 3 hepatic duct and the proximal end in the gastric lumen. Here we can see the deployment of the distal end of the metal stent. However, on endoscopic vision, there was non-visualization of the proximal end in the gastric lumen. Fluoroscopic image showed deployment of the proximal end in the intraperitoneal cavity. To further add to our misery, there was loss of guide wire access as well. Now at this point, we were left with two options, either attempting to regain access into the mal-deployed SEMS through the previous tract or going directly for surgery. We opted for first option. Initially, we attempted to place a guide wire into the previous tract using a sphincterotome. However, after multiple attempts, this approach was unsuccessful. We then thought of using a spy scope, directly entering the fistulous tract and placing a guide wire. However, this endeavor as well did not fare well. After failure of this approach, we thought of using a rat tooth forceps and directly grabbing the SEMS and pulling it into the gastric cavity. But even this approach did not succeed. Then we used an upper GI gastroscope for directly placing a guide wire into the fistulous tract and metal SEMS. However, after its failure, then we used ultra-thin scope of directly entering the fistulous tract, visualizing the SEMS and placing a guide wire. However, after multiple attempts, even this approach was not successful. After all these failed attempts, we were once again left with two options, either going for surgery in a patient who was a high-risk candidate or attempting to regain access into mal-deployed SEMS now through a new tract, either an end-on or a side-on approach, and putting a second fully covered SEMS. After due discussion with the family and considering all the risk factors, we went on with second option. However, end-on approach was not feasible as the alignment of the stent was lost with gastric wall. We were successfully able to puncture through the body of the SEMS, and we placed a guide wire through the body of the mal-deployed SEMS into the segment 3 duct. Position of the guide wire was confirmed on fluoroscopy. Then the further dilatation of the tract was done using a 6 French cystotome along with cutting of the wire of the mal-deployed SEMS. After this further dilatation was done using a 4 mm hurricane balloon. This is the fluoroscopy video showing dilatation of a new tract, and the previous mal-deployed SEMS can be seen in this. However, since the new stent assembly was 8.5 French, a further dilatation using a 10 French cystotome was also done. After the adequate dilatation of a new fistulous tract, a second 8 cm fully covered stent was placed through the body of mal-deployed SEMS, and the proximal end was deployed in gastric lumen, this time under endoscopic vision, and an adequate intragastric portion was kept. The position of the stent was confirmed by biliary drainage. This is the fluoroscopic image showing both mal-deployed as well as the new stent placed through the mal-deployed stent. In order to prevent injury to the opposite gastric wall from stent edges, a 10 French plastic stent was placed through the body of a new stent. In order to relieve gastric obstruction, a duodenal stent was placed as well. Now, what were the challenges that we faced in this case? A mal-deployment of SEMS in a surgically high-risk candidate, and also there was loss of guide wire access. Further, there was loss of alignment of a mal-deployed SEMS with EGOS tract, and we were unable to regain entry through the original ileus tract, and the puncture through the metal stent in itself was an uphill task. On follow-up, there was a small cholangular abscess in segment 2 which was aspirated, and patient was started on antibiotic. Patient responded well to antibiotics. What are the learning lessons through this whole case was that adequate length of intragastric portion of SEMS should be kept, and the deployment of the proximal end should be done either under endoscopic vision or an intrachannel deployment should be done. Mal-deployment of stem during hepaticogastrostomy is a rare complication. However, there is no definitive algorithm that exists so far. We were able to salvage the situation through a novel technique of placing a fully covered stent through the body of a mal-deployed stent, thereby avoiding a morbid surgery. Thank you.
Very brave. What happened to the original hole which we could see where you went through the gastroscope and tried to see the stent?
So
what did you do about that?
We are hoping that will close spontaneously.
Oh.
We put an NJ tube through the duodenal SEMS also in order to give rest to the stomach. And on follow-up CT, there was a small collection also, and which was resolved after with antibiotics. Patient is currently doing well.
No contrast study was done at that time to see whether there is ongoing leak, because we could see the scope going into that soft tissue.
Yes, sir.
I don't know what.
So after that, a CT was done, which showed a small collection adjacent to the stomach, but it responded to antibiotics. And a small cholangular abscess was done, was there in segment 2 because it was blocked with the covered stent.
So why do you think these things happened in the first place? Why was the stent deployed inside the bile duct?
So there were probably two reasons. The endoscopic vision could not be achieved initially during the deployment of the proximal stent. We tried to get an endoscopic vision, however, we couldn't get it at the right time. And second, the intragastric portion needs to be very adequate. If the more of intrahepatic portion is kept and less of intragastric portion is there, it can lead to such complications.
And did you use a 10 centimeter stent or 8 centimeter?
The first stent was a 10 centimeter partially covered stent.
And the whole stent went inside?
Yes,
10
sir.
centimeter?
Yes, sir.
Okay.
And the distal end was in the peritoneum or it stuck to the wall?
So the proximal end, which was towards the gastric side, it was in the peritoneum, sir. Sir, initially it was stuck with the wall, but with further maneuvering and manipulation, it sagged down, and the proximal end was facing downwards.
So normally, if the stent is mal-deployed and it is not in the stomach wall, as Mohan is saying, it goes down.
Yes,
it doesn't remain in the same axis as you anticipate.
Yes, sir.
So if it was in the peritoneum, then all the maneuvers that you did were futile because the stent had already moved from its original place. If it was stuck in the stomach wall, then all your maneuvers were right. But if you say it was in the peritoneum, then all those maneuvers are totally unnecessary because there was no way you could have reached the stent. It was already, outside the gastric wall.
Initially, sir, it was touching the gastric wall, but when we kept on trying it, in a repeat fluoro image, it sagged further down, sir.
Yeah. So it was outside, completely outside. Anyway, brave, very brave.
Thank you very much.
Could you have closed the defect by using a clip or something?
So we thought of doing so, but we had already placed an NJ also, and we were not giving anything into the stomach. So after bowel rest, it would have been
it subsided.
Not required. Yes.
Thank you so much.
Thanks.
We'll move ahead.
Thank you, sir. The next speaker will be Dr. Chintan Patel, consultant gastroenterologist from SIDS Hospital and Research Center, Surat.
Good afternoon, everyone. First of all, I would like to congratulate Dr. Sanjay and thank you for this opportunity. I would like to present a case of Bhopal saving piecemeal EMR of a large duodenal adenoma. A 65-year-old female who was presented to us, who is coming from the lower socioeconomic class, who has abdominal pain, recurrent on and off vomiting and weight loss. Her ultrasound was suggestive of dilated pancreatic duct and a common bile duct with a smooth tapering of lower end. Her CBC and LFT were within normal limits. Dilated CBD and 8 to 10 millimeter on the EUS. Dilated pancreatic duct of 2.3 to 3 millimeter with a distended thick walled GB with sludge, and approximately 5 centimeter ampullary lesion was there, which was extending to D3. There was no intraluminal extension to common bile duct or a pancreatic duct, and no lymphadenopathy on the EUS. This appeared adenomatous on the narrowband imaging on the duodenoscopy. Patient was underwent CCT abdomen. So this confirms the diagnosis of 5 centimeter size ampullary adenoma without any lymph node invasion. So after discussing with the relatives, we have offered a patient choice of either surgery or a piecemeal EMR, and they opt for the piecemeal EMR. On duodenoscopy, there was a transient intussusception of the large polyp into the duodenum, which was relieved. The area was clearly seen, and we planned that the resection would be piecemeal, starting from the D3 distally to lessen the tumor bulk. We planned EMR in such a way that start with the distal most part to doing a EMR, then on the lateral margins, and after that, when the orifice is clearly visible, we have to resect the ampulla proper. So this is the standard technique of snare and EMR on the cautery. The piecemeal EMR continued to lessen the tumor bulk. The lateral margins were resected likewise. Once the proper ampullary portion was visible, we resected that portion on snare. The bleeding was controlled with use of coag grasper and a gold probe. And after the complete secure of hemostasis and complete resection, common bile duct and pancreatic duct was stented. Post-procedural events, patient was kept overnight nil by mouth and was started orally on next morning and was discharged uneventfully on the second post-operative day. The final histology was suggestive of adenoma with low-grade dysplasia, and the base was free from the lesion. There was no evidence of malignancy. To conclude with, for bulky villous tumors, debulking by means of piecemeal EMR followed by a final resection helps by increasing the field of vision and thereby working space. Whipple surgery was avoided in this patient, which would have been unavoidable in view of recurrent pain secondary to transient intussusceptions and bulk of a tumor. And not to forget the high chances of developing obstructive jaundice and its malignant potential in future. This case summarizes the usefulness of piecemeal EMR for bulky tumors that are otherwise pre-malignant rather than having invasive carcinoma. And this helps to decrease the time of actual procedure by increasing the field of vision and working space, and helps in R0 resection. In this patient, we successfully avoided the Whipple surgery, which would have been otherwise too morbid for the patient. And this patient was coming from a village with a negligible health care facility with the lower socioeconomic status, and these patients cannot be kept on a regular follow-ups, which they may not follow and add to their misery. Thank you.
Nice presentation, excellent presentation. Few questions. How did you retrieve all the pieces that fell in the duodenum after your resection?
We use
are you sure that you retrieved everything, or something flew down into the jejunum?
Sir, we started in a D3 and the chunks were large, so we could retrieve it with a rotnet.
So after removing each piece, you first retrieved it, or you left it and then?
We left it in the stomach and then retrieved it.
In the stomach?
Yeah.
So after the resection, was biopsies taken from the base?
Yes, sir. The biopsies were taken from the base also, which were adenomatous, with low-grade dysplasia, but there was no invasive malignancy.
No, whether there was any residual lesion at the base, that is an important thing.
Yeah, the biopsy from the base was negative for
Since it was a piecemeal EMR, you may not be able to say that the whole tumor has been resected, because if it
yeah,
is
agree, in a sir.
one piece, then it's okay.
Right, agree, sir. So after the final resection at the ampullary end, we took the biopsy from the lateral margins as well as from the base. So those were negative for the.
Your pre-op endosono showed dilated CBD.
Yes,
was there any intraductal extension?
I showed that there was no intraductal extension.
But you did the US with a bulky tumor.
Yes, sir.
So always what we do is we do a balloon sweep when you are putting a CBD stent. There can be a chunk of tissue which will infiltrate lower end, because once you are doing a EUS in such a bulky tissue, you may not be able to see the lower CBD very well.
The contrast enhanced CT did not show any intraductal extension also. And after when patient came for a follow-up for stent removal, we did the balloon sweep which was negative.
Good. Thank you.
Thank you.
So move ahead with another presentation by Dr. Arvind. The last one, not the least. Arvind, you have to be fast. Otherwise, you are an athlete. You must run.
Thank you, sir. My case is okay. Thank you. So basically, she was a young lady, 32 years, and presented in a periphery hospital with acute abdominal pain with bilious vomiting. So there was definite obstruction, and CT scan was done, which showed duodenal intussusception, and surgery was attempted in periphery itself. But because of some reasons, this was a CT scan which showed duodenal intussusception, and this location was at DJ. So the general surgeon found it difficult and he closed and referred to us. So patient was already underwent laparotomy at a periphery hospital, and they also did try to do an intra-op endoscopy, and then they thought endotherapy can be done, so they requested us for endotherapy. Patient came next day to us, we optimized the patient, everything was normal. I discussed with my surgeon also, and we went for straightway again a repeated CT scan, and that also concluded that this was a large lesion intraluminal with a arterial feeder from a pancreaticoduodenal artery. So basically we did first of all an endoscopy because we know that it was at the DJ, so there was some risk of perforation, bleed, and it was a difficult location for ESD. And before going into any venture, we discussed with the two endoscopists also from the high volume center, and we did this endoscopy by ourselves. So this was really a large lumen. Beyond that, it was very difficult to go. It was almost at the D2, D3. So it's not playing. So first we did an endoscopy. We evaluated further, and then we discussed with the endoscopist as well as surgeon and the family, and they thought that we can go because it's a difficult location. They wanted to go for surgery itself because it was a very large, and it was difficult to go beyond the lesion to define it further. So my surgeon opted for surgery, and when we went for surgery, he thought it was very difficult. It's a large one to remove it on surgery itself because he was not sure that he will get R0 resection, and so he thought because he could see from the other side. So my intention was that removing on endoscopy, the two main complications were bleed or perforation, and it was really difficult to manage endoscopically. But for surgeon, it was really difficult to get R0 resection, so he thought he may have to proceed for Whipple surgery. So we discussed it intraoperatively itself, and I went for again doing an endoscopy because he was sure enough that it's not a malignant lesion, but it was definitely causing obstruction, so we had to remove it without any complication. So we decided to go for piecemeal removal of this because it was very large. So I went with the
piecemeal EMR for this patient, and we could remove it with 3 large chunks we retrieved with Rothnet, and this was the first piece we removed. So this was really large, and I thought it would have bled like anything, but my surgeon was on the other side, so he was an asset for me at that point of time. So I could remove this whole chunk. We can see that this duodenum was really dilated proximally because of this obstruction. We retrieved all the 3 large chunks, and we could ensure means complete removal of this large polyp. We could send all this sample to our histopathologist. So this was the complete resection. So this was the clear margin at the end. And what we got, so this was clear removal of whole tissue. And these were the 3 large chunks which we removed. We retrieved all the pieces and sent it for histopathology. So with this, histopathology turned out to be hematomatous polyp, Peutz-Jeghers type from the duodenum. We reviewed the literature. It's really uncommon. It's hardly 1–3% of upper GI we do, and we get duodenal polyps. More than 10 mm has a malignant potential, and ESD duodenal has some unacceptable risk profile. And these hematomatous polyps are really rare, more in children. Cancer risk is very low, but this is again common in jejunum, then ileum, and then in the duodenum. So it was the rarest of rare. And histopathology spectrum, I could get one study from SGPGI, 81 cases, and they could conclude very well that most commonly they present with abdominal pain, and maximum of these are non-neoplastic. So our patient was really saved with the Whipple surgery, which would have morbid complications also. And this was, I think, the best part for the patient. Thank you so much. Thank you.
Nice case, Arvind. 2 statements of yours I need clarification. One, you said the surgeon thought R0 resection was not possible. How can you make that statement?
Sir, actually,
this is a mucosal lesion. Outside is showing a normal jejunum. Where is the question of not being able to do an R0 resection?
Sir,
if he is not able to localize it, I can understand. Okay, he could not feel it or he could not palpate it, so he was a little uncomfortable resecting. But R0, there is no question of not having an R0 resection.
Vinay, he thought that.
Sir, surgeon thought
Whipples will be needed for it.
Surgeon thought that.
That is my second question. Yes. Why he mentioned Whipples here? This is a DJ lesion, right?
It's not DJ, sir. Actually, it was in D2, just beyond papilla. That he could conclude only after. Before embarking onto surgery and all the discussions, we thought that the lesion was at D2, D3, or it was reported on CT scan, it is at the duodenojejunal junction. But when he did surgery intraoperatively, what he could find that it was almost near to the papilla. Okay. So it was difficult for resection and then making an anastomosis there.
Arvind, would it be better if you do an intraoperative endoscopy and resection? Because then the maneuverability is very good.
Sir, we did only intraoperative. Okay. This was intraoperative endoscopy on
oral. I mean not oral. Enter just 1 feet or 2 feet. Yes, okay. Okay. So that your maneuverability is good. And how can you say it's totally removed?
Sir, just because the surgeon already moved, cauterized it, duodenum, so it was straight for me. Before going, when patient was not cauterized for duodenum, it was difficult for me to go beyond this lesion. But once he cauterized the duodenum, it became easier for me to
even if you open, the patient has a laparotomy, even if you do endoscopy, the surgeon can feed that polyp to your snare. That's the advantage you have.
But the size was little on higher side, sir.
One small comment from surgical point of view. We have published one paper with 9 cases of DJ flexure tumors, and I think 2 of them are from D3. That is way back in 2012. Now we have almost 18 cases of DJ flexure tumors. I think there is a possibility of segmental resection in this. They could have very well tried.
Actually, it's a call of a surgeon.
Correct.
If it is at DJ, it's okay. But if it is coming just beyond papilla, it becomes difficult for him.
We had a couple of cases located in D3 at the turn where exactly it takes the turn. So even then also we can still do a segmental resection. So we have completed successfully, and we have a lot of citations for that also. So it is feasible to do a segmental. We don't need to do a Whipple's procedure if it is not malignant. This doesn't look like malignant at all. So we can still go ahead with the segmental resection.
Arvind, that was a very good case.
Sir.
So the thing is, during surgery, you could go across the lesion. So if you could go across the lesion before surgery, would you have tried for endoscopic resection?
Sir, I did endoscopy before the surgery, but it was really difficult for me because it was on the medial aspect of the D2, D3. So even removal of in that area with the complications, if it has a feeder of a large pancreatoduodenal branch, then bleeding and perforation would have been on higher cart, and it's difficult to manage endoscopically in that area. So we discussed everything with the family, we discussed with our senior consultants also, and ultimately we concluded we will go for straightway for surgery.
Okay, thank you, Arvind.
Sir.
So with that, we'll finish the session.
Thank you, esteemed judges of the panel and speakers for this very interesting session. I would like to invite all the speakers back on stage for the group photograph with the judges. The topic of discussion for this next session will be newer therapies for hepatocellular carcinoma. I would like to invite the chairpersons for this session, Dr. Alok Verma, Senior Physician from Bhopal, Dr. Shailendra Jain, Associate Professor of Gastroenterology from Gandhi Medical College, Bhopal, and Dr. Seema Mahant, Professor of General Medicine from AIIMS, Bhopal.
Good afternoon. For the next session, I would like to invite Dr. Ashish Kumar sir. The topic is new therapeutic for hepatocellular carcinoma. Sir, please.
Good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. Sanjay Kumar and my old student, Dr. Naveen, for inviting me here in this August gathering. So I would be talking about newer therapies for hepatocellular carcinoma, and with the permission, I have slightly modified the topic. I will talk more of newer treatment approaches for the hepatocellular carcinoma. So my agenda would cover all these aspects: liquid biopsy for HCC, adjuvant therapies after curative treatment, downstaging and neoadjuvant therapy, new drugs in pipeline, and precision and personalized medicine. So many of these aspects are still not there in guidelines, but active research is being going on, and we may soon in next 5 to 10 years see many of these aspects being practiced widely. So coming to the liquid biopsy for HCC. So to understand what is liquid biopsy for any cancer, we need to understand what biomarkers are released into the blood from any tumor. For example, if liver is there, what biomarkers it will release? So it will release proteins, and it will release metabolomic markers. For example, proteins can be alpha-fetoprotein, PIVKA2, and certain metabolomic markers like bile acids, carnitine. These are the usual biomarkers. But apart from that, these, there could be other biomarkers which are released. For example, there could be extracellular vesicles. There could be circulating tumor cells themselves which are released in the blood, or certain nucleic acids which can be released. And these form the basis of liquid biopsy, which is now coming into the oncology practice of any cancer, not just liver cancer. Especially the nucleic acid which is released from these tumors are very important, and these are studied most. And especially the circulating cell-free DNA. So DNA which is not there in the cells but is circulating in the blood cells is studied and is most promising. It is also, once it comes from the tumor, it is also called as circulating tumor DNA. So what is cell-free DNA? So normal blood does contain some amount of cell-free DNA, and most of this in healthy person is derived from various sources of the body. For example, if we do the analysis from where it is normal cell-free DNA is coming in the blood, it would be lot of them would be coming from the blood cells, neutrophils, T cells, B cells, and some of them would be coming from various organs of the body like lungs, liver, heart, and kidney. This would be in normal persons. And physiologically, in normal persons, these cell-free DNA would increase with various physiological conditions, including exercise. Even exercise would increase the normal cell-free DNA of the body due to wear and tear. And also in pregnancy, the cell-free DNA increases, and that can be basis of detection of various abnormalities in the fetus. But pathologically, cell-free DNA increases with various inflammatory diseases. For example, even in rheumatoid arthritis, it can increase, or it can increase due to various cancers. For example, any of the cancer, it can release. And for the cell-free DNA which is released from the tumor or cancer is known as ctDNA, or circulating tumor DNA. So in HCC patients, with advancing tumors, some of the cells are released, as well as cell-free DNA, and various other biomarkers are released in the blood. Of them, when we study their nucleic acid or the DNA, we can study the mutation as well as epigenetic changes. So mutation like TERT mutation, CATNMB mutations, or any epigenetic changes like methylation can be studied in these patients. So there's been recently NEJM paper on cell-free DNA technology to detect colorectal cancer screening, which was there a few weeks ago. And similarly, there have been papers which are coming which are studying cell-free DNA testing for early hepatocellular carcinoma patients. So within next 3 to 5 years, cfDNA-based technology or liquid biopsy will be routinely used for not only diagnosis but also for surveillance, treatment response, recurrent detection. So right now this is a very nascent field, and with in next 3 to 5 years we will see more and more papers, and it will be widely practiced. Coming to other aspect of HCC therapy, what is new in it. So talking about adjuvant therapies after curative resection. So in early stages of cancer, this is the inacil BCLC staging. So when the tumor is in early stage, stage 0, stage A, or early stage, the treatment modality of choice is either ablation or resection, or also transplantation. So after ablation and resection, usually although the tumor is cured at that time, but there's a very high recurrence rate, up to 70% in 5 years. So how do we check that recurrence? So initially, once the sorafenib had come in 2008, they tried adjuvant therapy after resection and ablation of these tumors, but it was not successful, and the giving sorafenib after resection or ablation did not help these patients, and the recurrence-free survival or the overall survival remained same. But with the emergence of immune checkpoint inhibitors and latest immunotherapy, similar studies has been done, and which have been published just a few months ago, where atezolizumab was given to those patients who underwent resection or ablation, and these patients had a very good recurrence-free survival. And so this study, which was IM Brave 050 study, paved the way for adjuvant therapy for after resection or ablation of early tumors. So what is the concept of immune checkpoint inhibitors as adjuvant therapy? So whenever some tumor is there, even though it is small tumor is there could be certain occult metastasis at distant site in the same liver, which could be there. So once we are doing surgery for these tumor, we are removing these tumors by surgery or doing ablation, the tumor is completely removed, but we are not able to remove these occult metastases. So once we have given immune checkpoint inhibitors, it will recruit all the T cells and cytotoxic T cells, which will not only take care of the site from where the tumor was removed, but also at the distant site, if there are certain metastases, these prime T cells will take care of these cells. So more and more, apart from the 050 study, which I mentioned, more and more studies are now coming, which are showing that giving immune checkpoint inhibitors as well, or combining with tyrosine kinase inhibitors, there are better chances of having reducing the recurrences in these tumors. And many ongoing trials on adjuvant therapies are going on, and whose results are expected within this year or the next years. So who needs adjuvant therapy after resection or ablation? Especially those patients who have got high risk of recurrence. For example, if the tumor size is large, number of tumors is high, they are having microvascular invasion or even segmental portal vein invasion, or poor differentiation on histopathology. So after resection, if you find these features, these patients merit adjuvant therapy. Similarly, after ablation, if the size was large or multiple tumors, these patients would merit. So in next edition of HCC guidelines from various societies, we would definitely see that adjuvant therapy would be strongly recommended. Coming to the downstaging and neoadjuvant therapy. So what are the pre-operative treatment therapies which can be given? So if there is a resectable tumor and we are giving neoadjuvant therapy to prevent recurrence of the tumor, this will be called as neoadjuvant therapy. But if the tumor is very large and it is not operable, and if we are giving some kind of pre-operative therapy to reduce the tumor burden and then convert it to a resectable tumor, then this type of therapy is called as conversion therapy. It's also a form of neoadjuvant therapy, but we call it as conversion therapy. Similarly, if the HCC is within Milan criteria, but we are not getting the donor, he's in the waiting list and there's a lot of time, potential time, so the therapy which we give to these patients would be called as bridging therapy. And if the tumor is outside the conventional criteria, outside Milan criteria, outside UCSF criteria, and we downstage the tumor, then this is called as downstage. So all four of these types are neoadjuvant therapy, but with different names. So talking about downstaging, as you all know that Milan criteria is the best criteria which gives a 75% 5-year survival. And as we expand the criteria beyond Milan criteria, as the tumor number or tumor size increase, the 5-year survival decreases simultaneously. So can we actually, if we get a patient who is presenting beyond Milan criteria, but still we want to give him the best survival of 5 years, 75% 5-year survival, the best way would be if we are able to successfully downstage this tumor to within Milan criteria. So which patient should we downstage? So in our 2023 guidelines on HCC, we had mentioned that patient who present with Milan criteria or UCSF criteria, these can be taken up for upfront liver transplantation. But those patients who present beyond UCSF criteria, it would be better if we downstage these patients to meet the UCSF or Milan criteria before taking up for transplantation. So is there any upper limit of stage for downstaging? the usual UNOS criteria is that we should take up for downstaging only those tumors which are less than 8 centimeter, and a certain number of the tumors are there. But no vascular invasion on imaging. But these criteria are restrictive and applicable more for DDLT setting. In India and various countries now, we have seen that even those patients who have already having portal vein tumor thrombosis, this is a study from Dr. Soin's group. Even these patients, after successful downstaging protocol, are having good survival outcome, good overall survival as well as recurrence-free survival. So the pragmatic downstaging protocol would be to, for all comers who are beyond UCSF criteria but having no extrahepatic metastasis, we should offer them multimodality treatment in form of loco-regional therapy, Y90, SBRT, any of these depending on their stage. And also add systemic therapy to this, and then see, assess. Many of these patients would be successfully downstaging with this multimodality treatment, and now they are meeting UCSF criteria with acceptable level of tumor markers. Then also we immediately should not subject them for liver transplantation. We should give them a 3-month mandatory period, waiting period, to assess their tumor biology. If even in that 3 months they remain downstage, we should offer them LDLT. But if with multimodality treatment they are not successfully downstage, that means these patients are having a poor tumor biology, and these patients will continue with multimodality treatment. And also, even in the 3-month mandatory waiting period, if many of these patients do progress, then obviously these are not good candidates for LDLT, and continue with the multimodality treatment. A brief about conversion therapy. Now, many trials are coming on where unresectable HCC, if we combine multimodality treatment in form of TACE, SBRT, immunotherapy, it can become resectable. So recently the StarFit trial was there, where initially they had 68 patients which were unresectable, but with this multimodality treatment, up to half of them became resectable and with very good survival. So all stages of hepatocellular carcinoma can benefit from combination of multimodality treatment, loco-regional therapy, systemic therapy, even early stage tumor, intermediate stage tumor, or advanced stage tumor. There are many newer drugs which are coming. In our 2023 guidelines, we told that first-line therapy would be atezolizumab, lenvatinib, sorafenib, and then 2 more treatment options had come. But in next 2 to 3 years, we are going to have at least 10 more options for first-line systemic therapy, which will soon come. A brief about precision or personalized medicine. This depends on the tumor microenvironment. So tumor or cancer is not just a collection of malignant cells. It has got a lot of microenvironment in which it lives and thrives. And this tumor microenvironment contains a lot of stromal cells, immune cells, which actually feed these tumor cells and protect these tumor cells from immune damage. And this tumor microenvironment leads to 3 types of tumor: hot tumor, which has got lots of inflammatory cells; cold tumors, which has got less of inflammatory cells or excluded cells. So in next 3 to 5 years, we will see more and more biopsies being done, which will determine whether the tumor is hot tumor or inflamed tumors, which will benefit more from immunotherapy, and cold tumors or non-inflamed tumors where immunotherapy will not be so much effective, and these will benefit from more surgical or loco-regional therapy. So lots of personalized treatment will be coming in next 5 years. So HCC treatment approach is now evolving at a very rapid pace. Liquid biopsy will be the future of early diagnosis and surveillance and treatment monitoring. Adjuvant and neoadjuvant systemic therapy will be given to most patients in future, most patients receiving surgery and loco-regional therapy. And more patients will receive liver transplant after aggressive downstaging protocol, and personalized treatment option depending on tumor microenvironment is also on the horizon. Thank you for your patient hearing.
So, very nice and elaborated and very well covered. So, I think now message is that every patient of SCC should receive adjuvant or lenvatinib start at the diagnosis.
So this
Whether
randomized
it is for the diagnostic or for the progression till that exact ablative therapy or transplantation is waiting.
So once the patient presents with early stage disease, when we are doing the resection or ablation, the recent study 050 trial, that showed that the patient who have high risk feature, and if we give immune checkpoint inhibitors after resection, these patients would benefit and have better recurrence-free survival. But this is one trial, which is randomized controlled trial. Many more trials are still ongoing. So in next few years, we will see this in guidelines. Right now, it cannot be recommended as such. But what I am presenting is what we are seeing in future within next 3 to 5 years.
Thank you, sir. As we are running late, we would move on to the next session now. The next session, please come to the center of the stage for the photograph, chairpersons and speaker. The next session is a symposium. Topic is endoscopic management of GI cancers, do's and don'ts. I'd like to invite the chairpersons for this session. Dr. Atul Kumar Agrawal, Consultant General GI and Laparoscopic Surgeon from Bhopal. Dr. Tarun Bharadwaj, Consultant Gastroenterologist, Apollo Sage Hospital, Bhopal. Dr. Amita Singh, Consultant Medical Dietitian, Bhopal. And Dr. Mayank P. Pateria, Consultant Gastroenterologist at Gastrocare Hospital, Bhopal.
So for the symposium, we would like to invite our speakers, Dr. Mohan Ramchandani, who would be discussing on throwing his light on the topic. We'll request Dr. Mohan to start his presentation.
Thank you, Tarun. At the outset, I thank again Dr. Sanjay Kumar for giving me this wonderful opportunity. Can I have my slides, please? Yeah, so I'm talking about endoscopic resections of GI tumor. Yesterday we learned about how to diagnose them, because unless we diagnose these GI cancers in early stage, our 5-year survival remains dismal. Cancer diagnosed in stomach, 5-year survival is still in India is 35%, and in esophagus it's 20%. How can we prevent this mortality? Only by early diagnosis. Up till now, we are diagnosing them in a symptomatic stage. By the time patient comes to us with dysphagia, the patient has already metastasized, and the lymph node metastasis is 30 to 40%. As the depth of cancer increases towards from the mucosa to the muscle layer, the lymph node starts getting the malignant cell, and most of the time this type of treatment will remain palliative. If you want a curative treatment, the cancer should be diagnosed early. And now we are able to do that by endoscopic method. Not only do that, but also treat them by many modalities, endoscopic resections like polypectomy, which was there since long. Endoscopic mucosal resection and ESD is now been more commonly performed. Endoscopic mucosal resection is the resection of the mucosa by many methods. One of the method is snare method, where we do a tumor identification is the most important, which is done by endoscopic method by using image enhanced endoscopy. And once the tumor is identified and the layer of origin is determined, that looking by the look of these narrowband imaging or white light endoscopy, if the tumor is limited to the mucosa or submucosa, we mark this lesion. And if the lesion is less than 2 centimeter, we can do a band EMR. You can see here we are applying a band, and once the band is applied, we can cut this tumor from the base using a very simple technique. This is known as band EMR, when you can do a cut of the base of the tumor by sucking it in a barrel of a variceal band, and then you can cut it. So this is known as band EMR. Similarly, you can do this tumor removal by cap EMR, which I will not discuss because of the short of time. You can see the complete tumor can be removed using this type of band or cap EMR. If you have a laterally spreading tumor, you can again do a band resections, a snare resection. You can see a very large tumor, but this tumor is type 2A variety, Genet type 2A, which is not very submucosally invasive. And if you have a good imaging or endoscopic assessment that this is not a submucosally invasive tumor, you can do a injection, elevation of this tumor and keep on cutting from one end to other till you completely resect this tumor. So this is known as EMR, but piecemeal EMR, where if your endoscopic assessment is very important, because if your endoscopic assessment says that it is a superficially invasive cancer, you can remove by an EMR like this, because this type of treatment is very quick. You can do it in 10 to 15 minutes, 20 minutes, and completely remove this tumor by doing this type of EMR. So this is a modality which is quick, but endoscopic resection should only be confined to those where you have a very good assessment saying that you have a superficially invasive cancer, and pathologists do not have an access to the margins because they will never be able to say, because you have done at a piecemeal EMR. Now we are also doing cold polypectomies, because if these patients are treated by the polyps, which are early cancers, are treated by hot polypectomy, there is a post polypectomy syndrome, like there can be a delayed bleed, but now the dictum is to do this type of cold polypectomy without using cautery, just cutting them for any polyps which are less than 1 centimeter or 10 millimeters. So this is the new modality which prevents delayed bleeding and post polypectomy syndromes like perforations. So this is the new standard of care in a polyp which are less than 10 millimeters. ESD is another method where we can remove this polyp in toto. That means which is much better than the EMR which I discussed, where we are doing piecemeal resection. Once we are doing piecemeal resection, we are not giving pathologists opportunity to tell us about the margins. But if you diagnose these cancers like this in early stage, and you can do endoscopic submucosal dissection by marking this tumor by the cautery, and subsequently using special knives and elevations and doing a submucosal dissection. Once you do submucosal dissection, you can completely remove this tumor. This is just opposite of EMR, where we are taking care of margins and removing the full tumor by using many traction methods. Yesterday we saw how we use the traction method to completely remove these early gastric cancer or early duodenal cancer, and you can see whole tumor is completely removed. And once you remove them, you are not still done. You must subject this tumor completely to the pathologist. Pathologist will have a full sectioning, and they will tell us about the tumor, like this cancer which is limited to mucosa, and there is no this is the muscularis mucosa, and you can see the cancer has yet not crossed the muscularis mucosa. So this is a curative resection, where the T1A tumor which was diagnosed in an asymptomatic patient, and complete cure was achieved by doing endoscopic resection. We are also now treating cancers arising from subepithelial lesions, like a leiomyoma in the esophagus. You can see there is a big leiomyoma in the esophagus, and you can do a tunneling, creating a mucosal incision, and just going towards that underneath the mucosa. You can see there is a tumor. You have to create a mucosal incision, then submucosal dissection, and subsequently you can go inside the tunnel and completely remove these tumors by a procedure known as STER, submucosal tunneling and endoscopic resection. So this is how the tumor is removed, and complete excision is achieved without disturbing the mucosa and the muscle, and the mucosal entry side is closed, and whole tumor is subjected to the histopathological assessment to tell us about the margins. I'll not go into this detail because of the lack of time, but we can do a full thickness resections from the gastric gist also by removing these tumors in toto with the muscle. But as we saw yesterday in the live demonstration, once we remove complete tumor, we endoscopically clip the muscle defect and completely take care of the defect which was there. You can see the tumor is completely removed from the site which is not accessible for stir, and a full thickness resection along the muscle is done and complete cure can be achieved. Rectal NETs also can be removed by many other methods. This is one of the device assisted method where a device is attached with a full thickness closure clips, that is known as OTSC clips, and this tumor is sucked into the barrel, clip is applied and tumor is cut. So this is good for less than 2 centimeter tumors, which is now up till now were surgically treated, now can be treated by full thickness resection. So in the end I'll say that EMR, ESD and third space endoscopy, which have changed the paradigm, it requires some special training, but once it is achieved, the learning curve is not long, and tumor can be removed in toto. The primary thing is one should diagnose these cancer early stage, so that if they are limited to mucosa and the submucosa, and the tumors even arising in the submucosa or even from the muscle layer can now be removed. If you want to learn more, you can join us for these two major conferences which is happening in AIG, where faculty from all over the world, that leading faculty will be coming, and you are most welcome to join us. Thank you very much.
Thanks, Mohan sir. Please have a seat. Thank you for emphasizing that early diagnosis of cancers remain important, and also sharing the modalities by which resection can be achieved. In the interest of time, I would like to invite our next speaker, Dr. Manish Jain, who would be sharing his ideas on stenting in GI cancers. Please have a seat. I invite Dr. Manish Jain, please.
Just wanted someone to help me in my slides. Thank you, Sanjay, for a wonderful conference, and thanks for invite. My topic of interaction today is stenting in GI cancer. Stents are basically medical device which can be used to restore the lumen of vessels, duct and hollow organ like esophagus, colon and bronchus. In gastrointestinal cancers, stents can be used in esophageal obstruction, biliary obstruction, duodenal obstruction or colonic obstruction. Stents can be divided into two categories, biliary and antral. Antral again they can be used in esophageal, gastroduodenal or colonic malignancies. Again, stents can be made of plastic or can be metallic or can be made of biodegradable material. Plastic stents again can be simple plastic or they can be self-expanding self-expandable plastic stents. Similarly, metallic stents can be uncovered, partially covered or fully covered. Simple plastic stents are made of Teflon or polyurethane. Self-expandable plastic stents made of polyester skeleton, woven and completely covered with silicone. Self-expandable metallic stents are made of stainless steel or alloy like alloy and nitinol. These are very tough material used for spacecrafts, has got excellent radial force and excellent capacity to expand at body temperature. Biodegradable stents are made of woven surgical suture material like polydioxanone. So there are different generation of esophageal stents you must have used. Initially, plastic stents, they had very difficulty in placement. high complication rate, and subsequently we have now current generation of stent which are made of basically nickel and titanium, nitinol. They've got a shaft and a flare ends. Esophageal stent, the shaft diameter is about 2 centimeter. Flare end, they are basically slightly expanded to prevent migration. Length of stent can be variable depending upon size of tumor. So for patient who has got esophageal malignancy, the indication can be either a patient who has got inoperable cancer leading to dysphagia, whether it is esophageal or extraesophageal, or in patient who has got malignant esophagotracheal fistula. It is important to select a stent which is 4 centimeter larger than size of lesion. For a patient who has got tumor involving G junction, the stent size should be 6 centimeter longer. 4 centimeter of stent should be proximal and 2 centimeter distal, hanging into stomach. For tumor within 2 centimeter of cricopharynx, low flange stent can be used, but as the stent expand, the patient can have one body sensation and respiratory distress and pain. Therefore, it is better to advise radiotherapy or chemotherapy to these patients. There are certain steps and tips for successful stent placement. You must confirm indication, go for histopathological confirmation, because once you deploy a stent, it's very tough to take biopsy. Often obtain a good roadmap of lesion by performing a X-ray contrast study if possible to assess the length, tightness and angulation of stricture. Select appropriate scope. Suture dilatation is required if pediatric scope is not negotiable across the stent. Proximal and distal end of stents and stricture need to be marked appropriately for proper stent placement, and carefully read about stent and delivery device details beforehand. This slide shows different steps in deployment of placement of esophageal stent. This is how stent looks like when fully deployed endoscopically. All procedures, they have got their own complications. Similarly, stent has got its own complication. There are early complications within 4 weeks or delayed complication after 4 weeks. Early complications are chest pain, fever, bleeding, reflux and global sensation. Some patient can have perforation and stent migration. Late complications are tumor ingrowth, stent migration, development of esophageal fistula, especially at upper and lower end of stent, and there is recurrence of stricture, which is always a feared complication. As we discussed today morning, in patients who present to us with colonic malignancy in obstruction, all patients who have got a metastatic colonic cancer, stents can be placed as palliative care if they come to us with obstruction. And a patient who have got operable malignancy, especially left-sided, they present to us with colonic obstruction, you can place stent, because there is a wonderful study published in World Journal of Surgery in 1999, which has shown that it allows excellent decompression of colon. Bowel preparation can be achieved prior to surgery, and colonoscopy can be done to look for a synchronous lesion, and therefore, rather than going for a 2-stage surgical procedure, we can convert into a single stage or even laparoscopic surgical procedures. In patients who have got lower rectal cancers, stents are poorly tolerated, so better to avoid. This is how endoscopically the stent placement looks like. Oh, sorry. This is again basically a patient who presented to us with acute colonic obstruction secondary to operable malignancy. The stent was placed, and within 15 days the surgery was performed. This is resected specimen showing stent as well as tumor. It is important to remember that colonic malignancy, if you place stent, the complication rate are higher than that of esophageal malignancy. Complication rates are 7 to 17%, and technical failure are more high if the stent size is, if the stricture is longer than 4 centimeter. Major adverse event which can happen is colonic perforation. So these patients are already very sick and morbid, so this can be a fatal event in these patients. In patient who has got gastroduodenal malignancy, there can be different mode of palliation. In advanced malignancy, it can be duodenal stenting, it can be surgical gastrojejunostomy, or it can be endoscopic ultrasound guided gastroenterostomy. This is putting a duodenal stent is the simplest procedure which you can perform. You have to simply put a stent. Every gastroenterologist is expert in putting duodenal stent. Simple procedure, hardly any complication. So all patients who have got expected survival of approximately 6 months, you can go for simple duodenal stenting. There are tips for successful stent placement, and overall technical success of gastroduodenal stent placement is about 95%. And there are different studies in the literature. There are plenty of studies which have compared gastrojejunostomy and duodenal stent placement. Just give me 2 minutes. This is upcoming modality for palliation in patients who have got gastroduodenal obstruction. You can place endoscopic ultrasound guided stent, and there are basically this study which was recently published in a multicentric trial has shown excellent potential of this modality for palliation. In patients who have got malignant biliary obstruction because of variety of reasons, you can place stent, but important point I want to highlight here before placing any stent in patients who have got biliary malignancy is surgery with R0 resection is only hope for cure. So don't rush for ERCP in stenting in these patients. After a sonography, cross-sectional imaging is first line workup. So high quality, preferably triple phase CT with or without MRI, or if the patient can't afford, patient has got a hilar lesion, only MRI should be next imaging after USG prior to EUS or ERCP. And try to establish histopathological diagnosis prior to ERCP or drainage by doing some percutaneous procedure or by doing endoscopy and biopsy. In patients who have got biliary obstruction, which stent to choose, plastic or metallic? Obviously, the metallic is first choice because of better drainage, less re-intervention. But plastic stents can be used in common bile duct and lesion up to common hepatic duct when the cost is major consideration and histopathological diagnosis is uncertain. This is Bismuth classification, which is used for basically finding operability and the level of obstruction in patient with cholangiocarcinoma, but same can be applied to find out site of lesion or depending upon or selecting type of stent in patient who have got CAGB. In patient who have got cholangiocarcinoma, tissue is the issue. In majority of patients who have got malignant obstructive jaundice, tissue is the issue. Cytology and biopsy alone has got sensitivity and specificity of about 45 to 48%, and combination you can pick up diagnosis in about 60%. 20% of biliary strictures are indeterminate, and hence detailed workup like USFNA in case if there is distal lesion or fish or cholangioscopy might be needed. About 15 to 20% of patients who are operated for suspected malignant stricture turn out to be benign, as covered stent once deployed cannot be removed without surgery. Prior tissue diagnosis is of paramount importance. This slide we have already discussed in morning, stent in operable biliary malignancy. So I summarize by saying that stents have certainly revolutionized the endoscopic management of malignant GI obstruction. Careful assessment of indications, contraindications, stent and delivery device details prior to every procedure is key to successful stent placement, and I thank you for kind and patient listening. Thanks a lot.
Thanks, Dr. Manish. Please have a seat. I invite next speaker, Dr. Ashmit Chaudhary, who would be sharing his ideas on nutrition in GI cancers.
At the outset, I'd like to thank Dr. Sanjay Kumar for giving me this opportunity. The topic for my lecture is endoscopic methods of nutrition. Most of the part has been covered by Dr. Manish Jain also, and it will be an overlap also. So, neoplastic diseases represent second leading cause of death worldwide, and number of cases are expected to rise. It has been estimated that 10 to 20% of patients of cancer die due to consequences of malnutrition rather than tumor. So we need to regularly evaluate their BMI, weight loss, weight changes, and change their nutrition according to that. Malnutrition leads to generalized weakening. It decreases the body's immune forces and affects prolonged recovery and leads to lower tolerance of side effects to cancer therapy. In the study group, in a study published by ESPN, the prevalence of malnutrition showed variation based on the location of tumor. Pancreas, it was 66%. Esophagus, because of swallowing difficulty, and also in stomach, it was 60%, and head and neck cancer, it was 48%. So what are the cancer-related, why is cancer-related malnutrition caused? It is because of inability to ingest food due to lumen obstruction that causes dysphagia and recurrent vomiting, the harmful effects of surgery and medical treatment that prevent adequate nutrition intake due to swallowing, severe mucositis, nausea and anorexia. Metabolic modifications induced by cancer itself also lead to malnutrition. What are the ESPN guidelines? The energy intake should be like a normal person, it should be 25 to 30%. Protein intake should be in a cancer patient should be 1 to 1.5 gram per day. Intake of vitamins and minerals should be normal. ESPN does not encourage, that is the European Society for Enteral and Parenteral Nutrition does not encourage the use of high dose micronutrients which are propagated by many pharmaceuticals. In cancer patients who suffer malnutrition without swallowing disorders, nutritional counseling, and we have to start them on oral intake, and oral nutrition supplements are recommended. Enteral nutrition through tube is recommended if the inability to eat for more than 7 days is anticipated, and dietary intake is below 60% of the estimated requirement for more than 10 days. Head and neck cancers, particularly pharyngeal, laryngeal, esophagogastric tumors, all neoplasias causing gastric outlet obstruction such as tumors of the pancreas, hepatobiliary are important causes of intolerance to oral intake. As gastroenterologists, we have a very specific role in increasing their nutrition. ESPN also recommends, if you have severe anorexia, ESPN recommends use of corticosteroids for 1 to 3 weeks. Progestins, that is medroxyprogesterone, can be used as a pharmaceutical agent, and it increases the appetite. In cancer patient whose nutrition status does not improve despite enteral nutrition is recommended, and sometimes even parenteral has to be given. 2 recent reviews demonstrate long chain fatty acids, improved appetite, body weight, post-surgical morbidity and quality of life in weight losing cancer patients, and long chain fatty acids in similar population during chemotherapy, and made mostly tolerable. Chemotherapy was tolerated properly if they were given these supplements. There are several reports of protective effects of fish oil on chemotherapy induced toxicities like peripheral neuropathy. So we have to be more aggressive in treating these patients also. There is insufficient data to recommend cannabinoid to improve the taste disorder or anorexia in cancer patients. Subsequently, it was demonstrated that there are some immune modulating drugs, and the term immune modulating nutrition or immunonutrition refers to liquid nutritional supplements enriched with specific nutrients like arginine, N-acetylcysteine, and fatty acids and nucleotides. This have been helpful in the body, and as per the chart, this has already been discussed. So how does the gastroenterologist come into picture? These are the endoscopic techniques for enteral nutrition, enteral access. The endoscopy guided nasoenteric tube, the percutaneous endoscopic gastrostomy, percutaneous endoscopic gastrostomy with tube extension, and direct percutaneous endoscopic gastrostomy, and ultimately the endoscopic ultrasound guided gastroenterostomy. The nasogastric tube we have been all using this for many years together. The provision of nutrition is most appropriate in patients whom length of stay of impaired oral intake is expected to be short, typically estimated to be less than 30 days. This is the simplest thing, and it involves the passage of gastroscope to the level of obstruction and subsequent passage through the lumen under direct visualization. In the over guide wire technique, the guide wire is passed through the endoscope and then exchanged out. The nasoenteric tube is then passed over the guide wire. Sometimes even the ultra slim gastroscope is used transnasally. Percutaneous endoscopic gastrostomy is has been become preferred means to establish long-term enteral access who are unable to meet their nutritional needs perorally. In a recent study involved multi-centric retrospective analysis of 904 patients with head and neck cancers who received prophylactic PEG tube placement versus no PEG tube. The study compared weight loss, treatment tolerance between the two groups and found overall difference between the two groups were not significant, and this study was published in 22, American Journal of Gastroenterology, 22. However, a subgroup in this study, a subgroup of patients with low BMI, they found that these patients were able to tolerate therapy better if there was a PEG tube placement. In another prospective study, 133 patients with non-invasive nasopharyngeal cancer who were treated with prophylactic PEG tube placement were found to have significant improvement in terms of completion of chemotherapy, less weight loss, and lower incidence of mucositis than those in non-PEG tube group. There is always a problem of cancer seeding, and a recent retrospective review concluded that the risk of cancer seeding with PEG tube placement was underestimated, and it can be up to 1 to 9%. Percutaneous endoscopic gastrostomy with jejunal extension is involves the use of a jejunal extension tube that passes coaxially through the lumen of the PEG tube and subsequently maneuvered its tip into the small bowel. The PEG-J has the advantage of providing access to both the gastric lumen and the small bowel lumen, such that the gastric port can be used for decompression and the jejunal port is used for feeding. The only problem is the small caliber of the tube leads to clogging, and other problem is it can coil back into the stomach. So for this, the main drawback of the PEG-J has been the coiling back. One interesting modification is the pediatric PEG tube in place of jejunal extension with internal bumper of the pediatric PEG tube acting as a sail. I'll take 2 more minutes. Okay. Guidelines from the American Society of Gastrointestinal Endoscopy and the European Society of Endoscopy support the use of PEG-J and PEG gastrostomy with jejunal extension tubes for long-term post-pyloric feeding as alternative to nasojejunal tubes or surgical gastrostomy. This is how a PEG jejunostomy tube looks like, but this is not available in our country at present. Esophageal stents are self-expanding and they are used for patients with esophageal cancer. This has already been covered by Dr. Manish Jain. The interesting thing is PEG versus esophageal SIMS. In retrospective study of 308 patients which was published in 2021 who underwent PEG tube placement versus SIMS placement for palliation of esophageal cancer, those in the PEG tube group were found to be better survival and less need of further intervention in comparison to SIMS. So, therefore, PEG tubes, even if they do not palliate dysphagia symptoms, it may be favorable alternative in comparison to SIMS placement in terms of maintaining nutrition and avoiding post-procedure complications in patients and should be thoroughly counseled before proceeding with either course of action. Duodenal stenting already covered by Dr. Manish Jain. The current guidelines suggest duodenal stenting for patients with a life expectancy of less than 6 months who desire resumption of oral intake with short length of stay in hospital. This is because duodenal stents have been shown to have a clogging, and initial deployment is easier, but the efficacy is inferior to surgical gastrostomy. Colonic stenting, one thing I'd like to point out, is the risk of perforation is most significant side effect, and it occurs more when it is deployed in the sigmoid colon, where the radial forces from the stent with an angulated redundant colonic mucosa increases the risk of colonic ischemia and thus colonic perforation. Ongoing treatment, patients who are ongoing on treatment with bevacizumab in particular have been associated with higher rates of colonic perforation after stenting. Endoscopic gastrostomy, okay. Jejunostomy has already been discussed, and I will not go into it. Only thing is, it is better. The recent people who underwent EUS guided gastroenterostomy, gastroscopic enterostomy, however, had significantly sooner resumption of chemotherapy and sooner resumption of oral intake. In addition to the adverse event were lower in endoscopic ultrasound guided procedure. In the summary, I would like to say endoscopic placements of nasogastric tube or nasoantral tube can be a simple solution of patients in whom the length of oral intake is less than 30 days. Longer duration of impairment should prompt consideration of alternatives, means, and self-expanding metal stents have been successfully used to restore patency of esophagus, duodenum, colon. Typically, stents are made for palliative relief of obstruction. Caution should be taken undergoing chemotherapy, especially in colon cancer patients. Thank you for your patient hearing.
Thank you very much, Dr. Sir, for your very detailed discussion on the various modalities to feed patients of gastrointestinal cancers. However, I would have been more interested in, as a nutritionist, I would have been very interested in how do we meet the nutritional requirements of the patients. The ESPEN guidelines are all fine. Having been in practice, there are innumerable challenges in meeting and feeding the patients and adequately convincing them on using the foods as per their requirement. But thank you, Dr. Sanjay, for putting this in the forum, and I hope in future maybe we can have a wider discussion on the whole spectrum of feeding in gastrointestinal cancers. Thank you for this.
Thank you all the speakers and the chairpersons for the interactive session. I will request you to join in the center of the stage for a photograph. I have an announcement to make. Due to some unforeseen circumstances, Dr. T.P. Sahu has to leave in a hurry. So we have cancelled the next session. And we will move into our final session of the conference. That is, Beware of Immune Checkpoint Inhibitor Toxicity in GI, Liver and Others by Dr. Aniket Goyanka. I will request the chairpersons to join us on the dais. Dr. R.S. Chachra, Senior Gastroenterologist in Bhopal. Dr. Shohini Sirkar, Senior Gastroenterologist, Choitram Hospitals, Indore. Dr. Vijay Bhargav, Consultant Medical Oncologist at JLN Cancer Hospital, Bhopal. And Dr. Arun Singh Bhadoria, Gastroenterologist at Medanta Hospital, Indore. Thank you.
At the outset, I would like to thank Dr. Sanjay Kumar for giving me the opportunity to be part of this academic feast. And with all feast, it ends on a sweet note. So I'd like to keep, I'll promise I'll keep it short and sweet. The topic is immune checkpoint inhibitor toxicity. What I'll discuss today is introduction to checkpoint inhibitors, mechanism of action, toxicity spectrum, kinetics of toxicity, mechanism of toxicity, the role of GI physicians, and the Indian data on it. Immune checkpoint inhibitors
are molecules that utilize the immune cells of the body to act on cancer. Cancer has developed checkpoints and brakes on this immune cell activity so as to prevent its action, while these checkpoint inhibitors remove this blockade on immunity. At present, there are more than 5,000 studies being conducted on immune checkpoint inhibitors alone or in combination. Initially, these molecules showed exceptional response in melanoma, but are now used in many more diseases. This is from 2019 data from United States. More than 40% of all cancer patients were eligible to receive immune checkpoint inhibitors. As with all drugs in malignancy, initially they are utilized in metastatic setting, and then if they are successful, they move on to adjuvant and neoadjuvant setting. And here we can see that immune checkpoint inhibitors have moved on to neoadjuvant settings as well. For the GI physician audience, we all know that in microsatellite inhibitor, high colon cancer, we are using neoadjuvant immunotherapy as well. If you look at the mechanism of action, the immune checkpoints are PD-L1, PD-1 interaction and the CTLA4 and B7-1 interaction. If you look at the PD-1 inhibitors, it is nivolumab, pembrolizumab, while if you look at the PD-L1 inhibitors, it is atezolizumab and evolumab, while CTLA4 inhibitors are ipilimumab and tremelimumab. These are the molecules which act on these immune checkpoint blockades. If you look at the spectrum of immune checkpoint inhibitor toxicity, it affects almost all organs, systems. It affects from the brain to the gut, from the muscles to the lungs. It affects endocrine system and musculoskeletal system, all alike. If you look at the mechanism of toxicity, immune checkpoint inhibitors increases T cell activity against antigens that are present in tumors as well as healthy tissues. This results in immune activity against normal organ systems. Especially, this is the reason why myocarditis happens. This is what we call the on-target effect of immune checkpoint inhibition. Immune checkpoint inhibition also results in increase in levels of pre-existing antibodies, which causes the thyroiditis which is seen in checkpoint inhibitor toxicity. Activated T cells and cytokines lead to inflammatory bowel disease, and CTLA4 antibodies present on pituitary and can lead to pituitary dysfunction and hypophosphatitis. So if we look at the kinetics of toxicity, the time of onset of toxicity is usually predetermined. This is with PD-1 inhibitors, skin and gut toxicity is seen in 3rd or 4th week. Hepatic and endocrine toxicity is seen typically in 6th to 7th week, while neurological toxicity is seen in 7th to 8th, lung in 9th to 10th, and at the end, renal toxicities with 14th to 15th week of starting therapy. If you look at the resolution kinetics of toxicity, we see that the GI toxicities are resolved within a week or two, and that's why probably if the GI toxicity is not resolved within a week, we prefer aggressive management of GI toxicities. Here we can also see hepatic toxicity gets resolved within 3 weeks, while skin toxicity can persist for a median of 18 weeks as well. Now the toxicity profile of each drug is different, and immune checkpoint inhibitors is just a broad term. So if we look at the toxicity profile of ipilimumab, we see a lot of gastrointestinal and renal toxicity, while for atezolizumab it is more hypothyroidism, and with nivolumab we have more endocrine toxicities. If you look at the relationship of severity and incidence of toxicity, myocarditis and neurologic toxicity with encephalitis are usually fatal and life-threatening, but also less in incidence, while hepatitis, colitis, and pneumonitis are lie somewhere in the mid-range in incidence, while rash and arthralgia are high in incidence but less in fatality. So if we look at the spectrum of only fatal toxicities, colitis, pneumonitis, and hepatitis are the most important toxicities seen, especially with CTLA4 antibodies, that is ipilimumab and tremelimumab. Colitis can be as high as 70%, leading to all fatal toxicities. While if we are using combinations of PD-1 inhibitors, it contributes 37%, and hepatitis a good 22%. So if we look at the principles of immune checkpoint inhibitor toxicity management, these 5 sub-steps are important: prevention, anticipation, detection, treatment, and monitoring. What we mean by prevention is to know the immunity toxicity spectrum, is to identify these and to manage patients and to make the patients and healthcare provider aware about it. If you look at the anticipation, we need to ensure that blood tests are done routinely, detection based on symptoms and signs, treatment on the basis of the severity with immunosuppression, and most importantly, involvement of organ specialists, and ensuring that the resolution of symptom follows the typical resolution kinetics. It is seen that patients who have a history of autoimmune disorders have a higher risk of developing toxicity. Comorbidities should be mentioned as they can lead to organ compromise. In anticipation of toxicity, we need to ensure that baseline blood tests are done, and some blood tests are routinely done after every cycle. For detection, we need to be aware about the signs and symptoms of fatigue, rash, diarrhea, hepatic dysfunction, hypothyroidism, pneumonitis. And for treatment, we need to be, as a rule of thumb, this is grade 1, grade 2, grade 3, grade 4. Grade 1 needs symptomatic management. Grade 2, we need to stop the drug and start oral steroids. Grade 3, severe, it should involve a specialist, the organ system specialist, and grade 3 and 4 needs to be treated aggressively. Here, I would like to point out that teamwork is of essence, with organ specialists to be involved in management of checkpoint inhibitor toxicity. So why GI physicians are important in management of immune checkpoint inhibitor toxicity? Gut is a lymphocyte-rich area, hence higher incidence of gut involvement with immune checkpoint inhibitor toxicity. There are no phase 3 data on randomized data on management of toxicity of immune checkpoint inhibitor. All the learning of management of immune checkpoint inhibitor is based on IBD management. Earlier toxicity is seen in gut and skin. Life-threatening toxicities are colitis, pneumonitis, and hepatitis, while latent viral hepatitis B activation can also complicate management of immune checkpoint inhibitors. So I am speaking to an audience of gastrophysicians, so I would spend a little less time in management. But a rule of thumb, grade 1 to be treated with symptomatic management. Grade 2, we need to withhold the drug, treat with oral steroids. Grade 3 and 4, IV steroids and infliximab in cases of diarrhea. An important point to be noted is that not all diarrhea is colitis, and not all colitis will present with diarrhea. Colitis is defined on the basis of colonoscopy. It is defined on the basis of imaging. It is defined on the basis of stool calprotectin levels. Hepatitis management, again similar, with grade 1 being managed symptomatically, grade 2, grade 3, and then grade 4 involving other immunosuppressants as well, with mycophenolate mofetil. So is toxicity always a bad thing? Here, if we see the Kaplan-Meier curves of survival, the blue curve represents the patients who developed 2 toxicities, while the yellow curve represents patients who developed at least 1 toxicity, and the purple curve represents the patients who did not develop toxicity. And here we can see that the patients who developed toxicity had better survival. Not all toxicities are associated with better prognosis. Pulmonary toxicity is associated with poor prognosis. So if a patient develops grade 1, grade 2 toxicity with checkpoint inhibition, we can be happy if we are able to manage them properly. We use steroids to treat immune checkpoint inhibitor toxicity, and since steroid causes immunosuppression, there is a thought that providing immunosuppression to a patient who is on checkpoint inhibitor, would that lead to inferior survival? But that is not the case, as we can see here that the Kaplan-Meier curves are coinciding with each other, whether they have received systemic steroids or not. We have commonly seen that PPIs are prescribed in almost all prescriptions, and this is an important aspect that there are studies which have shown that PPI use results in less survival and is associated with poorer survival as compared to those patients who are not exposed to proton pump inhibitors. So proton pump inhibitors should not be routinely prescribed. Some important aspects about immune checkpoint inhibitors is that live vaccinations need to be avoided. We can do killed vaccinations. Breastfeeding to be avoided for at least 5 months after the last dose of immune checkpoint inhibitors. Contraceptives are to be used for at least 5 months of the last dose of immune checkpoint inhibitors. And we need to keep in mind about autoimmune conditions of the patient, drug interactions, and infectious disease screening. At the end, I would like to present some Indian data. This is from Tata Memorial Hospital by Dr. Vanita Norona et al. She presented a data of 155 patients. In her case series, it was there were the incidence of immune-related adverse events was less than 10%. And this is the data that we presented at IOC-CON. And here, in our data of 86 patients, the total toxicity was around 14%. So checkpoint inhibitors are not associated with very severe toxicities, but it can be fatal. So a few take-home points. We need to prevent checkpoint inhibitor toxicity. We need to screen for autoimmune diseases, know about comorbidities, and avoid routine use of proton pump inhibitors. We need to anticipate with regular testing of T3, T4, TSH, and other battery of tests. We need to detect, keep our antennas up for signs and symptoms. An important aspect is colitis is not diarrhea. It needs to be identified on the basis of symptoms and colonoscopy or imaging. Steroid use does not affect the efficacy of these molecules, so it can be used liberally. Interdisciplinary management is something of paramount importance in management of checkpoint inhibitor toxicity. And another important point, patients who develop toxicity do better. Thank you.
Thank you very much, Dr. Goenka, for your nice presentation. I just want to wish everybody WHO Day.
Thanks, Aniket, for presentation. And you have covered almost everything about immunotherapy uses and side effect in a very simple way and very informative. Now I will not like to delay the session more. Thanks.
Thank you. Thank you, sir.
Thank you, Aniket. Thank you, all the chairpersons. You can come in the center for a photograph. So, this is the concluding session of the academics. Now we have a brief valedictory function in which we will be announcing the prizes also. So please stay with us for another 5 to 10 minutes. I invite Dr. Naveen for the valedictory.
Good afternoon to all. We are coming to the end of our conference session. In the beginning, I would like to first announce the prizes for the poster presentation. I request Dr. S.P. Mishra sir to please come on the dais and hand over the prizes. We'll begin with the third prize, that is Dr. Shreyansh Thalera. He's from Choitram. Okay. Second prize goes to Dr. Priyank Shah from Choitram, Indore. There.
Nobody there?
Nobody is there.
So the cash will be forfeited.
And the first prize goes to Dr. Mustafa Malviya from Choitram.
Mustafa?
Thank you, sir. The next winners for the video digest, I would like to call upon Dr. Sanjay sir to distribute the prizes on the dais, please. The second prize goes to Dr. Sunil Kasturi, Fortis Hospital, Bangalore. And the first prize goes to Dr. Pankaj Gupta from Max, Delhi. So we are coming to the end of our conference. So I would like to thank the people who are participated in our conference. So to begin with, I would like to thank all the faculties who had come all over from the different parts of the nation and also from the state, who has participated in both the workshop and the 2 days of our conference, who has shared their knowledge and updated us with their knowledge. Thanks, sir. And I would like to thank all the delegates who had come all the way and interacted in the different sessions. I would like to thank our patron, Dr. C.C. Chaubal sir, who has guided throughout the preparation of this conference. I would like to thank a special thank to our Director, Gastrocare Hospital, Dr. Neetu ma'am, for indirectly involving in most of our preparations. And I could say this time, for the first time, Madam is directly involved also, both in the workshop and in the lecture also. Thank you, ma'am. And I would like to thank our chairperson, our medical superintendent, director, and organizing person, Dr. Sanjay Kumar sir, for encouraging and involved in directly, indirectly, and throughout, whether it is here or from the Japan, continuously, Bhopal and Bhopal Surgeon Club for participation in our conference. And I would like to thank my colleagues for involving all the workshop and the cases and in building this program of the 2 days conference. I thank all the pharma people who are involved in our conference from the beginning, who had worked all these 2 days and made it a good, grand success. I thank the press people who had attended here, who had coverage, who had given us the encouragement. Thank you. And I lastly thank all of our Gastrocare team who are involved in day-to-day and from the beginning till now in this each part of the program. Thanks, Gastrocare team.
He has been with me in the entire preparations, and he has been really has been a great help. His nature is that he's a bit critic, so that has actually helped me to uplift the nature of the program. So sincere thanks to him, and my entire team, especially the admin team, Mr. Dwivedi, Reena, Naren, and number of them, I cannot name all of them. So they have been with me in organizing this event, and I'm really thankful that they work hard, and that's how we could reach here. Special thanks, he has already mentioned about Chaubal sir. I request Mayank, Kamlesh, please come here for a photograph. Chaubal sir. Entire organizing team, I would request everyone to come here for a photograph. Kshitij is coming. Dr. Neetu, Kshitij. Let the organizing team photograph you first, then I'll request all of you also to come. So whoever is here, we can have a photograph. All those who have spent 1.5 days with us, I request for a photograph with them also.